Shall I start? Good morning, everyone. Now we are starting with the program for today. I would like to request all the esteemed guests to please come on dais. We have Dr. W. Silvamurthy, sir. Dr. Deepak K. Behra, sir, who will be joining us online. Professor Sanjay Juvekar, sir, and Subbu Roy, sir. And PC Joshi, sir, is on the way. So once he's there, we'll have him also with us. It's my pleasure to welcome all the past participants and esteemed guests today for the Pre-World Congress International Seminar on Anthropology, Health and Disease, Eliminating Disparities. Good morning, everyone. I would like to request Professor Ruby Day for the welcome address. Over to you.
Good morning, everyone. Greetings and welcome everyone to our very nice environment and beautiful, you can say the beautiful campus of Amity University. So I welcome each one of you who is here. So I'm extremely overwhelmed to get this opportunity to address this August gathering for in one of the most auspicious occasion of the much awaited pre-World Congress International Seminar on Anthropology, Health and Diseases, Eliminating Disparities. So with the blessings and motivation, vision and encouragement of our Honorable Founder President, sir, support, guidance and blessings of our Honorable Chancellor, sir, Honorable Vice Chancellor, Madam, and the constant support of our respected Dr. W. Silvamurthy, sir, Dr. Neda Sharma, sir, and the entire fraternity of Amity University, I welcome each one of you to this esteemed and prestigious Congress, pre-Congress in international seminar. I thank and welcome all the distinguished dignitaries on the dais and off the dais, Professor P.C. Joshi, who is on the way, Professor Deepak Behra, Dr. W. Silvamurthy, Professor Shalina Mehta, who will be joining us in the afternoon, Professor N.K. Arora, who will be joining us soon, Professor Sanjay Juvekar, who is here, who came all the way from Pune. Thank you, sir, for joining us. Professor Kustub Dalal, he is come from Sweden. So thank you so much, sir. Professor Shubho Roy, a very good friend. I welcome you, sir. Professor K.N. Saraswati, who is on her way, maybe she's a very good friend of mine again. I welcome all the invited speakers, colleagues, and participants for your esteemed presence in the event. So this is a very long-awaited event. The planning started in 2021, July, when the United India Anthropology Forum was formed. And then there was a suggestion from my senior respected teachers, many of them would be joining us today, that we should organize something in Amity University, Uttar Pradesh. And I had the privilege and got the permission from our Honorable Vice Chancellor, ma'am, who very easily allowed me to organize this event. And I'm thankful to our founder, sir, our Chancellor Sir, our Vice Chancellor Madam, and everyone in the Amity University who has given us this opportunity to organize this seminar. So before I go ahead with the seminar, everybody would be hearing about the seminar talks, and they will get a good idea of what is happening and what are the health disparities which is happening in India and around the world. But I would like to tell our journey of Amity anthropology in Amity University. The journeys began in 2009 when our visionary founder president sir wanted anthropology to begin in Amity University. So it was a long planning, like from 2004 onwards we were planning to start the institute, and finally it worked out in 2009 with just 2 students in anthropology. And I'm so happy, students. Like today I have more than around 70 students in the department, which gives us a lot of pleasure. And this all happened because of the great support of the university management, our top management, and of course my colleagues in the department who have helped me to build this institute. And we have reached to this level where we are doing a lot of research, a lot of things which have been done in the last 12 years. So since the inception of the program at Amity University, we have been actively engaged in numerous research endeavors, which encompasses population studies, social issues, community health, human genetics, and developmental studies. These initiatives are like these topics such as we worked in the congenital birth defects, prevalence of communicable diseases like HIV, and then obesity, cardiovascular diseases, thrombosis, lung cancer, ovarian cancer, and currently we are working in thalassemia. So, and even in lung cancer, there are 2 projects from ICMR which is ongoing in AIA, that is in anthropology, that is on thalassemia and lung cancer. So many of our researches we have conducted in the remote areas of Northeast India among the indigenous communities of Northeast India. So I take immense pride and joy in acknowledging the remarkable achievements of my colleagues in the institute at Amity University for the significant contribution to the advancement of the discipline anthropology. I'm very proud of you, my colleagues. So over the years, our center has evolved, adapted, and grown, keeping pace with the ever-changing dynamics of the society and academia. It emerged as a good institution for anthropological research, education, and community engagement, not only within our university, but also on a national and global scale, as many of our alumni are placed in reputed international organizations and universities. So many of our students are employed in UNICEF and other international organizations, and they are also in reputed universities like London School of Economics, SOAS, Queen's University, and many more. So, like even in India, there are premier institutes in India, and one of our students is here who is currently doing his PhD from IIT Delhi. This international seminar comes at a crucial time in our global history, where the intersection of anthropology, health, and disease has never been more relevant. Our world is grappling with the numerous challenges, and the COVID-19 pandemic has exposed the disparities and inequalities that persist in the healthcare system and society at large. It has reinforced the importance of understanding how cultural context, societal norms, and historical experiences shape the health outcomes. My aspiration is that this seminar will leave us feeling inspired and motivated to create a positive influence in the field of anthropology. The gathering of diverse perspectives and cultural exchange from participants can nurture novel ideas and innovative approaches which hold the potential to reshape the world, particularly in the realm of health. I wish to express my sincere gratitude and thanks to Amity University, Uttar Pradesh, for providing us with the this platform for this captivating international seminar. I extend my sincere thanks and gratitude to the sponsors. We are very grateful to DST SERB, ICSSR NRC, CSIR, Anthropological Survey of India, and DRDO, as well as our private sponsors for their valuable contribution that have played a significant role in making this event a resounding success. I am thankful to all my colleagues, my dynamic organizing team. I'm very proud of you, my support staff, my students, my students who have worked untiringly. I'm so grateful and thankful to you and love you all. So for their constant support and hard work to make this event possible. The once again, so with this, I think I should end here. Once again, a welcome to all the dignitaries on the dais and off the dais. May this seminar be a remarkable journey of exploration and discovery. Let us strive to build a healthier and more equitable world. Thank you so much. Namaskar. Over to you.
Thank you, ma'am. Ma'am is head center of anthropology, Amity University, Noida campus. She has done PhD from Department of Anthropology, University of Delhi. Professor They have completed 6 projects and 2 ongoing projects from major institutions like ICCMR, ICCSR, Ministry of Health and Family Welfare, Intel Technology Private Limited, CSR and Department of Biotechnology, Government of India. She has published more than 60 research papers in reputed international and national journals over 27 years of her research experience. Her specialization ranges from biosocial anthropology, women studies, adolescent studies, demography, maternal and child health, reproductive health, public health, and population genetics. She is a peer reviewer of various international and national journals. Professor Day has organized numerous national conferences, seminar, workshop, and professional development programs as a convener and organizing secretary. She has also been felicitated as distinguished anthropology by Department of Anthropology, University of Delhi on International Conference on of Pre-World Anthropology Congress. Now, I would like to request all our esteemed guests for the Saraswati Vandana and lamp lighting.
Lamp lighting.
Vandana is a Sanskrit word meaning wisdom, and Saraswati is known as the mother of Vedas and the champion of knowledge, wisdom, and arts. Chanting the Saraswati Vandana mantra is believed to remove all the obstacles to success in one education and career. Third year students of MSc Honors Anthropology will come forward for the Saraswati Vandana.
देवस्य धीमहि धियो यो न प्रचोदयात् ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यम् भर्गो देवस्य धीमहि धियो यो न प्रचोदयात् ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो न प्रचोदयात् ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो न प्रचोदयात् ॐ स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो न प्रचोदयात्
वरदे वरदे वीणा वादनी वरदे 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 वीणा वादिनी वरदे प्रिय स्वतंत्र नव अमृत मंत्र नव प्रिय स्वतंत्र नव अमृत मंत्र नव भारत में भर दे भर दे भर दे वीणा वादिनी वरदे 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 वीणा वादिनी वरदे काटे अंध उड़े के बंधन स्तर काटे अंध उड़े के बंधन स्तर वह जननी ज्योतिर्मय निर्झर काटे अंध उड़े के बंधन स्तर वह जननी ज्योतिर्मय निर्झर कलुष भेद तमा हरि प्रकाश भर जगमग जग कर दे भर दे भर दे वीणा वादिनी वरदे 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 वीणा वादिनी वरदे वीणा वादिनी वरदे Thank you. Now, I would like to request Professor Rumi ma'am to please felicitate our guest for today with the Tulsi sampling. Professor Dr. W. Silvamurthy, sir. Professor P.C. Joshi, sir. So this is for you. Professor Sanjay Jivekar, sir. Professor Subbo Roy, sir.
Thank you so much. Thank you.
Now, Dr. W. Silvamurthy, sir, is currently working with Amity University as President of Amity Science, Technology and Innovation Foundation and also serve as Director General for Amity Directorate of Science and Innovation and Chancellor of Amity University, Chhattisgarh. Dr. Silvamurthy did his doctorate Faculty of Medical Science from Delhi University and Doctor of Science from Bangalore. He was also awarded at DSE for 5 universities in recognition of its outstanding research and development contribution in life sciences. Dr. Silvamurthy has served the Defense Research and Development Organization (DRDO), Ministry of Defense, Government of India for 40 years in recognition of his significant contribution in the field of biomedical research and development. He has been awarded several prestigious research awards, a few prominent ones as Dr. APJ Abdul Kalam Award for the most prominent scientist and educationist by Oasis World Records. 6. Dr. B. K. Anand Memorial Award by Nutrition Science Society of India, Hyderabad. Distinguished Science Leadership Excellence Award by World Science Congress. Now, I'll like to request Dr. Silvamurthy sir to say a few words.
Yes, clapping is always good for health. So, my dear students, all the very distinguished guests, invitees, speakers, members of the Anthropology Association, and all the very distinguished invitees for this very important seminar, Pre-World Anthropology Congress, which Amity is hosting today. So on behalf of Founder President, Dr. Ashok K. Chauhan, who has created this Amity Universe today, with 12 universities in India, 18 campuses abroad, 28 schools, 200,000 students, 700,000 alumni. So he has created the universe. So on behalf of this great personality, who may also be listening to this program, because he doesn't miss even a single science and technology event or any other important event like this. So thank you, Founder President, for your blessings and also the best wishes to all of us here in this hall. I also welcome a very important person, Professor Joshi, with whom I have interacted since my DRDO days at DIPAS, when I was the director DIPAS, and then as DG DRDO, I have interacted with him on many occasions. We have done collaborative research, Life Sciences Research Board. So thank you so much, Joshi Saab, for gracing this occasion. And he has also been the Vice Chancellor of Delhi University and also the former Professor of Anthropology, Delhi University, because I belong to that university. I'm the alumnus, so I belong to you. Thank you, Professor Joshi. Professor Sanjay Javekar, Chem Hospital from Pune, and he is also has been working with the DRDO on many occasions. I have met him also on a few occasions, so welcome. And also Professor Subha Rai from Calcutta University is a very renowned premier in universities in the country. So we are very fortunate to have a few of our very distinguished faculties from there who are also sitting off the dais. So Professor Rai, thank you for joining us. And your presence is very important from Calcutta University and also from the Anthropology Department. We are also joined by Professor Kostov Dalal from Sweden. And he has come all the way from Sweden. I had a very brief interaction before you commenced this program. So I was able to see the way he is contributing in the social anthropology and other domains of anthropology. We are also having Professor Kostov Dalal from Bangladesh, who is here. Thank you, Professor Dalal, for joining us. And also my own, from DRDO, we have Dr. Shweta, who has come all the way she is heading the Department of Anthropology in DRDO. And thank you so much for joining. And I'm not taking everybody. There are many, many distinguished guests over here. And Madam, I have also interacted with them. So thank you so much. I must appreciate Dr. Rumi Dev, who is a silent worker. She's like a karma yogi. She doesn't make much noise, but then she produces wonderful outcome in terms of academics. She has brought this anthropology department, which founder Dr. Chauhan started way ahead in 2005. When the university started, this was one of the premier department which was started. And this was built by our Rumi Dev, and who has brought good faculties who had brought brilliant students to our campus, many alumni who have passed out from the portals of this Amity Institute of Anthropology. They are doing extremely well. Rumi, compliments to you. And even though she was selected as director in one of the government departments, she joined there for a few days to have she didn't want to disappoint government also. Then she came back to Amity University. So leaving a person a government job, which is very attractive as a director in the Ministry of Health and Family Welfare, as professor. Professor. So that shows her affiliation and also the attachment to Amity University. So thank you, Rumi, for joining us back and then rebuilding this department in a big way. We are also joined by our Vice Chancellor, Professor Balvinder Shukla. Let's clap for our Vice Chancellor, who is looking after in this university is the biggest campus, with 40,000 students, 40,000 students over here. So thank you, madam, for joining. And I must also appreciate his team, her team, our Rupak Mukhopadhyaya, who is running around here, there, and you won't see him. Yeah, he is there. And he has so many connect. Many people came because of Dr. Rupak Mukhopadhyaya and Dr. N.K. Mungrefi. And again, she is doing a great job. And Dr. Tarun Joshi. So all the other team members of the Amity Institute of Anthropology, let's give a big clap to all of them. Now, coming to the topic, the focal theme of this pre-World Congress is very, very vital. That is anthropology, health, disease, and they are looking at how do we remove these disparities, inequality, inequities in terms of the healthcare delivery. Because, our country has got a big challenge. If you look at the 1.4 billion people, if you see the ethnicity, if you look at the ethnicity, there are tremendous diversity. And people speaking languages, different religions, and also different sects. And all this is a big challenge. So how do you give the healthcare? Inclusivity in healthcare delivery is a big challenge. So how do we deliver? That's what we are going to deliberate in this from the anthropological and social anthropological angle and other dimensions. And health is a very primordial requirement, right to health, like a right to education. Every one of us have a right to be a good healthy person. And we want to deliver health care for everyone, not only 1.47 billion people across the world. So it's a big challenge. So how do we do that? So anthropology is one angle through which, if you look at this, and there may be certain clinical conditions which are specific to a group, ethnic, or it could be an indigenous population, which was earlier called as tribals. So now we don't use the word tribals anymore. We call it as indigenous population. So if you look at them, there are different kinds of health disorders in these populations. So how do you identify and look at the sociological angle, anthropological angle, and deliver the healthcare to the people, both for prevention as well as promotive and also the curative aspects of the health. And this conference is also happening during our G20 presidency, which is happening now. India is proud to have the presidency of G20 for this year. Next month is going to be the final summit. I attended one of that in Coimbatore, where we made the final draft communique was formulated, and in which there are three verticals. One of the verticals is global health. One is clean energy, then the universal and also holistic health. Third dimension is science for society and culture. So the health is being given importance even in the G20 presidency deliberations. And I'm glad to inform you that Amity is hosting the S20 event this month, 23rd and 24th over here. And I have been identified as the chairman of this organizing committee. And this responsibility G20 has given to Amity to organize this. And I'll be using all my colleagues. I'll be taking their help. And so this is going to be a very big event where, again, health is a very important aspect here. And why I'm telling you is G20 presidency is looking at how do we remove the inequities in healthcare delivery. So that is why your deliberations here, health, disease, anthropology, and also looking at the disparities, how do we address these disparities? So I appreciate Dr. Rumi and also this the advisory committee which selected this topic. Now, little about our Amity group, we must mention. I mentioned about Dr. Ashok Chauhan. For him, research and innovation is his passion, junoon, and who is driving the research innovation. That's how it has expanded in such a short time, 2 decades, to achieve this level of excellence from a private university is a great achievement. And so we have given a focus on research and innovation. If you look at our projects, we have almost 400 ongoing projects which are happening in all our campuses, 400 of the value of more than 200 crores ongoing projects. Look at the publications, 40,000 research papers in journals of repute like Nature, Science, and also in the Royal Society of Chemistry, and many, many top journals we publish. And Lancet, we have many publications, more than 10, 12 publications in Lancet in the recent years. So all this speaks volumes of the scientific, the focus which is the university is giving today in Amity Group. And we have filed more than 1,970 patents. So that's a huge number. So that is the number that shows there's also innovations coming out. Amity is emerging as a cradle of innovation. We have also transferred technologies to the industry. More than about 25 technologies have reached the industry and through them to the society. So this is Amity today. Little Amity about anthropology. Not only they are good in academics, churning out the future global citizens in anthropology dimensions, whom some of them are here, some of them have passed out, many of them have passed out. And then she is also focusing on research. As was mentioned, she has looked at Northeast as one of the focus for research, because this is an area where our country would like to give a focus. So Northeast, Rumidev and the team have done a lot of research looking at the HIV. One is HIV. Child maternal health, she has addressed in Northeast. And also she has looked at thalassemia, another problem, and congenital diseases, how it is prevalent among in the Northeast, particularly among the indigenous population, the tribal population. So I think these research have already made a great impact, and I'm sure you will continue this, Rumi, with your wonderful colleagues who are committed, devoted. Now, coming to the final message, we always would like to connect with people, because all these experts sitting on the dais, off the dais, how do we harness this connectivity by synergy? That is, we contribute to their mission and they will facilitate, catalyze our activities in Amity. So one message I would appeal to all the experts who have come from outside, from different universities, let us build a consortium. Let us work together as a group. So this is the mission connect and mission synergy, which Dr. Chauhan has propelled here and promulgated, and that is propelling the university system. The other important mission is outcome. See, we have many conferences, pre-conference, World Congress, but then we look for the outcome, sustainable outcome, not just making the recommendation during the conference alone, but how do you continue to sustain the efforts to implement those? That is very vital. So mission outcome is another important thing which drives the Amity to achieve their sustainable outcome by such events which are being organized. So I would be eagerly looking forward, Rubidev and your team, that a very fruitful, sustainable outcome from the deliberations of this. Finally, let us all connect together, as our Chancellor says, together with you all, we will be able to create a happy world. We will be able to make a difference in our humanity and their quality of life on this planet. So that is what is the final message. Let's create that happy, healthy, peaceful world. That the health is the focus here in this seminar. So I'm sure that we will churn out many, many novel ideas through anthropological angle to address these inequities in healthcare, and how do we address not only in Indian context, taking that as a model at the global population. With this, I welcome each and every one of you once again for this gracious presence and active participation. I'm sure, I'm very confident that with such brilliant brains sitting together in this hall, we'll be able to bring out many, many novel ideas and implementable recommendations which will make that difference. Thank you. Have a wonderful day.
Thank you, sir. Thank you so much for your blessings. Uh, we have Honorable Vice Chancellor, ma'am.
Ma'am will join now.
All right.
भेज दिया मैंने वो लड़का जा दिया आपको सबके पास.
Good morning, ma'am. Professor Dr. Balvinder Shukla is Vice Chancellor, Amity University, Noida. She has over 22 years of experience in organizations such as Smith Group, Intra Software, IIHT System, Amity Group of Institutions. Ma'am, core competencies include establishing new business, HR planning, recruitment, and development as per the business needs and processes establishment. To her credit, she has presented many papers in seminar at conference conducted at national and international level. She has organized over 150 seminars, conferences, and management development program. She is on an advisory board of many companies, is a member of several professional bodies, and she is closely associated with many CSR projects. Ma'am is a strategist, institutional builder, mentor, and an inspirational leader and a relationship builder, along with being a with researcher, teacher, trainer, and entrepreneur leader, where her specialties include strategic management, resource based strategy, business reconstructing, CRM, automation of process and system creating and scaling up new businesses, change management, growth strategies, organization turnaround, and leadership. Welcome you, ma'am. We'll have a word of wisdom from Honorable Vice Chancellor now.
Very good morning. Um, our very special guest, Professor Deepak K. Behra, President, UIAF, and Honorable Vice Chancellor of Kalinga Institute of Social Sciences, Bhubaneswar. Our keynote addressee, Professor P.C. Joshi, former Professor of Social Anthropology and Vice Chancellor, University of Delhi. And a special guest, Professor Sanjay Juvekar, Professor in Health Sciences, KEM Hospital Research Center, Pune, and Savitribai Phule, Pune University. My esteemed colleague, Dr. Silva Murthy, and Dr. Romi Dev, and all the faculty members, the head of institutions, and the distinguished participants. The first of all, I, on behalf of Honorable Founder President, Honorable Chancellor, all the deans, head of institution, faculty members, on my personal behalf, extend very warm welcome to all the distinguished guests, speakers, and participants on the Pre-World Anthropology Congress 2023 International Seminar on the theme Anthropology, Health and Disease, eliminating the disparities. First of all, I would like to congratulate the organizing team, especially the president of UIAF, for choosing the very appropriate theme for this Pre-World Anthropology Congress International Seminar at Amity Campus. Today, when this kind of seminars not only enhances the knowledge, but also gives the trends and the in the particular areas. When we talk about the public health or the health or the diseases and the anthropology together, it brings the multiple dimensions, the culture. It brings the um, also the unique, helps in to go through the unique lens through which we can understand the diversity of the human societies, cultures, and the behaviors. Uh, it is a Anthropology is a discipline that allows us to bridge the gap between different people and foster a deeper sense of global understanding and appreciation of our shared humanity, uh, despite being from the various backgrounds. Our understanding of health disparities must encompass the entire spectrum of human experiences, transcending geographically, cultural, and the socio-economic boundaries. Only by embracing the diverse perspective can we create comprehensive and equitable strategies to address these disparities effectively. In the pursuit of knowledge, let us remain all committed to the principle of empathy and compassion. And I'm sure during this uh, uh, international seminar, a lot of dimensions, lot of aspects related to anthropology, health, and disease, eliminating disparities will be discussed, deliberated, which will enhance the not only the knowledge of the participants, but it is going to give a wonderful opportunity to the scholars, to the researchers, to the academicians to discuss, deliberate for how to collaborate for future research and work together. And at India has always propagated the Vasudev Kutumbakam, whole world is one family. And how we, from the diverse background, diverse nationalities, how can we work together collaboratively and find the solutions and understand from these diversities for the commonly applicable solutions to make, as our honorable founder president has said, let's make this uh, global world a truly global family. And our honorable chancellor said that together we can work and we can make the huge difference in the lives of others. And I'm sure this international seminar, all the participants, all the distinguished speakers, work together. And it is a privilege and honor for Amity University to host this international seminar. And I'm extremely thankful to all the distinguished guests, all the distinguished participants who have joined in person, as well as many of the speakers are present online. With this, I once again extend a very warm welcome and look forward, as Dr. Luamurthy was saying, that for us the outcome is the very important. And I'm sure the outcome is important for everyone. And at the end of this seminar, we will see the outcome in the form of forging the collaborations for the future research, and also the exchanging the knowledge and coming up with the maybe the joint projects and research publications, or the student exchange, faculty exchange, or many other collaborative areas where we can work together. So with this, once again, I extend very warm welcome and look forward learning about the what we have done. I wish that this pre-World Anthropology Congress International Seminar will be a catalyst for the positive change, inspiring transformative actions that impact lives across the globe. So wish all the best. God bless.
Thank you, ma'am. Thank you for your blessings and so much of wisdom we always get from her. So thank you, ma'am. Thank you so much.
Now we have Deepak Mehra.
Okay. So we have now with us online only, we have Professor Dr. Deepak K. Behra, who is the president of UIF and Honorable Vice Chancellor, Kalinga Institute of Social Sciences, Bhubaneswar. He was formerly the Vice Chancellor of Sambhalpur University, Rajendra University, Behrampur University. His distinguished career has many national and international honors to the name just a few. Fulbright Visiting Fellow, California State University. He is the chair of IUAES Commission, Anthropology of Children, Youth and Childhood, the former member of Governing Council Association of Indian Universities, AIU. Professor Behra is the author of more than 120 research publications and 19 books in the field of tribal studies, children and childhood. He has visited more than 30 countries in different academic assignments. Sir, we welcome you all.
Sir is joining, so I've sent him the link again. So so then I should be have yours before him. He's not yet joined. Join the link, I think. Yes. Okay. Sir is joining. Online. He said I'm on. I already joined. He said. मैंने बात की अभी. Yes, yes. So you join, sir. We will continue here. You join in the meantime with the details. Okay. Okay, sir. Okay. I think we can continue with Joshi, sir. Sir will join in the meantime. Okay.
Now we have Professor P.C. Joshi, sir, is a distinguished former professor of social anthropology, Vice Chancellor of University of Delhi. Sir has done MPhil in social anthropology and PhD in medical anthropology from University of Delhi. He has been the president of the Society for Indian Medical Anthropology and a recipient of Indra Priyadarshini Sa Mitra National Award as a founder member of the Friends of Trees. He has received appreciation from his work in disaster studies from Xavier University, Philippines, and University of Indonesia. Professor Joshi, sir, has extensively published in the field of medical anthropology, environment, and antibiotic resistance. He has deep interest in visual anthropology and made films on the village life in Germany, Vietnam, and Philippines. Joshi, sir, is the founder president of Society of Indian Medical Anthropology and continues to hold the position till date. I welcome you, sir.
Good morning to all of you. Respected Professor Selvamurthy. He has been a very old acquaintance of mine and a very powerful speaker. You have seen the sample of that. Madam Professor Balvinder Shukla ji, the Vice Chancellor, MIT University. Professor Rumi Dev, Professor Sanjay ji, Professor Subure, my colleague from Calcutta. Suburi is also editing a very, I think one of the topmost journal of India, that is Indian Anthropological Society Journal. He is editing that. But he's also involved in INCA, which is a kind of a consortium of different associations that we have in India. So, and of course, he's a very active member of UIF. So, I think it is very apt that he is here guiding us. Sunita Paltaji, Neeta Mawarji, Professor K.N. Saraswati, Mungfree, Rupak, and all the friends who have come from different parts. Huh? And all the friends who have come from, I think I can speak like this also. So I think it's a very historical day for MIT University that they are organizing pre-World Congress. And it is in the series of pre-congresses that have been organized starting from University of Delhi in March, if I'm not mistaken. In January, sorry. In January. And I think you were there from Bangladesh, right? You were there in that.
Yes.
So, very glad. You are going to Bhubaneswar also? Okay. But we wish you come there also. So right from there, we have had it in different places, in Pune, in Mysore, Punjab University, and different places, And of course, from 9th to 14th, we are going to have it in Bhubaneswar, which is going to be the World Anthropology Congress. And I represent United Indian Anthropology Forum. I am the chairman of the academic committee of the World Anthropology Congress. And I think in that capacity, I represent UIF here today, not as a former vice chancellor, whatever. So I think that is the main thing that I'm here. So I'm representing, of course, our secretary is also going to come here. So first of all, I would like to congratulate MIT University for coming up with this wonderful topic. Anthropology, health, and disease, eliminating disparities. I think this is something which has been a challenge from the very beginning that we have had. Now, India had a very illustrious tradition of its own medicines. Ayurveda we had, and if you read whether Charak Samhita or Susut Samhita, you know how advanced we were, and a lot of researches that were done, not only in the field of medicine, but also in the field of surgery. That there was a lot that was there, and then came the Unani, which actually was a Greek system of medicine brought to India by Arabians, and that was called as Unani system of medicine. And I think somebody should do research on a man who is actually a legend in Unani system of medicine. His name is Luqman. And, I don't know, some of you might have heard of Luqman Hakim. And it is said, like in proverb, we say that if something is not known to Luqman Hakim, then it is not known to anyone. That is the kind of, he was he was such a great physician that we have had. But then, when we are talking of today healthcare, we are primarily talking about the scientific medicines which have come to us from, I think, by the Britishers, and earlier than Britishers. I think first of all in 1520 that they came to Goa. That is where the allopathic medicine, something like allopathic medicine. At that time, it had a different kind of color and flavor. It came to Goa, and then we had the Britishers, and their troops were there. Their soldiers were there. Their administrators were there. Very few of them were there as East India Company, and they were ruling us. We were, like 1,000 times more than them. But then still, they were ruling us, and they had their own system of medicines. Now, the British, that Indian system of medicine, they would call it also later on. That was something which was not actually meant for us, to be very frank with you. It was meant primarily for, their soldiers, primarily for their citizens, and some of the so-called Rai Bahadurs and others, So there were centers. So most of the hospitals that they created, they were in cities like Mumbai, Bombay, Madras, and Kolkata. Calcutta was considered to be the place where they had, I think, very good in medicines. Chennai was a place where they were very good in gynae and obstetrics, and Bombay was a place where they were very good in surgery. This is the kind of pre-independence British time I'm talking about. The first, I think, first hospital for the native Indians. Hospitals were there; they were primarily for the Britishers. But first hospitals for native Indians, I think, came up in 19th century, in the later half of 19th century. That is, it was called as the Jamshedji Jijabai Hospital, which is now called as JJ Hospital. I think that was the first hospital where ordinary Indians were allowed. But I think this healthcare was confined primarily to the cities, to the urban areas, to the cantonments. And very, very, much later, much later, maybe after 1932, that we had this National Institute of Hygiene, that was there in 32. I think it came up in Calcutta. That was the first time, and therefrom, I think, slowly we started. So I would say that when we became independent, at that time our life expectancy was 32 years. 32 years. So you are supposed to live and die by 32 years. And I sometimes wonder, on a lighter note, I sometimes wonder why our gods, they are always without mustache and, beard. Whether you look at Rama, Krishna, all the gods, they are always without beard, they are always without mustache. Why is that, And one of the reasons I think could be that, you can make your own guess, life expectancy maybe was very low. So by the time you are 25, you had your grandchildren, and, I think they are married off. People would get married at 5, 6, and like that, So what I'm trying to say is that our health status of Indian population was abysmally bad, if I may say so. Now, we have somebody called William Joseph Bohr. Now, this is very important person, if you are looking at healthcare, and if you're looking at, disparities in healthcare, we're looking at. Bohr was somebody who had that was a health survey committee that was formed in 1943. And between 1943 to 1946, Bohr committee, this is called Bohr committee. And they gave wonderful recommendations. And they are the ones who for the first time, thought about people who are living in nooks and corners of India, people who are living in the tribal areas, hills and coastal areas. I think that was for the first time that they did. And I think they came with the revolutionary recommendations. They came up with a very, very wonderful concept, which was adopted by WHO 32 years later. In 1978, they said, in India, we must have primary care system of primary care. So for every 40,000 population, there should be, no matter where it is located. So it was the first recommendation, and government really accepted that, where we try to decentralize healthcare. We try to demystify health away from the cities, away from the cantonments to the nooks and corners of India. And I think India has made tremendous progress. I think because India is such a large country and such a large disparity is there. We have Kerala, which can be compared to any developed and most developed country of the world. But we also have Rajasthan, we also have Uttar Pradesh, where, like the indicators are far below our expectations. So India is a very, very diverse country. It's a very, very heterogeneous country. And that is the challenge. When you're talking governing India, you are thinking about governing Europe. India is no less than European Union. So all these European countries are, to govern them together is like governing India. So it's very, very difficult. And therefore, I think our health planners and our health bureaucracy, and of course, people, we have got, living example, people like N.K. Arora is sitting here, who have been, like day and night thinking about how to reach those people where we have not reached. So I think we have made tremendous progress and we must celebrate that tremendous progress. We were far ahead of many others in terms of primary health care. We even experimented with community health volunteers. We experimented. These are all experimentations that India has made. We are now experimenting what is called as Ayush, where we are trying to look at alternative ways of reaching out to those peoples. At least when we are talking about the preventive, when we are talking of boosting of immunity during the time of COVID, I think we were there in the time of COVID. We had Ayu Raksha. Ayu Raksha was something which was produced by Ayush. And this Ayu Raksha was used to, was given to people for the boosting of their immunity. And I don't know, some researches definitely must have been done. I'm not aware of those researches, but these researches are required. So India is trying to use different management strategies, different systems in order to reduce these disparities. Now, anthropology is a subject, especially medical anthropology is a subject where I would say from the last 100 years, since, to be more precise, W.H.R. River wrote his first book on medical anthropology, it was in 1921. So it is more than 100 years that medical anthropology has been working on looking at, people and reaching to the people. And I think there is a society for medical anthropology in India, which is called SEMA, and I happens to be its president. So we are, we came up with a slogan, 2 years ago when we had our conference, and the slogan was "Health for all at the doorstep." This is and when we say health for all at the doorstep, we are talking of again decentralizing, because this system that we have, that primary healthcare system, with of course later on we added sub-centers also, and these sub-centers were allopathic and Ayurvedic and Unani, all kinds of subsystems were there. So there was a kind of mixing of the systems of medicines for the subsystems also. So we try to reach at the doorstep, but still, I must say, there are problems. Silvamurthy sir talked about ethnicity. I can say culture. Sometimes culture is also a very, very important factor. In anthropology, we have worked on poverty. There was a book which was called Pills Against Poverty, and I think anthropologists must be knowing that. Pills Against Poverty. Now, in that book, which was a case study of a village in Tamil Nadu, where they try to look at why do people not accept certain things, or why the people do not change their behavior. Now, they said poverty is one of the very important causative factor. Poverty is not merely about lack of money. No. In that book, they showed poverty is a culture. Poverty is a mindset. Poverty is a mindset which prevents you from making rational choice. So you don't make correct choices. And this poverty, where you sometimes make wrong choices as well, can be seen in Delhi also, in the poor areas, where like we did a study in a colony called Patrachar colony. It is in Timarpur. There is a Juggi Jopdi kind of huge cluster is there, Juggi Jopdi. We try to go there and try to see pneumonia. When the children have pneumonia, what do mothers do? They need not go to a free hospital that is available to them. They would go to some doctor, and this some doctor would give some kind of spurious medicines. So why do they don't do it? It is not that they can't reach out there. They can reach out there. It is in Delhi that they can have the best free available. But still they are not reaching there. I think this mindset that is there, this mindset is very about. In 2021, in academic pediatrics, there is a study where they are talking about poverty. I'll just give you the reference. This is a very important reference that has come. And in that reference, this is by Lucy Mercil, Anti-Poverty Medicine Through Medical Financial Partnership, a new approach to child poverty. Academic Pediatrics, November, December 21. Now, in this particular article, they are again talking about poverty. They said poverty is linked not to economy, it is linked to biology. There is a direct linkage between poverty and biology. There is direct linkage between poverty and what they are going to do and why they are not going to succeed. So what I'm trying to say is that we have seen during this vaccination, COVID vaccination also, there was a discussion, critical discussion on vaccination hesitancy. And I think some of our friends in UNICEF, they were working on this vaccination hesitancy. Why do people hesitate? What are the factors? It's freely available. It is not going to make you infertile, but still all kinds of things going on. Sometimes people are just not ready to accept that we can be given something free. There must be some hidden, this is the kind of mentality that people have, especially people who are poor, especially people who are uneducated sometimes. Education also makes a very important. So what I'm trying to say here is that it is not sufficient that we have discovered medicines. It is not sufficient that we have trained our doctors. It is also important that we cross cultural barriers. We understand cultural barriers and we cross those cultural barriers so that people can have access. And we have seen wherever there is education, increase in education would lead to increase in access. In other words, lack of education is also related to lack of making the rational and right choice. So therefore, what I'm trying to say is that there are, when we are talking of healthcare delivery, when we are talking of healthy nation, we should look at these disparities. Number one, there are gender disparities, caste disparities, class disparities, regional disparities. All kinds of disparities are there. We must understand. And when we are trying to make intervention, when we are trying to, have some kind of a healthcare delivery, we are trying to reach out to people. We must take care of these, and we must filter, try to filter them out. And that is what is required. I think in the end, I would like to congratulate MAT once again, and I hope that with the kind of stalwarts that they have been able to, call here, they must be coming up with, I think, very good recommendations. And these recommendations should be shared by people. So thank you very much.
Thank you. Vera sir will join.
Thank you so much, sir. I just wanted to share one of my experience with sir. Sir was with me when I was doing my master's, when I was doing my graduation. Like from graduation onwards, sir was my mentor. So listening him after an ages reminds me back to my graduation class. Thank you, sir. Dr. Reva, sir, I hope you remember. Okay. Now we have with us Professor Dr. Deepak Behra, sir, who has joined us online.
Thank you very much. At the outset, I would like to welcome everyone to this wonderful seminar. It's not seminar, in fact, it's a pre-congress. And UIF is collaborating with MIT University in organizing this wonderful pre-congress, Anthropology, Health and Disparity. So I would like to congratulate the Center for Anthropology, MIT University for hosting this wonderful pre-congress. I cannot see everyone, but just I heard Professor Joshi's wonderful lecture. So Professor Joshi, Professor Subbaroy, and the coordinator, Professor Rumi Deb, other anthropologists assembled there in the conference hall. So namaskar to everyone. And it was a fascinating lecture. I was listening to Professor Joshi carefully. And I'm impressed, he talked about medical pluralism. And that is actually the ground realities today. And here, we should also discuss about the perception of the poor people, because time and again he referred to poverty and poor people. So how do they perceive disease, illness, and why don't they go to the medical practitioner, and why they prefer to consult a traditional healer? Here I would like to say that in our university, we have a concept of professor of practice. There are many who are unlettered and or people with very little formal education. They are from the remote areas, and but they are wonderful repository of knowledge. We have one professor of practice by the name Sobharam, and he has 300 medicinal plant in his backyard, and he is coming to our university and teaching our student, and he is also helping up to develop that kind of garden. So sometime, this traditional healer and quack, it is difficult to distinguish, but it is important for the anthropologist to distinguish the traditional healer from a quack, right? And, poverty is linked to nature of treatment, and there is a concept like culture of poverty, which was put forth by Oscar Luis. And that is why poor people, they display behavior, including the medical, their approach is a different type. And that is why choices, it's not directly related to poverty, I would say. It is related to culture, because there are some cultural paradigm, promotes or motivates them to take decision in a particular way. So many decisions are culture-based decision, and why don't they go to a doctor, and why they go to a medical practitioner? This is that should be, traditional healer, that should be discussed, because when a patient will go to a traditional healer and he can speak in the same language, and the traditional healer, the patient need not pay, and once he or she gets cured, then he may or she may offer a bottle of liquor and a chicken. But when he goes to the dispensary, there the doctor speaks in an alien language and writes in a paper, and that is not, he doesn't understand, and he would be asked to go to a shop and buy medicine that is expensive. So these hazards and the constraints should also be discussed. I'm sure it's going to be a great seminar, and once again, I would like to congratulate Professor Rumi Deb. I'm extremely sorry I couldn't make it, because I expect all the participants sitting in that hall to be here in our campus after 2 days. On 9th, I would like to see each one of them, and I give this responsibility to our representative, the chairperson of WACNAC, World Anthropology Congress, National Academic Advisory Committee, Professor Joshi. I entrust you this responsibility, and today morning, Professor Grigory has left, and maybe he would join you in the afternoon. So you please undertake this responsibility, bring everyone to our campus, and we are expecting more than 1,000 participants, and 150 would be from outside India. And it's going to be a great conference. And medical anthropology, there are many sessions on medical anthropology. I'm just trying to boost, motivate, inspire the delegates so that they can come to our campus and they can interact with our indigenous children. We are very excited, and thanks to the authorities, Vice Chancellor and other authorities for allowing UIF, United Indian Anthropology Forum, to collaborate with MIT University to stage this pre-congress. Namaskar, Jai Hind.
Thank you, sir. Now we have Professor Sanjay Juvekar, sir, Professor in Health Science, KM Hospital Research Center, Pune, and Savitribai Phule Pune University. Sir, an anthropologist, leads a diverse team consisting of anthropologists, medical professional, computer analyst, biotechnologist, health science scientist, and field-based researcher. He has done Masters of Science and Doctor of Philosophy in Anthropology from University of Pune. He heads Vadu Rural Health Program, that is VRHP, covering 1,70,000 people in 22 villages, and renowned Vadu Research Unit. Professor Juvekar efforts have empowered the community, especially local women, to conduct research. He has various multidisciplinary research at VRHP, including epidemiological, social science, disease burden, vaccine trials, clinical trials, behavioral intervention, implementation, research, science, and microbial studies. He has been conceptualized the in-depth sharing and assess respiratory. I share a world-renowned initiative to make research data publicly available for the global scientific community. Sir will be talking about the positioning Indian anthropologist in global initiative of improving health and wellness. Over to you, sir.
Thank you very much. We have been having a great day so far, and I'm sure we're going to have another full post-lunch as well today. Good. I'm going to talk in about how much time? 20 minutes? I know we are already running late.
Yeah,
So
10 to 15 minutes.
okay, you want me to cut down on my slides? Don't worry. Okay, I'll make it in 15 minutes. It's fine. Where's my presentation? Anybody? You know, where is it? Is it on this computer?
कहाँ है presentation?
Is it on this computer? Let's stop it.
Where is the presentation?
It's कहाँ पर है?
No, he's given like pen.
नीचे वाला देखिए. Okay, I'll be very quick. Some slides I'm going to just rush through. Wanted to just show you some names. But positioning Indian anthropologists, that's what you wanted me to do, Romy. Position ourselves in the global health forum. Let me see how I look at it.
Yes, sir.
So this is my perspective I'm going to give. And how health and wellness is understood by anthropologists, I think Professor Joshi has already told us. With that perspective, we've been working. So I'm going to quickly talk about the global health and anthropology standpoint as we understand, and then a bit of networking. We've been talking, even Dr. Selva, we talked about the networking, principles of stakeholder engagement, how does it apply, collaborations, examples of Pune-based anthropologists, and that too the mid-career, not the senior ones, not the very junior ones, but yes, the mid-career. Because there are n number of anthropologists in India who have done great work and are doing good work. But I won't be going to each and every one. I just would like to give a glimpse of Pune anthropologists and finally what is needed for the better positioning of anthropologists. Okay. So global health and wellness is possible if and only if it is really global. Now, when you say global, does it mean just go beyond borders? No, it is way beyond that. So how do you understand global? Indian as well as LMIC anthropologies. I won't say only India. We have to proactively position ourselves in addressing the SDGs. So far, it is only the Gates Foundation, the Wellcome Trust, the UK, US, European Union. They say that SDGs. And they throw some money and say that you do this work. I think that's not what we should be doing. We say that this is what we as LMIC want, and we want to position ourselves in such a manner that we come out with our own challenges and solutions to those challenges. And that's why SDGs have to be looked at very holistically in nature, and that could be best done by anthropologists. And anthropology, as you all know, is both. It's most scientific of all the humanities. And if you talk about the humanities, then it is also the most humanistic of all the sciences. With that principle, I think if we work, we would reach that. Now, a few quickly, cultural understanding. healthcare access and utilization, community health practices, you talk about patient-provider communication, you talk about global health research. Now, all these things, you would see that this is a link even. This presentation will be available with Romi and you can share with your students and anybody you want. And it could be shared in public, no issues. It will show how anthropologists have contributed to every aspect of this. And I'm saying it is not any anthropologist. Indian anthropologists have contributed to every aspect of this. And this is for work in Africa, Asia, and Oceania. It is not only in India or elsewhere. So that's why this is going to be very useful. And if we talk about the networking, I think that's what we believe in also. Our graduation starts with going and talking to the community and start with the networking with the community. So networking is not something very buzzword for anthropologists. We have been practicing that since childhood of anthropology. Otherwise, Manoj will say, what is this since childhood you are practicing? But yes, but coming to now you talk about the data sharing, enhanced training and capacity building, collective evidence. Now, all these things you see everywhere, only and only networking is going to be of help. If we try to do in today's world all these things, you practice this in silos, probably you may not reach to your goal. Maybe individuals' goal may be different, but when we as scientists, a scientist with great integrity, we have goals, whether it is for a study or for our career or for your work. Our goal is always set for a specific outcome related to, say, health for the population. Now, if that is in mind, we have to work in a network manner. And I think that is the way we should be going. I'm going to give 2 or 3 examples. One classic example is the in-depth network, which started with just following the population. And it was started by demographers. 3 or 4 demographers came together in 1998 and they realized very quickly in no more than 2 or 3 surveys they did, because that's what demographers do. They don't do studies, they do surveys. Count, that's their science. They do it very well. They did it and they realized, oh, we are just counting. What do we do next? And then they involved anthropologists. And when anthropologists was involved, it was realized that this network soon became the global network that could produce great results in Asia, Africa, and Oceania, about 46 centers across the globe. Now, this network was, again, we have a network, similar network in Asia. This Asian network of HDSS, they call it Health and Demographic Surveillance System. It also started with an anthropologist taking lead. Now, it is not that nobody else can do it, but because we are trained in that manner to accept and understand people first before jumping into that. And also, I think one of the things which we learn is respect. Respect everyone you are working with. Don't only have in mind that, okay, I'm here with great degrees and I'm coming to you. But we know we respect everybody with whom we work. And that respect actually helps us to network better. This led to the formation of Indian HDSS network. Very recently, I have Dr. Arora here, Rupak, many of you. So how did it come? Health research has been done a lot by the epidemiologists in this country, the public health specialists, as you said, even by anthropologists. But did we ever try to come together? Maybe the pediatricians have their own group working together. The epidemiologists, the public health professionals have their own consortium. Anthropologists have their own consortium. Where do we come together? Sharing our knowledge with each other. And that's where this HDSS network came in. Again, it started with an anthropologist thinking, can we really bring in anthropological expertise to bring people together by forgetting their own respective expertise and my network and my thing and my public health network? No, it's a nation's network. And that's something which we found very recently. About 1.5 million population are followed regularly by the people, and it's through the network across the country. This network, I'm sure, is going to grow more. Now, principles of stakeholder engagement. This is simple. Principles of stakeholder engagement apply even to our globalization of Indian anthropology. We want to go ahead. And what are these principles? Respect, equity, trust, collaboration, and transparency. All these things are extremely important. And please do not forget these, because unless you have these things in mind and heart and in your practice, you're not going to go global. And when you talk about the collaborations, we did collaborative studies. What do you mean by that? And you will know that science is hardly 10-20% there. Most of it is actually communication. And that's where, again, our science of anthropology comes in picture. We are taught how to communicate well, how to communicate effectively with the communities. And these communities not necessarily mean the tribal communities, the rural communities, or the communities from Jogis. It means every community. We have to be very much related to the growing nations. So a lot of urbanization is happening. Can't we anthropologists work in that? We do have a stream called urban anthropology. So that is where. So this is something very important we should keep in mind. Quick 2-3 examples. 3 minutes, please excuse me. I'm going to be very fast here because we have lack of time. So very fast. Yeah.
You do at your pace.
No, that'll be too much. Anyway, so Human Microbiome Initiative. Now, microbiome, metagenomics, genomics. Now, only one branch of anthropologists do study that. But whenever it comes to genomics, people will talk about the geneticists working in that, the genomics people. But now we have so many institutes in India. But here is an example. We started with the Human Microbiome Initiative for the nation. And we thought we would go and find out about 90,000 population in India across various communities, almost 200 communities. And how do you decide community? Now, if I say I am from Maharashtra and from one specific community, but I have started say eating eggs long ago, do I really retain some of the cultural traits? Probably not, especially when it comes to the genomic studied, metagenomic studied using stool examinations. Okay, so how do you do that? But we said, let's bring in anthropologists here. And this was conceptualized basically by an anthropologist sitting together with a genomic specialist. And then this study came up. This is ongoing study. But this is how you as an anthropologist have to push yourself into different streams, explain what expertise you bring, which will be complementary to the modern sciences. This is just an example of microbiome. But there are many examples. So even epidemiologists or the public health people or the community medicine, what we call in the Indian system here. So what do? They do epidemiology. But are there any standardized way of ensuring the research fairness and research integrity? Probably this was a learning of over 20 years of working, 25 years of working. And then we realized that, okay, we really need to bring in these in research integrity and research fairness proactively by working with. So how do you do that? Again, 3 anthropologists, one from India and one from Latin America and from Netherlands. We came together and said, let's try and find out. So there are these bridge guidelines which are actually bridging the scientists together across the globe to come out with research fairness and research integrity while you are practicing your research in medicine, of course. But this is another example. Sharing is something which I personally believe right from long ago, and we thought scientists are really hesitant. Dr. Arora is here, you know it very. You've been talking about this, Dr. Arora, with so many forums across sharing data. But they're skeptical about their data quality. That's why they fear. Their fear is also of the misuse of your data. Ownership or versus the custody. So these are some things. But in spite of all, against all odds, we tried, could we share this? And then there comes in-depth sharing and access repository. Now this repository is nothing but it is something an anthropologist sat together in a rural area, worked with the IT people and said, can we share data in public domain? It started with only Indian data coming up. Then Thailand and Papua New Guinea came along. And now almost 42 countries are sharing data. But it started with an anthropologist. So if you really want to position yourself as an anthropologist in public domain, don't just think of the theoretical aspect that you might have learned. Also think of applications of anthropology, and application of anthropology are immense. So I'm just giving an example, like in public health, in sharing data. So you have anthropology there. So you have to come out with concept, talk to the concerned people. Now let's see an example of how a mid-career anthropologist from one department, the Pune University department, Pune University, and in Pune City. So some of the anthropologists who have their ideas are very clear. They wanted to do initially they wanted to go global, and they started thinking that should we really do it for everybody? And then they realized that yes, anthropology helps us. For example, Nishi is from Haryana, works in Pune, but she envisions Indian anthropologists. This specifically I said because when I talked about this talk, and she said, okay, holistic approach to health research, cultural competence, unique skill and perspective that we could bring in, and transformative potential of anthropological research in clinical settings. So these are the things which Nishi, as an anthropologist, brought in. We have another one, Solomon. Now, Solomon is a hardcore qualitative research sort of a person, but works a lot in policy. And he says that policy implementation, be it vertical or horizontal, within sector or across sectors, does not depend only on the technical inputs, but what he says is largely shaped by social interactions and relationships. And for that, anthropology is an answer. So this is how he, as an anthropologist, could position himself in the global scenario. Now, today, in many of the European countries, he's invited specifically talk about the policies in India. Now, we have an educationist anthropologist working in the Department of Anthropology, but she also thinks that empowering future generations is something, and that too for what role of Indian anthropologists as teachers. So this is what she's trying to inculcate in her students. Sorry. We have Shantanu, works in genetics, anthropology, teaching in anthropology there. But he believes that for global health and well-being perspective, evolutionary perspective in biological anthropology is essential. That's what he believes. And he trains his students towards that. So can we go beyond that? He also talks about the genetic and hereditary disorders. Is it the domain of only the medical scientists or the geneticists? No, there is an anthropological perspective to that. And that's what we as anthropology could contribute and bring in. We have Aarti, who works in health sciences. I'm not saying medical anthropology per se, but she's very clear. Anthropologists propose collaborative knowledge creation with participants, co-researchers, collaborators, and with colleagues for designing projects by sharing expertise. So it is sharing expertise, and gone are those days when somebody from London School comes and says, you do this. Now we have our own expertise, and especially when it comes to anthropologists. I think anthropology is a science which could be best studied in countries like India, and not staying in Washington, D.C. So that's what she does. She collaborated with the Norwegian universities, and in fact, they said, and I met some of them, they said that we are the learners here. We never thought that Indian anthropologists could bring in this perspective. So that's how we position. Sachin works in drug resistance. Imagine just one aspect, drug resistance. An anthropologist working in that, started working in the lab, soon realized as an anthropologist that I have to go to my community. And he started going there. And now he is one of the leading persons working with drug resistance tuberculosis. That's something very important. Vaishali is a person, clinical research. It's all clinical trials, ethics. And ethics, if you talk about who better than anthropologists can really, really do things ethically, understanding ethics better. And Vaishali picked up a very different topic, which is unusually done by anthropology, the clinical trials. And she trains people for that. She has created curriculum for University of Pune also. So as an anthropologist, community cannot be forgotten. And Savita has been working with the community, and not with only she learned a lot from Indian communities, but now talks about the global communities. And she goes to African countries. At that time also she will talk about the communities. So that's how the community perspective. And then the position in Indian anthropology is again by a private university. Thanks that I'm here in MIT, and we have a teacher there in Symbiosis University, and she says that leverage research tools in anthropology. So she started with very small things, but she has a lot of bigger things in mind. Exploring the No, I think we as anthropologists could also understand, rather we could understand it even better. So can we bring in our perspective there? So that is what you all as young anthropologists have to keep in mind. Now imagine it just 10 scientists that I have named. There are many more in Pune as well. Dr. Noah, you are here. Huh? Sorry, I already said that no senior anthropologist listed here. But yeah, we have plenty here. Now imagine the global position in that we as anthropologists, through the forums that we have, thanks to Dr. Gregory and Dr. Joshi and all of you, the seniors who have created such wonderful forums, and also the INCA thing. Last slide. So what we could do, just take home messages for us, share learning with fellow anthropologists. I think we really need to share. I've seen that, I've been going to many universities, anthropology universities. I was very recently in Gangtok, and the people there did not know other than names. And maybe whenever they go and attend conferences. But was there any sharing with that population? No. I think we as fellow anthropologists, we have to share, start sharing. Adopt, think global, act global policies. I think that I have been, those who have visited me, Manoj, you visited, there is a world map behind my, in my office. It's simply to tell people that think global, but also act global. And only then we can position ourselves as Indian anthropologists in the global forum. I think that's something very, encourage young generation anthropologists for this, have faith in fellow anthropologists. That's something we should start. We shouldn't say that no, people don't study nowadays. Oh, post-COVID, people have gone bad. There's now students, I think everybody is complaining. I've been to so many medical colleges, everybody is complaining. Post-COVID, किसी को काम ही नहीं करना. Nobody wants to study. Just forget it. It's the different life they are experiencing post-COVID. If not, we as anthropologists can understand the changing practices in learning, who else can then? I think have faith in the young next generation. Work together as network partners. Integrative approach will help gain confidence of all stakeholders. That is again important. We have to work not only in silos as anthropologists, but we work very closely with our, so if you're working in medical health, obviously work with the medical doctors. If you're working in education, work with the educationists. If you're working in architecture, work with the architects. So we have to show how we are always complementary to the basic sciences. And as we all know, anthropology is also defined as mother science of all modern sciences. If that is true, then we have to always attach ourselves with something. If we try just, of course, that is also required. If you want to build a theoretical perspective of anthropology, working in silo with that perspective is okay. But if you are talking about global positioning, I think we have to think beyond that. Okay, and venture in newer methods in anthropology. That's what I will stop here. Thank you very much for listening.
Thank you so much, sir. Now we have with us Professor Subbu Roy, Professor, Department of Anthropology, Calcutta University, Kolkata, West Bengal. Professor Subbu Roy is a PhD in anthropology from University of Calcutta. He has served Allahabad University for 4.5 years and presently serving the University of Calcutta as professor. Sir is a managing editor, book reviewer, editor, associate editor, and also a member of editorial board of various anthropological journals. His research is mostly focused in understanding health of a population from its biocultural perspective, precisely how social and cultural factors shape the health status of a population. He has published more than 100 articles in national and international journals. Sir is presently a government nominated member for the Rashtriya Manav Sangrahalaya Samiti 2020-25, Ministry of Culture, Government of India. Over to you, sir.
Well, thank you very much. Thank you, Amity University, especially Professor Romide, for inviting me in this pre-Congress. I will take the cue from what Professor Joshi has left. Health for all by the year 2000. This was a slogan made by the world players 50 years back in an Alma Ata conference. And the objective was to eliminate, if not eliminate, to minimize the disparity and to reach primary health care to all the people of the world. I do not know how far this has been succeeded, but the approach, what I'll be talking about, has a novelty. The approach they declared would be multi-sectoral, that is an overall development of socioeconomic status in terms of imparting education, disseminating information, and also raising the economic standard of the people. Second, it should be bottom-up approach rather than top-down, where community people should participate, allocate their resource and utilize their resource, and use of appropriate, acceptable, accessible technology. This appropriate, accessible, acceptable technology is very important. And here comes the role of anthropology and other social sciences. So, if we look at the premise of health as such, we have social dimensions of health, biomedical dimensions of health, and applied clinical dimensions of health. But the first two where anthropologists are contributing, social dimension, biomedical dimension. And we have amongst us, I can recognize Professor Saraswati is here, contributing a lot in biomedical science. And like Professor Saraswati, many of the Indian anthropologists and global players in anthropology, they are working in the area of biomedical, competing with biotechnologists, microbiologists, geneticists, and so on. And look at the social sphere of health. It is very wide. It is very broad. And here we have a number of dimensions. Say, for example, we have on one hand socioeconomic perspectives, which leads to disparity. We have health services and systems, and also the utilization of health facilities, where we find disparities. All of us are not utilizing because there is a problem, or there is a disparity created by the state, or there is a disparity that is inbuilt within the community's perception in utilizing the healthcare facilities. So, for example, in institutional delivery, government is promoting, we are also improving, but how far we have progressed? Why 100% institutional delivery is not taking place? Perhaps culture plays a very important role. Why FP utilization? I'm giving you an example of sterilization, where overall over India, sterilization is very pronounced, very high. But if you look at Assam, here you'll find sterilization very low. People are reluctant to go for sterilization, and that is culture bound. And one of my students is doing work in this research, and we were preparing a manuscript why sterilization is so low in Assam. So here comes the role of anthropologists, how they play a very important role. Now, coming to socioeconomic perspective, migration is a factor. Migration may put people in difficult situation, or may offer opportunities to people, and that leads to a diversity in health. We also have gender, and WHO has a section, gender and health. And this is a very important issue, because gender diversity starts right from the birth of a child. It starts with weaning, and it widens as the child moves towards the adolescent stage. And finally, when we find this case of women, we find this reproductive health issue, which starts with their onset of menarche and ends until the end of the life, with passing through several life courses like obstetric, childbirth, breastfeeding, and finally reaching to menopause. And then we have another thing, and to minimize this disparity, we have heard of number of conferences like Safe Motherhood Program, which was initiated in 1987. You see the disparity, where 500 women, there was a statistics that 500 women die because of childbirth birth-related issues per 1 million birth in developing countries compared to 5 to 10 in developed countries. So in 1987, we had this Safe Motherhood program where a woman can pass through safe motherhood and deliver a child. A healthy child means a healthy nation. Now, there were certain issues, programs which was initiated at global level as well as at state level to improve this maternal health condition. Now, 1994, we went beyond that, beyond maternal and child health. We came into international conference on population development, where reproductive health was considered to be key in development of a population. And the address went beyond to maternal and child health and covered areas like family planning, adolescent health, cafeteria approach in family planning. Why? In order to reduce the reproductive health discrimination disparities in across different populations. And you know that in case of reproductive health, a culture of silence plays a very important role. And here, anthropologists are trying across the world to minimize these gaps. If we look at the concept of child health issues, we find different types of childhood. We find childhood of people. We find, children living in refugee colonies. We find children who have been migrated, living in difficult situations. So here again, we find a very interesting role which anthropologists can play in removing this disparity. Finally, in a country like India, the government has categorized on the performance of or on the utilization of healthcare facilities at different types of states, high performing states, low performing states, which means that we have not been able to eliminate these disparities, and these high performing and low performing states have been based on maternal healthcare utilization. It is very interesting. A case I'm talking about, I'll refer to you, that West Bengal is considered to be a high performing state compared to Jharkhand. But our research shows that poor people, especially the marginalized people, they utilize lesser health service in West Bengal, in different sections of West Bengal compared to that of Jharkhand. So we should address the nuances of this disparity, and only I think that the anthropologist can play a very important role in this regard. The time is short, but I would like to say disparity in health was there, is there, will be there. The role of academia, anthropology, especially the anthropologists and other social sciences, is to minimize this gap, if not to meet or to end this gap. At least we should do it to minimize or reduce this gap for the sake of humanity. Thank you so much.
Thank you so much, sir. Now, I would like to request Professor Rumide to felicitate our today's guest. Professor P.C. Joshi, sir. Now we have Professor Sanjay Juvekar, sir. Professor Subbu Roy, sir.
Thank you, sir, for coming all the way. Thank you so much for this.
Thank you so much, sir. Thank you, ma'am. Now, we go for a break for high tea, and after that, we'll start with the parallel session in different rooms.
And those who are online, please stay online.
And those who are on online, please remain online. Like we'll start within 10 minutes. We'll be back for the session. I hope all the speakers for this session are present here. We have this in F3 seminar hall. Amrita, please check all the speaker for F3 seminar hall has reported here. Okay, so we'll start with the session. We have this session named as Global Health Anthropological Perspective. So, as a chair, we have with us Dr. Monja K. Das. It's Manoja K. Das, Director. Is he there? Okay. Okay, sir, please come on there. Dr. Manoja Kumar Das is a full-time child health researcher. He has led leading projects on community-based intervention and medical technologies to promote early child development diagnosis of pneumonia in children. He is a leading led 25 project as a principal investigator and participated in 18 project as co-investigator. He is a recipient of 3 Global Grand Challenges research grants, Saving Lives at Birth, Saving Brains, Food in Maternal Nutrition, and 2 Grand Challenges Indian research grants. Now we will have with us a co-chair, Dr. Rupal Mukhopadhyay, Associate Professor, Center of Anthropology, Amity University. Sir is an Associate Professor at Center for Anthropology, Amity University, Noida. He has done PhD in Anthropology from University of Delhi. He is an anthropologist by training and experience in developmental sector and in academia over more than 10 years. He has published over 10 papers in peer-reviewed international journal. Sir has worked with urban, rural, tribal communities and industrial workforce in different geographical span in India. His specialization is in health, development, research, training, and has managed several multi-stakeholder national and international projects. So we'll start with the session now. Over to the chairs and co-chairs.
Good afternoon. I think after the inaugural session, we should move to the specific session on global health anthropological perspectives. For this session, our first speaker is Professor Kaustubh Dalal. Most of you might know Dr. Dalal. He is a faculty in the Department of Health Sciences in Mid-Sweden, University of Sweden. Dr. Dalal is a well-known researcher in the field of prevention sciences, health and safety promotion, health economics and systems research. He has PhD degree in public health sciences from Karolinska Institute in 2008, and currently he is a professor in Mid-Sweden University, Sweden. He is also on faculty board member and has several responsibilities in the international arena. He has been a senior advisor to the WHO International Safe Community Certifying Centers, and he is also the director of the Center for Injury Prevention and Safety Prevention at Örebro University. Dr. Kaustubh has several assets that he has been part of the several senior members along with ministers and the directors and senior persons from the ministries from different countries as his PhD students, and also he is one of the top researcher globally with supervising about 70 students. Dr. Dalal, yours.
Thank you. So it's really empty hall. I understand that anthropology has taken everyone there. And we are the global health sitting as usual. I have one background before this presentation. Couple of years back, one of my very good student was lynched by a mob who was eventually a medical doctor. And I was so much shocked that being a doctor who is trying and serving the patients, why the same patients are trying to kill the same doctor. And then I started to investigate the issues scientifically. And we published a very good article in very good journal, the relation between doctors and patients and why the violence especially erupted. And then this is the Indian scenario. And in Sweden, we had one student, very intelligent student from Israel. And we developed one model for patient empowerment, which is now very popular in European Union. And EU authority is actually relying on that model for patient empowerment, especially on information and communication technologies age. So based on these two, when Romy invited me, I said, okay, let's go for this. And you see that how the patients describe the doctors. And this is a scientific article. You will not see a single word from the patient's side who describe that, yes, the doctor was good one. Here in India, we sometimes, if get cured, then said doctor is next to God. But on the next moment, if the same doctor have some bad medicine, he or she is next to Jamraj. So this two polar extreme is our behavior. But why? Why it happened? So from my health economics perspective, and I should also inform you that I am one of the person in this world developing health economics. So the first health economics program and course in Karolinska Institute and Europe was developed by me in early 2000. In 2000 actually it started. And since then I worked in, physically I worked in 52 countries with the Ministry of Health and provided advice for developing the health systems. And so every time I focus and prioritize on these two issues, that if you want to provide good services to the patients, you should reduce the asymmetric information. What is asymmetric information? How many times you, if all you are sitting here, you are the educated persons in the society from India. How many times you ask the doctor why you are deciding like this? How many times you did in your whole life? Most of the time, you accept what your physician said. So it's more mainly one-way communication. You communicated with all your disease problems, with your symptoms, and receive one way the medicine from the doctor. Rarely you challenge the doctor, or even you ask that why you did it, or why you are not giving that medicine. So that was the problem. And why that's the problem? Because lack of empowerment. Here, like other consumerism, the patient is the most neglected consumer. And that lack actually the empowerment. Here as a patient, I'm not empowered, both maybe the juridical system gave me some power, but we rarely employ that power. So we are lacking the empowerment to challenge the healthcare systems. So generally what do you want as a patient? I just summarize from our study. Generally we try to, as a patient, when you visit any nurse or any doctor, generally we have this kind of issues, what you want from our side. Context, in which context you are there. Create the context for real discussion with the patients. So how many times you get that context from your doctor that you explain with 15 minutes or 20 minutes to a doctor? It doesn't matter that how much money you are paying. It could be 1,000, it could be a good hospital, it could be a good nursing home or private hospital, or your private visit to the doctor. How much money doesn't matter. The more famous, that's also another problem in Indian subcontinent, that doctors are either world famous or Asia famous. There is no below standard. So if you visit the Asia famous doctor or world famous, how much time you get? Maximum 2 minutes, 3 minutes, and then he prescribed. So how you could not create the context so you can explain to the doctor. Similarly, the doctor is failing to create the context. Then the holistic approach. Provide a holistic care. Most of the time, here we receive the holistic approach and holistic care. Personalized. You have very good relation. If you are socioeconomically in a good status, good position, then you have good relation with your doctor. But most of the time, what Subha was saying, and I forget his name. After Corona, I always forget their names. Yes, that's my Jubekar. So you were discussing about the disparities. So if we think about the disparity, we must go to the bottom. And that actually Amartya Sen and we were discussing all the time. That if we take the bottom side, a little trust, then the health system will be much more improved. So here is the problem. When you are thinking about the personalized care and the care goals, how many times the poorest person access to the doctor or the nurses, and how many times she is allowed to speak her own? So why that the poorest person will come to the doctor? It's very simple. And then the care pathway. I know that couple of years back, I published one article from India, and I have shown that why the poorest segment of the society, they do not access, even the health system is there, primary health care is there, but still why they do not access it. And the same thing I can inform you that recently we are discussing in WHO and we also with the United Nations that the effective coverage, the patients are there, the system is there, but how many patients effectively use that system? So that concept is known as effective coverage. India is very, very poor ranked in effective coverage system. But you cannot claim that government is not providing. Government is providing the services, but effectively we are using very significant low number of healthcare systems. So the care pathway is very poor. And then we have the home care. Most of the time we rely on home care. So if you are socioeconomically somewhere you can afford a private doctor, you visit to the doctor, get the medicine, stay at home and get the home care from your caregivers. But that should not be the system, because if your mother or your wife taking care of you, she is losing a big amount of human resources. So that human resource, we should not forget it. But economy is, as a total is looking for it. But in Indian subcontinent, we don't take care of it. That's why we are losing a big amount of resources, from human resource and also economic resources. And we avoid the unnecessary procedures or tasks. So nowadays, if who are around 40s or 50s sitting here, we know that when we are in our childhood, we went to the doctor and she prescribed one medicine, we took it. But now if you visit to the doctor, she will immediately ask you for 10 different blood tests or this or that or that. And actually that creates some mental barrier to access to the. And even if you go to the government hospitals, you do not need to invest money, but what you need to invest, that's time. So if you go to the hospital for one disease, it will take at least 3, 4, 5, 7 days for different tests and getting the results, and then it will get the treatment. So it's a long delaying process. So we must avoid it. The patients are demanding, and prevent the focus on prevention. It's really lacking in Indian subcontinent. We rarely focus on the prevention side. And then autonomy. Autonomy is also very much lacking in Indian subcontinent. So as a patient, you need support. So the health system is not giving you the support. The healthcare services is not giving you the support. The support only you are getting from your own pocket or insurance. and from your family members and caregivers, and information. Nowadays, I see that information is a boomerang to our poor Indians because we have the mobile phone, we use it very frequently, we Google it, we know that Dr. Google knows everything, but don't forget that Dr. Google is enriched by sometimes some blogger and some blogger who are really, even believe me, I know some of them who are earning 3 lakhs every month. They are not matric pass. They could not pass the matric examination. So you are getting enriched by the poorest educated segment, being the highest educated person. So you understand why the asymmetric information is just flooding all over India. And then the empowerment is grossly missing because even WHO since 80s prioritizing a lot. In the last European Union WHO meeting, they completely focused only one point, that's the empowerment of the patient. And based on that, I felt that in India we grossly miss. And that is why this power asymmetric distribution between the doctor and the patient jeopardize the whole healthcare system. So patient empowerment, I just quoted from the WHO, a process through which people gain greater control over decisions and actions affecting their health, and should be seen as both an individual and community process. So from morning we have heard the word, the community so many times, but can you tell me that in your context, how many times you have utilized the community concept for your health or for your empowerment? Rarely. So that means understanding your role as a patient is grossly missing. You do not have sufficient knowledge, or you did not acquire the knowledge to able to engage your healthcare provider. So she could be engaged with you and you should be engaged with her. Skills. The skills are lacking from the patient side. If I am very highly educated, we are sitting here, sometimes we go and ask to the pharmacist, do you know why my doctor suggested it? But we did not ask the doctor why they suggested it. And then the procedure of a facilitating environment. The environment is missing. Due to huge pressure or demand from the patient side, the environment is missing. And last week I was in another university. I was telling that we have enough number of doctors and nurses. We have, every country in the world has a resource problem, healthcare resource problem. So India has, but we do not have significant shortage. The problem is the distribution of the healthcare personnel. That's the great challenge. And we had the evidences, because I am always asked for the evidence-based approach. So we had evidence from Cuba that how they distributed the healthcare personnel, and each and every person got immediate healthcare support. So we had the evidences, but the distribution of the staff is actually lacking the problem. So patient empowerment, we control this patient empowerment with some beautiful concepts. One is control. How you can control as a patient. A rickshaw puller, when he has fever, he control it because he knows if he cannot earn 200 bucks, he cannot pay it to his child's teacher. So even with the fever, he is pulling the rickshaw and earning 200. And I, as one of the highest earner and socioeconomically top position, if I have even one itching, immediately I call the doctor. So being the same human being, the control actually plays a bigger role. How you are controlling yourself. And I can give you one example. The same people who are living here or the low income countries, when they are visiting as a refugee or anyway, visiting the high income countries, for example, in Sweden, even they are sneezing, they immediately call the facility that I'm sneezing. But the same sneezing, after 1 year, they never called a single, even nurse, when they are in her or his country. So you understand that how control plays a bigger role for the empowerment. Psychological coping, how you are coping. If the doctor said, okay, this patient has the cancer, I am pretty sure any patient from OECD countries who actually taught from the very beginning that this is part of your body disease, she will cope very easily. And here we only taught how to get higher score in our education. We did not, and how to get a better clerk, to be very honest. We are producing bigger and better clerks in Indian education system. Rarely we produce a great scientist or academician. So we have very poor psychological coping. And then self-efficacy. Self-efficacy
Sir,
is...
You have to complete in 2 minutes. I'm really
No, I
sorry.
have 20 minutes.
Oh, so yeah,
I have
20.
20 minutes.
Okay, right.
So self-efficacy is like, there are always, we misunderstood that self-efficacy and self-esteem. So when we ask about the self-efficacy as a patient, how many times you have produced your self-efficacy to your medical person? Understanding, legitimacy and support. I already discussed short support. And here is the consequences. As a patient perception, we visit to the doctor with our own perception. The perception, we measure it generally with health-related quality of life and with your satisfaction. So I use this satisfaction scale and HR call so many times when the patients exit interview. I did it thoroughly. I'm doing one longitudinal studies in Bangladesh right now. And we found that patient perception is the most triggering factor for the consequences from the patient empowerment. Clinical outcomes is always there and healthcare systems effect. So based on this, we always running, especially in our subcontinent, a visa cycle. A visa cycle, we spend less on healthcare and infrastructure. We are ready to pay out of pocket when it's extreme disease condition. And there are three kinds of doctors. One is the best doctor who never allow the patient to come to her. The mediocre doctor who treat at the beginning, and the worst doctor treat the patient at the extreme stage. And in India, most of the doctors are the worst doctor because they treat at the extreme stage. And based on that, when we spend very less, because we are not paying tax, we always say we have 140 billion, but how many persons? Even 1 billion doesn't pay tax. So how we expect that the healthcare spending will be higher? And then poverty, illiteracy, and no or poor empowerment from the patient side, and delayed diagnosis. We always diagnose, especially for the cancer, for the diabetes, for the hypertension, we always diagnose at the later stage because screening system is grossly missing in our subcontinent. And advanced disease, it's always at the advanced stage. So what you need to pay more. And then you are again increased with all these parameters and pay again. So you are always with this vicious cycle of disease. So is there something or someone to help the patient? So these are the chunk of the cake or the pie. So these can help, but I can tell you this is one of my good friend from in Calcutta University. He produced it, and we found that most of the time the patients are lacking all this concept. So what we can find that in ICT can help them, information and communication technology can help them, and actually it helped so many patients around the world. Every day we are using ICT. It improved the healthcare sector. A major improvement in Indian health sector came from ICT intervention because there are e-health, there are mobile health, and there are digital health. And how it affected, I can show you the statistics. And now currently we have artificial intelligence. So all these together, the information and communication technology, how it can provide the empowerment. So we have all these empowerment factors here. At the patient, what you can consider all these empowerment factor to optimize. And how you can optimize? You need the strategy. The strategy should come from the policymakers, from the patient's lobby. We have the, after this national health policy, 2017, we have some good strategy for patient organization in every hospital, primary health sector, but it's not effective. So the strategy is there. For example, that education. We need to educate the people. Instead of teaching twinkle, twinkle, little star, if we teach the boy or the child, wash your hand at the very first day, that's much more effective than listening these rhymes. And we have evidence. We have some case control studies in Bangladesh, in very poorest area. Instead of teaching this colloquial education system, we taught them about their health behavior, about their safety behavior. And we found that after 3 years, those students actually, they were from class 1, class 2, class 3. When they were class 5 or class 6, they were much healthier and they performed much better in their academic career. So we need a proper education system. We need monitoring, communication, analysis, and engagement. So here we need a workflow. That workflow is missing. Workflow should decide how the information and communication technology services the patient should use, not the doctor. We all think about the doctor side. The doctor is using, but how about the patient? And technology tools are there. Patients are not allowed to use. How many times you allowed to use? At least see your X-ray machine. How many times you allowed to see your needle you are getting injected? So the needle you are getting penetrated, you are not allowed to see it. The nurse is asking, oh, look, that hasn't just injected it. So these kind of very minor issues actually affected patient health grossly. And we measured it in Sweden. We measured in Europe. I measured it in Asia also, like in Japan, in Taiwan, in many countries. That these minor issues, we run ourselves by the perception. That's the greatest challenge of Indian society. We always say about perception, and even these minor issues grossly affect the patient's health. And when we think about the tools, evaluation never done. We never ever evaluated any program. Give me at least one example from Indian policymakers. They evaluated one program they did in last 75 years. Nothing. So how about the mobile phone? Look, the access to the technology, how it's growing up. In 2023, we had almost 820, and now it's jumping to 928. So the information and communication technology, how the digital health is actually revolutionized the Indian healthcare system. In this year, it's 12.2 billion US dollar. It's the current market. In 27, it will be 25.64 billion. So next 4 years, it will be more than double. So how much money we are investing on digital health? But the average revenue, don't forget it, average revenue per user is 32.26 US dollar. So every time as a user, as a patient, you are using any digital health device. It could be your mobile, it could be any device in hospital. The average you are paying 32.26 US dollars.
Sir, 2 minutes more.
I'll finish in 1 minute.
Thank you, sir.
We have the Ayushman Bharat mission. But why? They put a lot of emphasis on digital health, e-health, m-health, all kind of health. Why they did not put one paragraph on patient empowerment? So you understand, we have gross missing of this concept. Unless we empower the patient, this kind of patient-doctor relationship and the violence against the medical personnel, we can never control it. Because there is really big amount of misconception and overconception from the Google. So we are getting biased from our information as we are not empowered. So we are arguing with the bias to the medical professionals or the service provider, and the patient empowerment by malinformation leads to reverse asymmetric information. So now the patient has more negative information when she is communicating with the doctor. Patient middle and higher socioeconomic status, and poor they don't have. So this reverse asymmetric information from the patient side will create more problem in next couple of years in India. So you will find more such violence news against the doctors in India in coming years. So resulting more violence. How should we can stop it? It's very easy. Empower the patient by any means. And I always end with this great scientist. We cannot achieve problems. with the same thinking. We used when we created them. So you must come out from your thinking box, and we must come out from our perception-based lifestyle. It should be evidence-based. Thank you.
Thank you, Dr. Dalal. Do we have any pressing questions, or we can move to the next speaker otherwise? Okay. Yeah, one question you can take.
Please. I could not hear you. Just
Can you take the
please,
mic?
please.
Yeah.
So, misinformation has been an extremely big problem during the COVID-19 pandemic, especially in Europe as well as in the US. We have seen the anti-vaccine movement take up quite a bit of steam. I understand your perspective when you say that promoting thinking critically is important, but a lot of studies have shown that once people make an impression that XYZ medicine is bad or so and so, trying to convince them otherwise tends to make them double down, saying that, oh, you're trying to convince me against, this anti-establishment belief that I have made. So what do you think is, for those who have already become entrenched in these beliefs, how do we get them out of them? How do we empower them? When you have that misinformation, how do you combat it?
No, why you have the misinformation? That's the million-dollar question. Because we did not receive the right information. That's why we are flooded with the wrong information. So who will provide the right information? The scientist. So how many times, here everyone is scientist, how many times you disseminated your findings to the media? Very simple. You are disseminating within your groups, with your colleagues, and with the scientific community. So it never goes to the taxpayers. And that's why in Sweden, because I am now in the academic council of EURESTRA, European Responsible Transition, EU, we clearly mention that every student must taught at the primary level, first year or second year bachelor's level, how to disseminate. Because that if you read a good information, how many times you disseminate that information to your family members? So you are not giving it to your parents, to your family members. So how you expect that your neighborhood will be enriched? Yes, please. Please.
There is absolutely no reason why I should be asking you a question, because with your experience in West Bengal and nations abroad also, you have worked with people about psychological issues pertaining to health infrastructure and also health dissemination. I just wish to ask you one basic question. If you're talking of critical thinking on the part of the patient, who, when we talk of indigenous populations, they are primarily illiterate, so to say. They have not gone to even school. So critical thinking imparting is more important to doctors or to the patients?
To the system.
Sorry?
To the system. Because doctor is in one hand and patient is in the other hand.
And also related to this is the major question of the ratio, the patient-doctor ratio. Often I have seen doctors complaining if they are not able to explain to the patient what is the problem to the relatives, those relatives and the support structure that the patient has. The doctors are often seen frustrated over this, that how can we explain this to these people? Now, do you suggest that anthropologists do play an important role?
Very important.
And I would say that communication strategy should be evolved, and people at your level can suggest to the policy to improve upon the communication strategies.
Yes, we actually.
Thank you.
I can just inform you very briefly. Before Corona, we had a long discussion with the DG Health in Delhi. We had actually went up to a certain level, and then Corona came, and then all the stuff they removed, and now new stuff. So I need to develop from the beginning to But
Thank
now
you,
we missed
sir.
it.
Thank you very much, sir. I
Uh,
think.
I think for the pressing time, because we're running already half an hour late and we need to do justice with two other speakers, we will take all the question during lunch session as an interaction. Thank you very much.
Now, moving forward, after Dr. Dalal's talk, we'll request Dr. Neeta Mawar to come on for the next speak. And Dr. Neeta Mawar is a former DIC and Deputy Director at the ICMR Sinari, which was leading the AIDS research and also other. And she holds a 35-year-long experience in various institutions, including the NIHFW, which we all know about that, along with the ICMR and the other institutes in the India. And she has contributed significantly to the research projects across these various organizations at a national and international level. She has been working and has a keen interest on the women's health, special aspects of the HIV/AIDS, and youth, women, and high-risk behavior groups. And we'd like to hear from you about your experiences on these women and the related issues as health. Thank you.
Thank you, Dr. Das and Dr. Yeah. And all my colleagues, friends, and my seniors and my juniors. It's a thanks to Amity University for inviting me here to present a paper here. It gives me a pleasure to be here back with anthropologists. So nice to be with anthropologists. As an anthropologist, I've been working in the last maybe few decades with medical, in the field of medicine, and often with doctors. And I've always been emphasizing that any health problem is as much a social problem as it is a medical problem. And it takes them time, but they do believe that it is possible, because eventually, when it comes to patients, the dyad of doctor-patient is possible only if anthropological intervention happens. Otherwise, the interaction is something like a technical giving and taking, because the doctor is busy treating, following a certain norm incorporated, and the patient that is who's receiving it. So that's the way the things go. So interaction among them, and thanks to, in a way, when epidemics like HIV and AIDS came, so a lot happened on the ethical issues, because this was related to the human rights. It related to ethics, because the first time it happened, this particular thing was seen, HIV infection was seen in US, among the 4 H's. And the 4 H's were heroin addicts, homosexuals, the Haitian population, and the hemophiliacs. So because they were getting this infection, those people always felt that we have certain rights, why we should not get the treatment in a proper way. Proper means not according to what the doctor is giving as a technical information, but what a patient wants as a right. And that is where, as Dr. Kaustubh said, do they have the issue of negotiating? This is where they come into a practice. It was with the scenario of HIV and AIDS, ethics committee became very active. Earlier, we had ethics committee in our institutes, and for social scientists, they said there is no, there is no invasive procedures involved. So why do you want to submit your project for ethics committee approval? Because unless there is a blood drawn, then only it is invasion. I said, what about invasive procedures? I mean, the moment you intrude into the privacy of an individual, that is where the whole thing starts. So the relationship changes, and that's where it becomes important. So when HIV came, it was not just a medical problem. It was as much a social problem, very much an individual problem, where confidentiality was very important. Autonomy of a patient was respected, cared for, and so also justice in taking people who are going to be a part of your research subjects. Not because they are easily available. If we can go to a jail and let's take, collect the blood samples, or we go to the red light area and collect the blood samples, no. A lot of ethics was involved in it. I don't want to go into the ethics part of it because that itself is a separate topic. So, but it was important that we talk it up as a rejoinder to what Dr. Kaustubh just mentioned. So it's important. A lot has already been said what I wanted to talk in the morning, but I would still highlight because it's a part of the journey. And it's the women issue that I will really talk of because disparities are there very much with relation to women. Well, whether we call it gender, whether we call it male or female, biological differences are there. The gender issues come because social cultural norms are there related to particular thing. When a child is born, for example, a very simple example, when a child is born in a hospital, the nurse says it's a boy or a girl, and a barfi or a peda is distributed to symbolize that. Barfi meaning girl and a peda means boy. And now when in acknowledgement, because when they want to reciprocate the good news by some gifts to them, so if it's a girl being born, even in a private hospital, they don't expect very much to be given because it's a girl being born. But when the boy is born, they expect a very high remuneration. It's a right. So so that's where the gender begins. The doctor has said a male child or a female child born with so much kg, 2.5 kg or whatever. But the moment the nurse says it, peda and barfi, that's where gender really begins. So it's day one, the gender really begins. And that's how the child is really brought up. How do we go about it? What is to be done after that? Well, we all know it is okay for a girl to, go to school, come back by 4 o'clock. Perfectly okay for a boy to go return by 9 o'clock. No question asked. The girl is late by even half an hour. Lots of questions being asked. She's scolded. So she is, in a way, through the process of socialization, being protected. Unlike a boy who's not protected. But what happens is no questions being asked. The girl wants to study, come back from the school on time, everything is fine, but not from the boy. So this kind of I'm just giving you a backdrop. Within this, the boy and a girl are brought. So the girl remains unprotected. I mean, she is absolutely secured, protected. When she gets married, I'm not going into HIV and how it happens, but we have seen it happening in clinics. When a woman who is pregnant after marriage and she goes to the antenatal clinic, whether it is urban or a rural center, antenatal checkups are done. She's found to be HIV positive and she's told that she is positive. And if she wants to avoid passing on the infection to the child, then she must take an AZT treatment to avoid the transmission to her child. That means she would not be breastfeeding her child. She's mentally prepared all along that she would not be breastfeeding her child. She would have to keep the child away. The birth has to be there in the hospital because it has to be done under the C-section because to avoid the transmission. Because it is not genetically transmitted, but it is through the biological process itself in the delivery, the chances of transmission are there. So in that scenario, what does the woman do? Avoiding breastfeeding is a very big challenge when it comes to, when she goes back home, the women literally cry. This is a paper that we have already published and it's come in the International Journal Culture, Health and Sexuality, given to us by NACO to do this study, and we did use qualitative research methodology to do it in different sites of the. So that's how it happened. So the women cry, that how difficult it is for them that they want to breastfeed the child when the child is crying, but they cannot. So to give them top feed, okay, one is not this resource poor country, so they cannot afford many things, but for them to hide the fact, because when neighbors come, they're interested, okay, baby boy, you're feeding everything, But the woman has to pretend that she's suckling the child, and she cannot do that and then she cries. And then when there's some kind of sickness, there are different kinds of problems with that. So these are the very, very basic personal, humanistic approaches that we really need to approach when we are talking of such things. So this is one example of gender discrimination, disparities between male and female. So this is one example that I gave you. Another example that I would definitely like to, this is the talk of, now she got an HIV infection, her husband he did not tell that she was HIV positive, but he had a risky behavior. So although no risk of her own, but with her monogamous partner, he still got an HIV infection. Just because the partner did not tell her his own HIV status. He in fact put the blame on her. Sometimes deserted the woman, literally threw her out of her house. She had to go to her parents' house or found some way to do that. So there were very many ways how women had to hide. So there was a lot. Why did they have to hide? Because there's a lot of stigma associated. Very much a social problem. So this is one of our papers that is very well cited paper. And so women have a double burden, not only because they are women with their own vulnerabilities, but they also have the additional HIV stigma added to it. They are not entitled to any property because if the husband has passed away, the child, if it is a boy, okay, some possibility that they would have some advantage. But if it's a girl, they would not. Then they said it's a burden to us. They find some reason to get us. And that is why counseling becomes very important with HIV. The ICTC, Integrated Child Testing, Counseling and Testing Centers are very well operated even till the village level. In the this thing, they are available. So counseling becomes a very important part and that is where social scientists come up in a very big way. Our institute was also one of the centers to train in, training of the trainers in states like Kashmir, Uttar Pradesh and Rajasthan, because we come from, I mean, they wanted somebody from Hindi speaking well, so we had a team so we could go there and train them. That's it. This was just to give a backdrop. So I would talk about is women and health a transformative journey over the last 50 years. Why have I asked it as a question? Is it really true that on paper it looks, when we do a search, we find that it's improving, everything is going better, family planning program is very good. How come? Okay, so I think I've gone beyond this. So if family planning program is so good, how come population in India is still increasing? Do we feel proud of the fact that we are the first one with the highest population? Is it good for us or no? That is something that we really look at. So increased awareness about health and nutrition is happening because ASHA workers, the ICDS program has gone down to the village level. So people are improving, but how much have they control over their bodies? Do they have the choices? They definitely improve their choices, but to what extent they can actually implement it? Because this is governed by many other factors. And this is where the social cultural factors come into play. A woman cannot decide anything without her husband. She cannot have a choice on her own. Even our, sterilization forms, the husband has to sign first. Then only a woman's consent is taken that she could get herself sterilized. To that kind of, because a woman who has already had 5 children, 5 daughters, and she does not want to undergo the torture of having more children, she cannot get a sterilization done till the father has signed it. So these are the kind of discriminations that happen, the disparities that exist, and we need to really be realistic to see how can we approach it. So can we talk of transformation for women in this stage? I think we really need to look at it. So when we talk about reproductive rights, that is one of the important roles of women because she is defined as a feeder, breeder, and home products producer. So that is her basic role. I'm talking of the overall Indian scenario. So in traditional society, that is what it is. But can she really assert it? To what extent can she do this? This is something that we need to look at. So birth control pills did help to some extent in many countries. In India, somehow it was not very popular because it disturbed the breeding pattern. And culturally, the breeding pattern being disturbed is a nuisance for the family because a woman cannot do many work. And somehow it was never encouraged. The IUDs were still okay, but that had problem for the woman herself. So it was again not considered. Sterilization was an option, but only woman has to get herself sterilized, and that is the way it was. So somewhere it was improving. The other aspect was the legalization of the abortion. So at least women's rights improved with that. Okay. I think we have talked about this. I have some time, right?
5 minutes more.
5 minutes, that's all?
Yes.
Okay.
And we would request you to complete sooner.
Okay. Okay. So so we have to address the disparities with a comprehensive approach, not because somebody is rich or poor or something like that. Access to healthcare by giving it is not enough. We have to include as access to money. Do they have access to the money at home? We have done studies on women where earnings of women in the rural areas specifically, because it is always exchange. It is in terms of, the grains that you get. So woman doesn't have any cash. The cash is always got by the husband because when he has a whole pile of grains, the money comes and that money remains with him, though the woman has worked for it. So her work goes really unaccounted for. So in that case, can she really go and have an access to a healthcare provider, the modern healthcare provider in a sub-center? Even if it is free, she has to spend money on the transport. She has to spend the whole day. She will lose her wages, even in kind. But when she goes to a gunya, a local healer, she can just give the bowl of grain and that's fine, she can get it. So we have to look at it, the time for herself, the travel costs, healthcare providers, how they are going to behave with her. She would be told to come in the end. And when it is HIV, if they know it, this woman is told, please wait outside. After lunch hour, everybody is gone, then only you can come. We have seen these things happening with us in our own setups. When it is culturally competent health system, for the woman, the support system is very important. Will the mother-in-law support her? If she is given birth to a male child, yes. But if it is a female child, would she get the support? I'm not sure. So specific concern with these communities is overcoming their barriers. That has to be addressed at a big way. Okay, I've talked about it. So we need to advocate for their health needs through crucial role in raising awareness at different levels, not only for the women, but as much for the husbands, as much for their mother-in-laws. So those kinds of dyads of relationship that we have, we need to do it. We have done these kinds of studies and we have shown that it has well proven. I'm going to present it somewhere else about this. Demanding policy changes where these need to be addressed. For example, if we want to tell women to adopt a particular family planning method, husband's consent has to be taken or she has to be informed. Even when our trials we have seen. And we have to look at it as equity or equality.
2 minutes, ma'am.
Okay, equality is something that is given. But equity is something that is like making them wear it according to the shoe size. So it has to be in the context of a woman's needs. Not because the government wants to give it, it is on equal level, it is given. But it has to be equity in terms of the context that does it fit her? Is it going to, how are we helping it that she makes utilization of these services? So in the end, I would just take 2 minutes. When it comes to strength, let's do a little SWOT analysis. We have the strengths, opportunities, weaknesses, and threats. I'll give you an example of population is one. We have the maternal mortality rate, IMR rate are decreasing, span is increasing. That is good. And things are getting better because opportunities, we are getting things much quicker, communication, improved technology, IT for one is improving. Weaknesses, the age at marriage has still to be increased further. Family size is decreasing, but no change in the census data. One thing is we don't have a census. Surprisingly, one of the biggest things that we have lost the last 10 years is the census data not being available because the census was not done. Now something is being reported even by the IIPS. Even that report is not allowed to be reaching. So these are things, it's not, I'm not talking it as politically, I'm talking of the real hardcore evidence-based data that we already have. The threat is, of course, new epidemics, HIV, SARS, COVID-19, these will keep coming and we have to see. So can we really say that this is progressing? So I talked about the AZT intervention when it was given. So I think I've gone a little here, but the success stories of HIV program has to be taken into account because that happened because it was a very close collaboration of control and research going hand in hand. Dr. Das, you must be knowing how Nari, our institute was formed and the NSCP came almost together in 1992. And it was realized that control and research cannot be isolated, they have to be taken together. Then only can they have a release, we can see the impact of it. And over the years, we have been collaborating together and we have seen definitely a very successful program happening as a result of it.
You have to conclude, ma'am.
Yes, I will just conclude. 2 more slides. So new infections in the same period have decreased by 60% as a result of the NACO ICMR program, antiretroviral therapy being given. So India is experiencing decline in new HIV infections in recent years. However, the decline is again steeper for males than for females. So this disparity still remains. How far are we able to have a control over these? So this is something that we really need to look at. So the last 5 decades witnessed progress in women's health, advancement in reproductive health, improved healthcare, access to AZT treatment, preventing PMTCT. However, the disparities remain, persistent gender inequalities remain, and this necessitates continued advocacy for ensuring that all women have equal access, quality healthcare, comprehensive support for their overall well-being, and this should be evidence-based related to policy and planning. And why policy and planning have to go hand in hand is because they cannot be taken as isolates. You know, policy is made by somebody else because we have to really have a community involvement. When a policy is made, is it really according to the needs of the people, which an anthropologist is definitely really keen on understanding. And I'm sure our anthropologists in different fields are able to influence that. Similarly, research along with it has to be supported. Again, the research findings needs to be disseminated, not only the people on whom the research has been done, because that is the ethical responsibility. We are not giving them anything else, but the data is for our benefit. We need to tell them what have we learned and what they can change. Similarly, the policy.
Ma'am, I'm sorry, I would give you 30 seconds only.
And then the community. So all have to work hand in hand. That is why we have in our institute, we have a scientific advisory committee, we have an ethics committee, and we have a community advisory board who work together. When a research is completed, we make sure that these are disseminated to the right people. We ensure that people from the policy, administration, and others are there together to contribute to that. I hope that you're.
Thank you so much.
Thank you so much, ma'am, for your talk. Now I quickly will invite Dr. Shweta Rawat, scientist, DRDO, to come on stage and deliver her lecture. Since she is a friend, I would request her to be a little brief. Dr. Shweta Rawat, working as a scientist staff in Defense Institute of Physiology and Allied Sciences, Delhi. She has lots of accreditation and credibility in her back. She has granted 2 international patents Recently, she has been awarded as National Award for Young Women showing excellence through application and science and technology for social benefits by Honorable President of India for her work towards development of full body protective gear for female engaged in riot control situation. She and her team was honored with prestigious Agni Award for excellence in self-reliance on Technology Day 2022. Shweta is a friend. We started career together and we cherish our memories. Thank you, Shweta. Dice is yours.
Respected Chair and Co-Chair, good afternoon. I am, first of all, my greetings from my institute to Amity. I am from DRDO, and most of the time, people ask me what anthropologists do in DRDO. So I'm very happy to tell you, anthropologists are really contributing in a big way in DRDO. Although we are only 2 anthropologists in DRDO, but I tell you for sure, we are indispensable. Because to anthropologists, I need not tell that even the small LCA cockpit, if they have to design, or a BMP tank you all must have seen in this parade also, they cannot be designed without an anthropologist involvement. And I'll yes, ma'am, I was involved in BMP2 study. I'll share my experiences. I'll share the work which we have done, and to my I would like to involve all of you in the end in one of my projects where I'll ask for your suggestion. Although we have solved the problem, but I'll be waiting for better suggestions. Okay, so let's move on. It's like Madam has shown one aspect of the women, and I'll show the powerful women. I'll be talking about the women who is engaged in riot control situation, the women who is powerful, who is actually protecting us. So I'll be talking about Sabla, and later on I'll talk about Prabala. Okay, the story, I'll start from Sabla, I'll end at Prabala, right? Okay, let's move on. Okay, yeah, before I talk about my work, I'll talk about a Sweden study. You know, there are some crash dummies. What are crash dummies? Okay. When they design cars, they check it for the safety purpose, but they cannot put asli आदमी को बैठा के तो नहीं test करेंगे ना crash. So they test using the dummies. Usually they used to take male dummies and they used to test it. होता था, बढ़िया से होता था. लेकिन सबसे ज्यादा जब स्टडी की गई, विमेन ड्राइवर्स का प्रॉब्लम ये नहीं है, ये मत बोलना कि विमेन ड्राइव अच्छा नहीं करती हैं. The problem is कि जो placement है, the clutch, the gears, everything is according to men's anatomy and anthropometry. They haven't considered us. Chalo, forget about it. Second is we are co-passengers always, but they never considered placement of even airbags according to us. Can you believe this? I'll show, this is a recent study published in November 22. Very recent study. Sweden. They did this study and they thought this time we should consider female. Number आ गया उनका. So we should make a female dummy mannequin और उससे हम crash check करेंगे. बहुत स्मार्टली मैन को छोटा कर दो, फीमेल बन जाएगी. बनती है मेल को छोटा करने से फीमेल, बट बनाई गई. आपको दिखाती हूँ मैं. उन्होंने ये देखा. I mean, I hope everybody is comfortable with mix this. Okay. So they saw that they just made a dummy using the male mannequin. They just made it shorter and they conducted all the tests. All the tests for the crash dummies were done, and finally the car was made. And then when it was actually tried, they found it was useless. All things were done again and again using the same dummies, but they were not able to see that dummy which they were using, actually that resembles only a 12-year girl. Because the male को जो छोटा किया था, वो जो बनाई थी, she was 48 kg, 4 feet 8 inches. ऐसा तो 12-year girl ही बनेगी. So finally, they understood the importance of anthropometry, and this dummy, 62 kg, 5 feet 3 inches, she was made after an anthropometric survey, and they acknowledge that importance of anthropological data is very, very crucial for designing of any product. So this was a preamble for my study. Now, about I need not talk to anthropologists regarding this. I'll skip this slide. All this anthropologists know even much better than me. Yes, this is one of my favorite slide. They say, thoda chota, thoda bada kya? But when the ease of use, this is invisible until it is okay with you. But its absence sure isn't invisible, right? So I'll now talk about the protective ensemble for female troops. Story began in 2016 when in Parliament this question was raised by an MP, and she asked that we are deputing our female soldiers, our female troops in riot control situation, in all kind of situation, but what about their protective gears? Will everybody agree with me that no such gear is available even worldwide? Why I am saying worldwide? Because I have got international patents. And I'll come to that story later, but that protective gear is nowhere available. What females are using? They are using the male's protector, the protector which already males are using. So we got this letter from Rapid Action Force. Have you seen all Neeli Vardi wale? Seen? They are Rapid Action Force. So we got this letter from Rapid Action Force and they wanted us to make a protective gear because it was compulsion from Upar. They wanted us to make a gear bana do bas. So we thought, let us understand the problems first. So when we talk to female officers and female troops who are actually engaged, and I asked, male protector mein kya problem hai? Acha to hai. They said, madam, we act as zombies when we are wearing it because our hand, elbow joint is here, so I cannot fold my hand. My knee joint is on my thigh, so I cannot fold my leg. So I wear this to show to officers only, and when I am in action, I don't wear it. Because otherwise, to lathi bhi nahi maar sakti hu. I can only do like this, and that I do only in front of officers. So when in actual action, I rely on my strength rather. I can use lathi, I can run at least, I can save my life. But using these protector, male protector, I cannot do it. So we found there were so many problems further. So we found that even the smallest size of the protector, male protector, was not okay with 95th percentile. I hope everyone is okay with percentiles, right? So even the smallest size was not okay with 95th percentile women. See what will happen with that protector. And this was the protector which the lady is wearing. She is wearing the male protector. See, the upper part is coming to her thighs in the first photograph. Can you see? In the second photograph, please see the knee joint. It is coming on her thighs. And elbow joint, you can see it is on here, on her upper arm. So this was in no way. And moreover, her sensitive parts, because female body is entirely different from male's one. So her sensitive regions were exposed. So there was no point wearing in that. So we worked on that. We made many designs, software analysis, 2D, 3D, of course, anthropometric data we collected from the user population. And then this is what we made actually. This is my Prabala. So she was Sabla, and now the protector she is wearing, our director has named this gear Prabala. You will be soon seeing our Neeli Vardi wali females wearing this Prabala, then you remember me. Okay, so this Prabala word is embossed there also on her earlier. Do you know what's the male protector's name? Like females one, I told you, this is called Prabala. Males one was Anjali. You can read in the first photograph, it's written Anjali. Actually, the one who made this first time, her daughter's name was Anjali. He wrote Anjali. So now they'll say Anjali hai ya Prabala hai. So Prabala sounds more powerful, no? So that way. So this is not just anthropometry work. This anthropometry is crucial part of it, but this protects us from the stone pelters, because the riot control situation, there are lots of stone pelters. They throw acid bombs. They're very intelligent. They take a used bulb and they mix 2-3 kinds of acids in that and they throw. and then bike chain, ye chain, wo chain, everything is very comfortable. So what we have made, this is anti-stab, this is anti-puncture, this is anti-impact, this is fire resistant, acid resistant, and safety features are slightly better than males, never compromised. So good fitting and safety features perfectly, rather I'll say better than males one. So now another where I'll be involving you all. So इसलिए focus more. We were given then again, अब जब लगा कि भाई ये तो बड़ा अच्छा बन गया, अब हो गया कि जो भी लेडीज के लिए कुछ बनाना है श्वेता मैडम को कॉल कर दो. अब बोला शील्ड बना दो. मैंने कहा यार शील्ड में हमने क्या करना है? अब बताओ शील्ड बनानी है. शील्ड जानते हो आप? ये पॉलिश लिखा होता है ना, शील्ड. पहले केन शील्ड यूज होता था. अब these days they are using polycarbonate shield and also the polycarbonate लाठी they are using. Why polycarbonate लाठी? Why not वो लठ? Why not? बताओ. चलो मैं बताती हूँ.
उसका इम्पैक्ट वो हाथ से छूटने का वो नहीं रहता है.
एक्चुअली
टूट जाता
हाँ, एक्चुअली यही है. एक्चुअली ये लोग हमारे ही अपने लोग हैं, है ना. जो ये बॉर्डर तो है नहीं, हमारे अपने लोग हैं. तो उन लोगों को आप ऐसे पब्लिकली हर्ट नहीं कर सकते. हर्ट तो करते हैं, लाठीचार्ज तो अभी भी होता है, लेकिन आप ऐसे नहीं कर सकते हो. तो आपको कैमरा में नहीं आना है. दिस इज द लाइन विच आई एम सेइंग. यही मैं आपसे अभी सवाल पूछूंगी. एक्चुअली उनको कैमरा में ये नहीं दिखाना है कि हम किसी को मार रहे हैं, ठीक है. इसलिए पॉलीकार्बोनेट लाठी जो कि व्हाइट है, पूरी ट्रांसपेरेंट है, वो यूज करते हैं कि मारेंगे भी तो भी कुछ ना कुछ तो हाइड हो जाएगा. और दूसरा, पॉलीकार्बोनेट लाठी से कभी हड्डी नहीं टूटने वाली, तो वो कोई प्रूफ नहीं रहेगा. तो इस टाइप का कुछ सिनेरियो है. ऐसे ही शील्ड है. अच्छा, अब शील्ड और लाठी पे आते हैं वापस. शील्ड और लाठी में हमने फिर वही पूछा, भाई क्या प्रॉब्लम है? तो बहुत भारी है, बहुत बड़ा है, ये है. विमेन तो पूरी कवर हो जाती है उसमें, इतनी बड़ी है वो, क्योंकि मेल का हाइट बहुत लंबा लोग सेलेक्ट होते हैं ना आरएएफ में, तो फीमेल भी लंबी सेलेक्ट होती है, लेकिन फिर भी मेल से हाइट में छोटा है. सो अब मैं आपसे पूछना चाहती हूँ, प्लीज आई वांट ओपिनियन ऑफ ऑल ऑफ यू. द क्वेश्चन इज, द लेडी टोल्ड मी कि मैडम हमारा एक प्रॉब्लम ये है, जब हम लाठी यूज करने जाते हैं भीड़ में, सो तो जो लोग हैं हमसे लाठी स्नैच करने का कोशिश करते हैं, और एक बार लाठी स्नैच हो जाती है ना, तो बहुत ह्यूमिलेटिंग है. इट्स वेरी ह्यूमिलेटिंग एंड आई डोंट नो हाउ टू स्टैंड देयर फर्दर. सो उसका कुछ सॉल्यूशन हो सकता है? ऑल्दो लाठी डिजाइनिंग से तो वो क्या रिलेटेड है, बट आई वांट अगर ये प्रॉब्लम सॉल्व हो सकता है. सो एनीबॉडी बताइए प्लीज. अभी उसको मैं वहीं पे आपको बताना चाह रही हूँ. उसमें हमें फर्दर वी वर इंस्ट्रक्टेड बाय द ऑफिशियल्स दैट वी कैन नॉट इंक्लूड एनी शॉक, any blade, anything like that, because अगर किसी को भी शॉक लग गया और उसने प्रिटेंड भी कर दिया कि उसको हार्ट अटैक आ गया या गिर गया है, तो इंक्वायरी पक्का है. तो आप उसको नॉर्मल बोल रहे हैं, अगर वो गिर गया, अगर उसने ऐसा प्रिटेंड भी किया,
there is a suggestion, Dr. Shweta. We can have a kind of stick which has a attachment and through that the stick will go.
एक्चुअली उसमें डेंजर थोड़ा ये है, क्योंकि वो पुल करने वाला बहुत जोर से पुल कर रहा है. अभी तक तो लाठी जा रही थी, फिर खुद भी चली जाएगी. वो भी थोड़ा, क्योंकि वो प्यार से पुल नहीं कर रहे हैं ना, और वो तो उसका तो मकसद ही वही है कि उसको इंसल्ट करना है, उसको हर्ट करना है. तो द वे दे, यस मैम प्लीज. It's already there, ma'am. Still they can. It's already there. I'll show in the pictures. I'll show you.
ये ऐसा हो सकता है, क्योंकि मैं हाथ में यहाँ पे बांधने की नहीं बात कर रहा. अगर you take that forearm और यहाँ पे लाठी के बीच में, मतलब इमरजेंसी सिचुएशन के लिए उसका डिटैचमेंट का एक ऑप्शन है, so that if somebody is dragging, so the person can clip and detach it. और अदरवाइज
सॉल्यूशन नहीं हुआ ना कि वो खींचे ना उससे, वो छीने ना उससे. वो बताओ, फिर मेरे लिए सब ताली बजाओगे पक्का, मैं सॉल्यूशन बताऊंगी. हाँ, एक मिनट मैम. हाँ मैम, फर्स्ट थिंग इज दैट वी डोंट वांट कि वो हमसे मेरे लाठी छीने. It is a good solution, ma'am, but we were on the first step कि पुल ही ना करे.
तो उसको शॉर्ट करा जा सकता है लाठी को, देयर इज अ फोल्डेबल काइंड ऑफ,
वो फोल्डेबल लाठी का ऑप्शन हमारे पास था, पैराशूट लाठी टाइप बोलते हैं, बट वो वीकेन करती है उसको, जहां भी जॉइंट है वो वहां पर स्ट्रेंथ नहीं है, और लाठी टूट गई तो बहुत बेइज्जती है। तो वही, इट्स ह्यूमिलेटिंग, देन इट्स डिफिकल्ट फॉर हर टू स्टैंड देयर, हाउ कैन शी कंट्रोल दैट क्राउड, वो तो उसका लिए बहुत मुश्किल है। और अगर वो गिर गई, जैसा उसमें अगर वो गिर गई, क्राउड में रूल पक्का है, अगर आप गिर गए आप बचोगे नहीं। आई डोंट नो मैम, पता नहीं रोल अप करने से कैसे होता है।
तो मे बी जहाँ पे वो पकड़ रहे हैं खींचने के लिए, उसका कुछ मॉडिफिकेशन कराए so that they cannot grip it.
हमने पहले हमने बड़े स्मार्टली बोला सर, उसके आगे वो जो दिखाते हैं ना, उसके आगे ब्लेड लगा देते हैं, ऐसे ब्लेड निकलेंगे, ऐसे लगेगा। उन्होंने कहा भैया किसी को हर्ट मत कर देना, नहीं तो नौकरी जाएगी। चलो मैम, मैं अभी इसको बताती हूँ, अभी हमने बहुत सिंपल सा सॉल्यूशन किया, पर अभी नहीं बताऊंगी, अभी आगे बढ़ते हैं। थोड़ा शील्ड के बारे में बात करते हैं।
5 minutes
अच्छा सॉरी सर, मैं बातें ही ज्यादा करती रही मैम, हो सकता है, लेकिन अभी मैं वो बताती हूँ जो हमने किया था, ठीक है। पहले लेकिन शील्ड की बात करती हूँ, ठीक है। शील्ड में द प्रॉब्लम वाज इट वाज वेरी हैवी। 5 मिनट है मेरे पास, जल्दी जल्दी बताती हूँ। शील्ड इट वाज वेरी हैवी, तो उसको हैवी बिकॉज पॉलीकार्बोनेट डालना है, उतना स्ट्रेंथ डालना है, इतना रिजिड टेस्ट होता है, ऊपर से फेंकेंगे, फिर उसके ऊपर स्टोन फेंकेंगे, टूटना नहीं चाहिए। अगर उतना टेस्ट करना है तो मिनिमम आपको थिकनेस पॉलीकार्बोनेट की यू हैव टू मेंटेन, राइट। सो इफ यू मेंटेन द सेम थिकनेस, देन हाउ विल यू रिड्यूस द वेट? Then they say कि मैडम हमारे लिए हल्का करना ही करना है। So we thought corrugated, you know corrugated things, जो शेड होता है, जैसे टिन का भी हम देखते हैं, they are made corrugated. Why not flat? वो सब तो ठीक है कि वो उसमें कुछ रुकेगा, वो सब ठीक है, लेकिन corrugated फिजिक्स का वो है कि अगर आप corrugated कुछ भी बनाएंगे उसका स्ट्रेंथ ज्यादा होगा। तो corrugated हमने उसको बनाया ताकि स्ट्रेंथ वाला पार्ट आ जाए। अब दूसरी बात प्रॉब्लम आ गई, corrugated तो बना दिया, देख रहे हैं तो उसमें से दिख नहीं रहा। अब अगर शील्ड में से, ट्रांसपेरेंट शील्ड में से अगर दिखेगा ही नहीं तो वो कैसे करेगी? तो अब उसमें और स्मार्टली एक्ट किया कि ऊपर का 1/3 पार्ट को कर दिया फंक्शनल एरिया, यानी उसमें से देखो, नीचे वाला कर दिया कोरुगेटेड, क्योंकि लाठी नीचे पड़ने का चांस ज्यादा है। ये है एंथ्रोपोलॉजिस्ट का दिमाग, ठीक है। आगे बढ़ते हैं। और दूसरी बात, हमने सोचा हमेशा उस लाठी को, शील्ड को ऐसा पकड़ के वो लोग मतलब करते हैं सिचुएशन। किसी ने नहीं सोचा कि राइट हैंडेड है तो क्या है, लेफ्ट हैंडेड है तो क्या, पूरी दुनिया को एक ही तरीके में हाँका जाता है। सो वी मेड इट एम्फीडेक्स्ट्रस, लेकिन दैट इज नॉट इजी टास्क। मैं अभी पिक्चर दिखा, अगर मेरे पास वक्त होता तो मैं सबको कहती बना के दिखाओ एम्फीडेक्स्ट्रस। थोड़ा मुश्किल है क्योंकि लोड शिफ्ट हो जाता है। जैसे ही आप हैंडल्स को प्लेस करते हो, ऐसा कर देते हो, वो नहीं कर सकता, कैसे पकड़ेगा? और ऊपर से देयर टास्क इज दे हैव टू मेक अ वॉल। बाहुबली में देखा था, वो उससे वॉल बनाते हैं। एक्चुअल सिनेरियो में ऑल्सो वो शील्ड से वॉल बनाते हैं। जब ऐसी सिचुएशन होती है, दे हैव टू मेक अ वॉल। तो वॉल ऐसा पकड़ने से और ऐसा पकड़ना पूरे टाइम पे कंफर्टेबल नहीं है, तो भी एम्फीडेक्स्ट्रस बनाना है। वी मेड इट। अभी आपको दिखाऊंगी क्या बनाया था, ठीक है। सब कुछ एंथ्रोपोमेट्री के हिसाब से हुआ, ज्यादा टाइम नहीं है इसलिए जल्दी जल्दी बता रही हूँ। ये है हमारी जो फाइनली शील्ड बनी है। इसके अंदर एम्फीडेक्स्ट्रस है। ऊपर वाले जो आप देख रहे हैं, पॉइंटर से नहीं दिखा पाऊंगी, ऊपर वाले जो टेढ़े हैंडल्स लगे हुए हैं, दे आर फॉर द ग्रिप। लेकिन ये जो नीचे वाले स्ट्रैप्स हैं, इनके थ्रू आप उसको पकड़ रहे हो ना, ग्रिप इज बेटर। आपका ये सारा पार्ट कुशन्ड है। लॉन्ग आवर्स में इट्स वेरी कंफर्टेबल, क्योंकि कोरुगेटेड हो चुका है नीचे वाला पार्ट। स्ट्रेंथ नेवर कॉम्प्रोमाइज्ड। ऊपर वाले पार्ट से आप बहुत अच्छा देख सकते हो, कहीं से विजन नॉट कॉम्प्रोमाइज। इसके ऊपर मुझे बहुत अच्छा एप्रिसिएशन मिला है, ठीक है। लेट्स मूव ऑन। अभी देखने में बहुत सिंपल लगता है, लेकिन जब मैं बोलूंगी ना डिजाइन करके दिखाओ, अभी एक और टास्क देकर जाऊंगी, ठीक है, ऐसे नहीं जाऊंगी। अब लाठी की बात करते हैं। तो लाठी में हमने क्या किया, थोड़ा सा प्लेसिबो डाल दिया हमने उसमें। अब देखो, इसमें आगे से थोड़ी सी व्हाइट दिख रही है, वहां पर बहुत तेज स्पार्किंग होती है, अंदर लाठी के अंदर हो रही है। लेकिन क्योंकि ट्रांसपेरेंट है, दूर से देखने वाले को नहीं पता चलता है कि वो असली है कि नकली है, कि अंदर है कि बाहर है। और उसमें साउंड बहुत तेज है। मैंने खुद, जो हम लोग जानते हैं, हमने उन लोगों के आगे भी ट्राई किया, करंट लगेगा भाई, हाथ नहीं लगाना है। वो इतना तेज साउंड आता है उसमें कि मतलब ऐसा लगता है कि स्पार्क है बहुत तेज, और स्पार्किंग दिख भी रहा है। तो जो दृश्यम है वो ही सच है, जो दिख रहा है वही सच है, तो कान से सुन भी रहा है। तो अभी कोई भी उस लाठी को छीनना तो छोड़ो, छूने की भी कोशिश नहीं कर रहे हैं। ठीक है, काली बदनी थी यार। चलो, तो ये लाठी भी प्रबला बताया मैंने, शील्ड बताई, लाठी बताई, ये सब उसका फीचर्स हैं। कभी ये सब उसका मैंने आपको बता ही दिया मोरओवर। इसमें मुझे बहुत सारे पेटेंट्स मिले हैं, नियरली 20 पेटेंट्स हम लोग कर चुके हैं। और आई एम हैप्पी टू शेयर, कल ही मुझे एक और ऑस्ट्रेलिया ने पेटेंट ग्रांट किया है और यूएस का पेटेंट हमें बहुत जल्दी मिलने वाला है। थैंक यू, थैंक यू। और ये वो था रूपक जिसके बारे में बता रहा था माय फ्रेंड, वो प्रेसिडेंट अवार्ड था जो। और हाँ, मोदी जी को ये प्रोडक्ट बहुत पसंद आया था, आईजीपी कॉन्फ्रेंस में उन्होंने ये प्रोडक्ट देखा था। प्रबला को लॉन्च, जब प्रबला हमने बनाया था उसको डीजी सीआरपीएफ ने उस टाइम लॉन्च किया था। और हम लोग उसको फिर जब हम कोई प्रोडक्ट बनाते हैं तो हम उसको, क्योंकि डीआरडीओ प्रोडक्शन एजेंसी नहीं है, हम लोग सिर्फ उस पर रिसर्च करते हैं। देन वी पास द टेक्नोलॉजी टू इंडस्ट्री पार्टनर्स फॉर द बल्क मैन्युफैक्चरिंग. So we have already transferred this to 10 of our industry partners. The product is already available on GEM. सब कुछ बहुत बढ़िया, ऑलरेडी स्टेट पुलिस ने ले लिया है, सीआरपीएफ ने ले लिया है, ऑलमोस्ट ऑल सीआरपीएफ एंड स्टेट पुलिस हैव बॉट इट. आप बहुत जल्दी देखोगे जो स्टेट पुलिस और नीली वर्दी वाले स्पेशली, वो लोग इसी आपको गियर में दिखेंगे. थैंक यू सो मच.
Thank you, Dr. Shweta, for such an engaging talk. I just hope you prepare some gear for husbands also.
They have, yeah. I'll just tell this. After this Prabala was very hit, just 2 days back I got this letter that ma'am, males are requesting कि हमारा अंजलि बहुत पुराना हो गया है, we want redesigning.
चलिए, okay. Thank you, Dr. Shweta. Anthropology is a science, ma'am.
Ma'am, I study botany. Yeah, I did my, I had physics, chemistry, biology. Yes.
Yes. Thank you very much. So, I would request Dr. Rituja, she's online, to come on and come to the link, come to the platform and deliver her lecture on facilitators and barrier for effective implementation of National Tuberculosis Elimination Program in India. Dr. Rituja Patil, who is also my colleague for several years, a research scientist in KEM Hospital Research Center, Pune, has been pursued biotechnology and turned into public health researcher at Vadu Rural Health Program in 2010. She did her PhD in global health from University of Edinburgh, based in Edinburgh, Scotland. Initially focusing on developing a molecular biology laboratory, her latter collaboration with diverse team of health and demographic surveillance system, indoor air pollution, digital health, has put her into perspective of global health. So over to you, Dr. Rituja. We welcome you to the podium. Thank you very much.
Thank you, Dr. Rupak. So I sense that there must be question what a biotechnologist is doing in this forum of everyone filled with anthropology background. So I would also like to mention that Dr. Sanjay Zuekar, to whom you have all heard in the morning, he is my mentor, and my co-presenter, Ms. Kajal, who has helped me preparing the slides, is also an anthropologist. So being with the anthropologist team for last 15 years, I've got a lot of perspective while working in public health. And this small presentation, which I'm talking about, has a lot of anthropological perspective used during implementation of this study. And that's why I'm here to present the study. This presentation is a small part of a ICMR funded implementation research, where in this we are talking about the facilitators and barriers of effective implementation of a program for TB elimination. So we all know TB has been there since many years. The earliest written mentions of TB in India are almost through 3,500 years ago, and it still remains a problem There are millions of deaths which happen on a yearly basis in the world. India in itself accounts for 27% of the global TB burden. And given all the scenario, given so much of interventions which are available, very good interventions and medicines where TB can be cured, still it remains a major public health concern. And what are the ways where we could really curb this problem? So, few of you might know that Government of India has planned to it envisions that to eliminate TB by the year 2025. And what is that? What are some additional steps we could take to help in delivering this vision for India? So ICMR came up with this idea where we invest some anthropological solutions and some novel strategies to implement the NTEP program, which is a TB program. And as you know, TB has many social dimensions. There's gender, there's socioeconomic status, there's also implementation issues with the ground level staff. And hence, adding this perspective might really help in better implementation of National TB Elimination Program, which is NTEP. So we conducted this study near Pune in a block which is called as Ambega block, and here you could see that there are some tribal areas, some rural areas, and some semi-urbanized areas. So this is a typical picture of Pune blocks where there are some semi-urbanized area and rural area, and this being a tribal belt as well, has some hard to reach difficult areas and has high burden of TB in this area. So we decided that let us work in this block of Pune district. And these are the people whom we mapped across. So mapping is another anthropological technique we used for identifying our stakeholders, mapping them as per their power and influence. And we created an extensive list of all these people, which included doctors, healthcare workers, ashas, patients, their contacts, and private practitioners being the most integral part of our health system, those practitioners and hospitals and pharmacies. So we mapped all these people in the block, and we went to them and conducted some in-depth interview, some interactions, some observations, which are, I mean, you people are more aware than I am about all these techniques, where we interacted with all these people to understand what are the realities and challenges in implementing the NTEP program. So these are in the further slides, I'm going to explain what are the strengths and barriers of this program, which we understood using the in-depth interview and most of the qualitative research part. So NTEP, as some of you must be aware, is a well-structured program, and it's trying to reach hardest to reach population in the community. It has well-defined staff responsibilities, very good infrastructure is available, good diagnostic facilities, very sensitive diagnostic facilities are available, which are also very specific. There is good supply of medicine across our district, and there's good IT digital health platform, which is a Niksha portal available for NTEP. Despite availability of all this information, this program is still suffering and has challenges in implementations. And in my next slide, I'm going to say why. And this is all we have realized from the data which we have collected on field using qualitative methods. So as in every public health institution, this program, the staff under this program are overburdened with multiple disease program. And if you look into ASHA's workload overall, almost all government programs are relying on ASHAs to collect basic data. However, they are very overburdened, and those things need to be considered when giving them additional opportunities. There are very fewer training sessions for the NTP staff. There was lack of standard training for the staff in order to enhance the diagnosis and treatment of TB. While interacting, because our team also had quite a few anthropologists during the data collection, there were very personal interactions with the health systems people, and there they kind of given some information which probably wouldn't have been provided otherwise. So they realized that there are frequent transfer, there are no facilities for the staff, especially the NTP staff who are the contractual staff, and that's why there are major challenges in implementation of this program. Although people want to work, there is acceptability of the program. Still, there are challenges where these are personal level challenges for the health system staff, and although these are very specific to our area, I'm sure there are similar challenges in other states and districts as well. And hence there is inadequate implementation of the program, especially for coordination between the teams, for coordination between the lab team and the medical team. And that is where our team is, the project team is now hand-holding the healthcare system staff to address these challenges. So these are some more challenges. There is lack of counseling and follow-up for referral of the TB cases, lack of attentive counseling on adherence of the treatments, and also TB preventive therapies for household contacts. And there are multiple recommendations based on all these challenges we have come across, and we have provided this recommendation to the health system, and we are working with them to find solutions to all these challenges. So there are presumptive cases who are still unwilling to provide sputum samples because TB is still a stigmatized disease. Overall, as any other health issues, there is less awareness of the program within, and especially in the private sector, the practitioners are not aware of the facilities which government provides for TB. And there are underdefined systems for involvement of private practitioners in the area. So, sorry. Okay. So these are some recommendations. We are working with the health systems now to work on these recommendations and making the health system staff and the NTEP program staff to take actions on the barriers which we have realized. And we are now working on training and retraining the health system staff, give them defined job descriptions, and also help in interaction and coordination between the teams. So there are certain gaps which our team is helping them to identify and work on those. We need skilled personnel to focus on TB related activities, and our district administration has started working on identifying such person. We also need training of private practitioners, which is a very important step, because the private practitioners are totally not aware of any of the TB guidelines and programs in the area, and they are also not registered on the Nikshay portals. And hence, involving them in countries like India, where 60% of the population first approaches the private practitioners. So that is something we are considering to work on. We are also trying to help and establish communication channels between the private practitioners and the program staff. Most important component of any program is the community, and we are involving the community leaders and politicians and the local leaders, like they were involved in during the COVID response in rapid diagnosis and treatment of TB. We are also and this is something very interesting. The screening and farming activities should be coordinated. So this is through the lens of anthropologists, we realize that this is something needs to be done, because the programs were happening all around the year, but then we realized there are dips in diagnosis and screening during the farming season, wherever there are farming activities happening in the area. And this is a very unusual recommendation with the health systems staff realize that this needs to be taken into consideration when they are planning any community level activities. We have also helped them design some reward system for successful completion of TB treatment, and have informed about the health insurance demand from the health system staff. These are some more recommendations which we have provided to the health system, where the PHS staff, the public health system staff, along with the NTP staff, should conduct monthly meeting to monitor the TB related activities. And this seems to be a very simple step, but this was not being done at all. So there was no communication between the NTP staff and the public health system staff, the primary level staff at all regarding the TB program. And this small monthly meeting, or so small interaction during their regular monthly meeting, has helped them resolve so many issues at the block level. There are recommendations around continuous supply of good quality consumables, and certain other things which were available in the block but were not used and underutilized, like the X-ray vans. They are also now suggested to be used by the health system staff. We have also suggested some standardization in terms of visits by the district personnel, which was a major challenge seen by the health system staff, where they thought that people are ignoring, or the district teams are ignoring the program. And this periodic visits have also helped in increasing the moral of the NTP team. And a few more generic suggestions were also given to the program people. So this were also taken up. So that's all about the program. These were the people involved in the conduct of the study. So the district TB officer, public health system staff, local private practitioners, and ICMR has funded this study. So that's all from me. We are planning to publish this as a paper. So this is the list of contributors who are part of this paper. Thank you.
Thank you, Dr. Rituja. And in fact, I compliment you for finishing this talk 6 minutes before. And this is really.
I'm unable to hear you, Dr. Rupak.
Yeah, thank you. Thank you very much. So now we move to the next participants, Dr. Manoj. So we now invite Dr. Joita Kushal Roy from Department of Anthropology, Narasingha Datta College, Howrah. This is my parental college, where from this college I have done my BSc and then moved to Delhi, obviously. Dr. Joita is an eminent researcher in anthropology. She is currently serving as assistant professor in anthropology. She did her work on congenital malformation and syndromic disorders, and also worked in myriad aspect of women and child health care. She did her training in genetic technologies and forensic application through DNA analysis from Central Forensic Laboratory, Kolkata. So podium is yours, Dr. Joita. Thank you very much for attending the conference. अरे तुम सुनो, ये लड़की अमृता डॉक्टर शांतनु संगुप्ता उधर गए हैं, उनको लंच करवा देने के लिए किसी को बोलो, उसको बोलो करीना।
Good afternoon. There is some technical glitch, obviously, of sharing with Google Slide and Google Link. So I'll just skip the slides and I will just give an impromptu lecture. And since we are running short of time, we are always talking about health issues, gender disparity in health, and the population burden, and lack of proper implementation of family planning, whether it is being implemented correctly or not. But the first adverse effect of reproductive health first was brought into focus after Second World War, when Japan faced the atomic bomb scenario. The first people became aware that the adverse reproductive outcomes can be in the form of different congenital malformations, which involves different systems like musculoskeletal system and many others. So that was the first time when health policy makers gave some attention to the problem of what happens to the adverse reproductive outcomes like miscarriage, stillbirth, incapability of conceiving, and sterility, both in males and females. This is where the health policy formation and policy making comes into focus. In India, the articles in Indian Constitution, articles 39E, 42, 47, 41, and 21 recognize right to health as a fundamental right. And since we are all in the G20 phase, the reproductive health is being considered as in a health emergencies in the form of prevention, preparedness, and response, with a focus on microbial resistance and One Health framework. Now, microbial framework is a when we are considering reproductive health adverse outcomes. In the reproductive health adverse outcomes, we have the communicable problems and the non-communicable diseases. Now, non-communicable diseases section, 60% of the death in maternal health is accounted for that, where the genetics, the behavior, environmental, and physical influences play a considerable role in the maternal health and reproductive outcome. Now, in 2021, the new health policy has been formulated, which has focused on the rare diseases. Now, what are rare diseases? Rare diseases has been defined in different countries in a different based on different incidence rate. US has defined rare diseases with an incidence of 1 in 20,000. In India, it is 1 in 10,000. But the rare diseases cannot always be accounted for, because, as the previous one of our speakers said, there is a culture of silence regarding reproductive health and the reproductive outcome when it comes to women. We generally are ashamed to share our reproductive history in proper light, even with the medical doctors. So there is always a gap between what is actually happened regarding miscarriages, inability to conceive, and what can be solved with proper healthcare policy intermediation cannot be availed by those mothers who direly need it. In the new health policy, the disorders have been classified according to one-time treatment with stem cell therapy, then disorders which can respond to organ transplantation, like those involving liver and kidney, disorders requiring long-term, lifelong treatment, like special dietary formula or hormone therapy, And then the first time the health policy has focused on centers of excellence or Nidan Kendras, where these type of disorders will be identified, and under these Nidan centers, some more centers will work as mentor group to solve these issues. The mentor institutes will be LHMC in New Delhi, CDFD in Hyderabad, AIMS New Delhi, CMC Vellore, MAMC New Delhi, SPGIMS Lucknow, and NIIH Mumbai. And these mentor institutes will have one district in focus, so that they can properly deliver the detection by using high-end detection centers. Now, this health policy can, the intervention of health policy from ground level, like in the district level to the higher level, is essential, very essential, because screening is very important for this detection of these rare disorders, and also for proper genetic counseling, so as to respond, so that the proper care can be given to these mothers, and adverse outcomes can be in more ways be controlled. Thank you.
Thank you, ma'am. Super quick lecture and yet comprehensive. So thank you very much. I would hand over to Dr. Manoj to conclude the session and give a comprehensive overview.
Yeah.
Over to you, sir.
Yeah. Thank you all, I think, all speakers for taking us through about different issues coming from the global aspect to the national and also very local aspect, and starting from very generic to very specific type of issues which we heard about. We started with the session from Dr. Dalal, who talked about the empowerment and different patient and provider relationship, the issues and the power dynamics, then differences and the challenges, and some potential implications for the urban and rural context and the relevance for Indian context. Then we moved to Dr. Neeta, who talked about the HIV infected special groups and the women, their challenges related to the healthcare and also the other social related rights and the preferences and the discriminations to certain extent what they experience. Then we moved on to Dr. Sweta, who talked about use of anthropology in the protective sector, like Prabala, who and the development of the woman-centered protective gears. Actually, we should talk about that, not the individual-centered, but woman-centered, and development of the tools and the different issues. Then we heard Dr. Rituja, who talked about the healthcare provider and the patient care related issues related to the tuberculosis and the inputs for the tuberculosis elimination program in India, specifically from a rural context of Maharashtra. Then we heard from Dr. Joyita about the rare diseases and congenital malformations, which have different issues and challenges. Although she talked about the specialized centers which are there in the India for this care, but one issue I would like to also highlight and would like to emphasize the anthropologists to look at, which the biologists may not look at, the environmental and social issues which are there related to the origin of congenital malformation, not the consequences and the care. Okay. So these issues give us good food for thought, and now I think the food is ready. Rupak is telling that you have walked and now you should go for food. Now we close this session. Thank you so much, and thank you, the organizers.
Thank you very much for all the participants to participate. I hope we have covered all the sessions for this particular session, and We will get back to the other participants after the lunch. Thank you very much. Excuse me, everyone. Just hold on for a minute. We would be felicitating all the invited lectures over here.
Okay. Now I'll request Dr. Manoja Kumar Das to facilitate Professor Kaustav Dalal. Then Dr. Neeta. Dr. Neeta Mawar. Dr. Shweta Raval. Dr. Jaita. Now we break for a lunch. Ma'am, there's no. Okay. I'll request Professor Rumi there to please facilitate our chair and co-chair. Thank you. Now we break for a lunch, and after lunch we'll have the afternoon session. So we have afternoon session on critical perspectives on culture, health, and disease. So with us right now, we have the chair with us, Dr. Kalyan K. Ganguly, who's a former Deputy Director General, Indian Council for Medical Research. Dr. Kalyan Kumar Ganguly is a renowned anthropologist who devoted his professional life in advancement of the subject beyond academics. He pursued MPhil and PhD from JNU in social medicine. He has contributed significantly as an anthropologist in many important scientific initiatives by the Government of India. He has served as a scientific committee member of many crucial quantitative national-wide studies. Dr. Ganguly has contributed to more than 40 scientific writing in various peer-reviewed journals, books and book chapter. He is the first social scientist to receive Professor B.C. Srivastava Foundation Award in recognition of exhaustive ethnographic study of opium users of deserts in western Rajasthan. He has been recognized as a distinguished fellow of Indian Public Health Association by Indian Public Health Association Kolkata for his contribution in public health. He was also honored as a visiting fellow at the University of California, Los Angeles, Now, with us, we have co-chair Dr. Kalindi Sharma. She's an assistant professor in IBAD, Delhi. Dr. Kalindi Sharma is as an assistant professor in Institute of Human Behavior Allied Sciences, Government of India, Delhi. She has done PhD in anthropology from University of Delhi. She specializes in teaching social and cultural anthropology and had done teaching experience in various institutions, including Amity University. Dr. Kalindi has published over 10 articles in the reputed journals. Her research interests are anthropology of disaster and extreme weather events, climate change, gender studies, society and institution, and visual anthropology. So I'll now request to chair and co-chair, please come on dais so that we can start on the session. Chaired as Dr. Kalyan K. Ganguly, sir. And co-chair as Dr. Kalindi Sharma.
Good afternoon. I think after post-lunch, it will be heavy, but I'm sure Professor Shalina won't make it so heavy. So, and I know she gives good talks, and I think she'll entertain people here through the discipline. And it is, I think it will be good to listen her and whatever presentation she does. But before I just give a brief about her. She has an MSc PhD from Delhi University and taught sociology in economics, Delhi University, before joining Punjab University, Chandigarh in 77. She taught there for 39 years, served as professor for nearly 20 years. She has been recipient of several national and international honors and awards. Some of her achievements includes Senior Fellow SSRC, and that is Social Science Research Council, New York, under the South Asia Regional Fellowship Program, funded by Ford Foundation USA and expert guest professor in gender studies in the University of KwaZulu-Natal, South Africa. She has more than 80 research papers published in national and international journals. She's author of 5 books and 4 edited volumes. Her publications are on ethnicity, gender, tribal studies, and medical anthropology. Sounds very interesting, the areas she has been working on. And now that she would be talking on medical anthropology precisely because this would be critical perspectives on culture, health, and disease. So I won't take much time and stand you and yes, wherever you want. It's free for you to.
Thank you. Thank you very much. Thank you so much, Professor Ganguly, for introducing me, which of course is an exaggerated statement of what we do as practicing anthropologists. I've been doing it for nearly 50 years now, almost, from the day that I started. And as he mandated, I'm here only to entertain you. Shromi Dev was insistent that I come here, and I possibly couldn't have disappointed her. I have never called myself a medical anthropologist, quote unquote, because my training in anthropology says you begin with holism and you end with holism. So you can't divide a discipline into compartments and assume that you have a specialization or a core specialization and that you want to designate yourself as so and so, a medical anthropologist, a political anthropologist, a linguist, or come what may. My journey, I have of course done few studies, I would say, on health or issues relating to health. And the point that I wish to make here is the difference that exists between the biological determinants of health and the cultural determinants of health. There is a misnomer, and I recollect very well that in 1992, when I started working on HIV/AIDS, the question that was always put to me was, are you a doctor? And obviously my answer was that I do have a PhD to my name, but I'm not an MBBS doctor. So the other side said, what are you doing here? This is not something that you should be dealing with. The question was not new to me because when I did my PhD on Hindu-Muslim relations in Delhi, in Sada Bazaar of Delhi, the political scientist would ask me, oh, from which year to which year? And I would say I'm doing a contemporary study, studying empirical relations between Hindus and Muslims living in Sada Bazaar of Delhi. So here again in 1992, the same question is posed to me, what are you doing here as an anthropologist? My answer was very simple. I said, as I understand HIV, it was just the beginning years, it is a behavioral issue. And who else is more competent to deal with it than we, the anthropologists? Because I think we understand behavior better than my very, very dear and close friends with whom I've spent a lot of time in hospitals as a patient, as my doctor friends too. The reason being that when you look at a particular deviance, as I may not agree with it, but as Parson said, there any kind of sickness is a deviance. And if it is a deviance, then what is it a deviance from? Is it a deviance from some kind of a very standardized behavior? The answer that was given to me about HIV was, you know, we in India are a very, very, we have monogamy and we follow all these norms and practices. So there is no possibility of India ever having HIV as a pandemic or epidemic for that matter. And when we started arguing that that's not the case, and honestly, it took us years to convince even the people who were managing National AIDS Control Program that you just can't do it without having anthropologists on your rolls. I'm proud to say today that at least 40 to 50% people who work in the IAC today come from anthropology. So at least that acceptance has come where you realize the cultural connotation of a disease. Being sick and being diseased are two very different things. You can be sick, but you need not show it. About 2 weeks back, I evaluated a PhD thesis for JNU. And this bright young girl had plethora of narratives that she was trying to analyze. These were of women laborers from South India who were working in the fields. And these women said, even if we have pain, even if we have high fever, even if our back is breaking, we can't say we are sick. And you had to understand that why is it so that they were saying we can't call ourselves sick? She said, I say I'm sick and not going to work, who is going to feed my children? So it's not her physical sickness, it's not her physical disease or her physical ailment that defines her reflexive understanding of what it means to be sick. She said, the moment I say sick, and the person says, oh, you don't want to work or you're not giving your best, therefore you are going to be underpaid or you're not going to be given the full amount. But this is really a harsh reality. A large number of these young women also talked about what they go through after childbirth. They go back to work immediately. They have backaches. They have all kinds of issues, but they can't afford to take leave. Because if they take leave, who is going to earn for them? So here is the perception, here is the difference between you are not being well and not really stating that you are not well. So sickness and disease have to be looked at very, very differently from each other. Let me come to a very basic understanding of how I look at it. And even here is a situation of people, women coming, especially for women, because there is a huge gender discourse when it comes to understanding the holistic perspective of health in totality. Women are told from early childhood, girl child is told from early childhood, that, you have to endure a lot of pain in your life. So therefore, prepare yourself for it. And don't say that you are experiencing pain. So pain is not really something which is physical. Pain is something which is not only experiential, but has been socialized or ingrained into yourself. So you keep controlling it. Men are told not to express their pain because it is against the notion of masculinity. If you don't interpret these things and you're doing a study of a health behavior of any kind, these are going to be bottlenecks, barriers that you got to understand. In a hospital situation, for example, I'll share my own personal experience. I had an acute attack of acute pancreatitis way back in 95. I happened to be the chair of the department, and I had acute pain for 3 days, but I refused to go to a hospital because I had 2 young children who were going to school. And I was a chair, and there were certain issues that we were dealing with in the department. So I couldn't afford to stay away from there. I chaired the meeting for 6 hours. I was vomiting constantly. Still, I refused to go to the hospital across the road, which was PGI. Till I got a telephone call from my brother-in-law and said, I want an opinion from a neurosurgeon in PGI. So please take me there. The neurosurgeon was a very close friend of mine. When I reached the hospital to get that second opinion for him, my friend, my Rakhi brother, he looked at me and he says, "What's wrong with you?" I said, "I think I have a food poisoning for the last 3-4 days. I have acute pain." He stopped me there and then and called a gastroenterologist who was just walking out of his room and going for lunch. And he says, "Well, just see, she doesn't look well to me." He touched my stomach and he told her, "Well, send her to ICU." Now, what was I doing? Denying pain because I thought there were other priorities. And there was a team of doctors who looked at me to call those, did all the regular tests and said, "Well, there's no way we can save her." I was in my early 40s. And 2 children in school. So I said, "Well, I can't die." 3 days, PGI struggled and said, "No way, we can't do it." So I was brought to Delhi, to AIMS. They said there's only one doctor who can do something about it. Now, what was the difference? The young doctors, those 1.5 to 2 months I spent in ICU, every morning they will say, "Oh no, I don't think so, she's going to last the day." And then would come my surgeon and say, "No, she wants to live." And even with all those tubes and with nothing literally left in the body, I wanted to struggle because I had 2 children and I wanted to bring them up. So he said, "Look, here is a patient who wants to fight it." So the parameters may defy it, the disease parameters may defy it and say there's no way she can survive, but then let us give her a chance. So I must thank them. They took excellent care of me, and I'm here almost 30 years down, standing in front of you, believing in myself, in my ability to recover, and in my doctor's ability to believe that he will be able to cure me. Now, if you were to dissect it and move away, the biological from the social, cultural, psychological, do you think you can really have a holistic perspective on health? Anything that you're doing, anything that you're trying to study today in the name of medical anthropology. There's one last story that I wish to share because we were already running behind half an hour. And please tell me when you want me to stop because I've been a professional teacher all my life. So this story, the last one that I'm wanting to share here with you today, while we were doing researching on quote unquote disability, we don't use the term. We find the term very derogatory today. And I had a special interest in understanding what happens to people who have intellectual challenges. I always use this term, people who have special challenges. Now, how do I understand that? Being a social anthropologist, my training says narratives, narratives, narratives. Unless you have narratives, unless you read those narratives, you are really not in a position to come out with the gist of it. So what do I do? How do I collect narratives from people who have intellectual challenges? So we evolved a method, something that we borrowed from philosophy and said, okay, since we can't talk to them, we will talk to their primary socializers, the primary caretakers, who will tell us their stories, who will be able to give us what we called as, Martha Nosumdun was the one who gave the term, and she says this is called narrative imagination. Who else could imagine but the primary caretaker who was taking care of these patients or these people who were suffering with intellectual challenges? Now, the challenge or the story that I wish to share with you here, and as I hope some of you will be coming for the main Congress in Bhubaneswar, where we are organizing a special session on gender exclusion and talking about some of these stories. This is about a young woman who was kept in a shelter home in Chandigarh and was, as happens with most of these patients women, people with intellectual challenges, she was raped several times over. And that too with the help of two women caretakers of the shelter home where she was staying. We've come a long way from calling them lunatic asylums and things, and even shelter homes, which I think is a much abused term. This young woman became pregnant, and obviously the understanding was that she can't have the child. So she must undergo an abortion. Nobody wanted to ask her because the assumption was that she is not in a position to communicate. She is not in a position to share what she wants. She was so adamant. She refused to undergo an abortion. She said, I want to have the child. The matter went to the court. Court, of course, in their wisdom, appointed a committee of the experts comprising of medical professionals, legal professionals, and they all said no, she must have this abortion because she can't bring up the child since her mental abilities are only that of a 9-year-old. Now, here is a case. Well, to cut the long story short, she won the case in Supreme Court because of the support of some people that she had. I met her. The child is almost a teenager now, living an absolutely normal life. This woman has changed, who has this intellectual diagnosed disability to such a great extent that she understands, she talks about what she wants her child to become. She has she's meticulously clean and wants to keep her surroundings clean. All this change happened after she gave birth to a child. The medical opinion says she should not have had the child. Now, here is a termination that occurs because there is a founded belief, and you as students who are going to study health and health behavior must understand that there is nothing established either in medical science or in any other allied branch. It's a continuously, perpetually changing reality. So when you go and talk to people in medical institutes, to nursing staff, the only message we as anthropologists want to give them is that unless there is a empathy emanating out of your persona, and you are not abusing and accusing, especially cases, COVID, you must have seen. All the stories that you've seen, the loved ones would not take their own for burials. Outsiders would do that, but they would certainly remove their diamond rings and make them put thumbprints on the will to get the property in their name. Now, unless the primary caretakers take this perspective, we started facing it from the time of HIV. The challenge that you have to confront is that when there is this distance being maintained at various levels, whether it is in the hospitals or it is at home, or there is an understanding of an ailment which says it can be contagious, and you put the people away, you start discriminating, you marginalize them, you've already put them in a bracket where, as Parson says, they will remain sick people. So please, as a social scientist, my only plea to my young students sitting over here is this, that don't go by the textbook all the time. Experience what happens around you. Your advantage as students of anthropology is that you go to the field, you learn, and then you come and write about it and talk about it. So even the most complex issues can be translated into simpler terms for others to follow. Thank you so much.
Thank you. But brief at the same time to the point.
I can go back to my.
Quite succinct. I mean, only thing, the last point she said that do write what you think you feel, mind it, your teacher should be acceptable to that. As I said, frankly, in Hindi, आपने रट्टा ही नहीं मारा, आपको number कहाँ से दे देंगे? How can you write your own things? It's not so liberal here, you know. I know in the West it is pretty liberal. If you justify your thought, fine, you'll get numbers. But here तो वही है ना कि हमने फलाना किताब पढ़ाया था, आपने पढ़ा नहीं, उससे आपने लिखा नहीं. How can I give you a number? So that's the only thing.
No, I think I replied on this. Honestly, I think my message to my students is always, please don't give me the topic. Tell me what you.
That's good. I mean,
I'm sure my voice is loud enough to reach everybody. If you come there, there's another very important thing we are about to discuss, this new education policy. And as I read more and more of it, I keep going back to Tagore. And I keep going back to Tagore because what we are trying to achieve is precisely what he did so many years ago. And we didn't follow him because we thought the Western model of education was the best model of education. So the experiential learning, the story of these women laborers that I had shared with you, honestly, till I read her thesis, I couldn't imagine that this was happening with people. I thought it would happen because, when your house help goes on leave saying she's not well, you say, okay, maybe she just wants a chutti. So that's what the experiential learning is, that how you look at the other person. So if what you write challenges my own understanding, I think that's the best paper I've read. If it conforms to what I have taught in the class, sorry, sir, you've not read at all. So if I walk into the classroom without a book in my hand or a notes in my hand, and I'm talking to you, obviously I'm not able to recollect every word of what I should have conveyed you in that particular topic, but I'm leaving it with a message to you that, look, this should be the basic understanding. So please get out of your mindset. Those of you who are teaching here, with due apologies to them, please don't put your students in straitjackets. Let them experiment. They have enough ability to do so. We just have to provide a platform to them and not stop them from doing that. In any field of research, innovation is what? It's reinventing. And how do you reinvent in this era of cyberspaces? So there's so much information which is lost in knowledge. And where is that knowledge which is lost in? Wisdom. So we are no longer wise. We only have information, a plethora of information that we are not using up to its optimum potential. Thank you, sir. I hope I've answered your query.
thank you. And as I said, she will entertain you. And she has. Because offbeat something she has said, now you take it or don't, that is up to you. And yes, Professor Shalna, this is what Jiddu also said, Jiddu Krishnamurti, you must be knowing. He has done all that area, all along doing this. And in fact, if you see in Delhi, Mothers International, Aurobindo's, they also do the same thing. I wish this perpetuates in higher learning too. And yes, let them flourish, let them come up with what you want to say, but yes, with justification. They can justify what they have said and why they have said. That's perfectly all right. It's not that you got to be, as she said, that straitjacket, streamlined, run-of-the-mill product should come out from you. That shouldn't be the case. And that one should do. And otherwise, that, that what she talked of that connotations of health and sickness, is really a very, very nebulous area where you need to work hard and find out that where that starts, where that begins, where is that gray zone, and where, I mean, probably the medical fraternity goes with the black and white, they don't go with the gray zone. Probably you and I got to sit down and see that what is that gray zone you need to decipher and find out that which is for the use, which has to be taken. It's all, everything is not black and white. Your sickness connotation cannot be black and white. Ailment cannot be black and white. Disease, dis-ease is a disease. So what is dis-ease? We always say disease. So we don't know what is ease. If you do not know ease, then how can you talk dis-ease? So that the problem is that there is something which is in a very nebulous, where you just really cannot find out what is what out there. The anthropologist who has been working in this area should look into that and try to find out that, look, here is the strain, the string which you need to really pick up and find that this is where you have to tie up the whole story with. It's if you're just going for the black and white, you many a time cannot really web the net, you cannot make the story round and round and round, and you just cannot come out with something. So I won't take much time. When you and Professor Rabiul Chaudhary from Kumilla University, I welcome you for your presentation. So before you start, I'll just give you a brief about you. So because you know who are you, we don't know who are you. So Dr. N.M. Rabiul Chaudhary is working as an associate professor in Department of Anthropology, Kumilla University, Bangladesh. Along with teaching, he has contributed in various development research projects as consultant with different national and international organizations. He is also experienced to work with well-reputed national and international organizations like International Center for Diarrheal Disease Research, Bangladesh, Holy Kormosh Higher Foundation Center for Injury Prevention and Research Plan International, and BRAC DRC Research and Evaluation Division as full-time professional. Dr. Rabiul, core areas of work are teaching, research, training, monitoring, and evaluation, report, writing, the documentation, program design, planning, and management. His research interest is focused on health system, non-communicable disease, reproductive health, behavior change interventions, impact assessment, and others.
Okay, I would like to start with thanking you, the chair and the co-chair. And before going to my slides, it's an opportunity to show my gratitude to the organizers. I would like to show my gratitude as well. So already you know you already heard about me and my name. I would just like to repeat that. My nickname is Robi, and I'm the Dean of Faculty of Social Science, Kumilla University, which is in Bangladesh. So I would like to start with saying that the topic of my speech is on non-communicable diseases, and sharing with the latest statistics is in every 2 seconds, one person under the age of 70. I mean, that is what we call premature death. In every 2 seconds, one person under the age of 70 dies for non-communicable disease. And the percentage is 86% in the LMICs countries. So these statistics basically saying about the severity of non-communicable diseases nowadays in the global or in the world. And health is not only a health issue. It's a huge barrier and bottlenecks for economic and comprehensive development as well. And by 2030, the SDG 3.4, they had a target to reduce the premature mortality by 1/3 for non-communicable diseases. And these are some statistics that globally more than 71% deaths are for non-communicable diseases, and which is basically increases nowadays, and it's about 74%. And these are also some statistics, and these are the top 4 non-communicable diseases, which started with CVD, cancer, diabetes, and COPD. Now, these are some statistics to see the background. Now I'm going to the main points. So as the NCD is most severe health burden in globally, and also in the situation is very severe in low and middle income countries, especially in South Asia, because of the population density. So it's not my fault, it's technical. So let's back to the earlier slide. Oh, it's not working. Okay. So now come to the main points. The point is, the statistics basically say that the non-communicable disease situation is very alarming, very severe for all over the world, and especially for the South Asian countries because of population density and other things. And that is why WHO take a global action plan to manage and control the non-communicable disease. And the plan was basically, they had a vision, they had a goal, they had some objectives, they had some voluntary targets, and blah, blah, blah. And if we just had a look to the objectives of non-communicable diseases put out by the WHO, the objective is basically talking about strengthening the health system, doing some researches, developing some strategies, and other relevant issues. Now the thing is how we can basically respond to the non-communicable disease, and how we can basically reduce the disparities, the health inequality. Because as I said, that NCD is not only health. NCD health issue is not only health issue. It's something more than health, and it is connected with not only one SDG target. It's connected with more than nine SDG target directly or indirectly. Now the responses pattern. As we know that, as I shared earlier, that the situation is very severe in the LMIC's countries, but the responses are more not up to the mark to those countries who have less non-communicable disease situation. Now where being an anthropologist we can contribute. The contribution area is what are the risk factors. If we look at the risk factors, there are various type of risk factors. Say we can divide the risk factors in 2 parts. One part is biological and another part is social, or what we call cultural or social factors, which is basically modifiable, because you can't change your biology, but you can change your behavior. And through changing the behavior, through working on the behavioral risk factor, which you can modify, but you can't modify your biological and other issues as well. So if we want to modify the biological risk factors, which is basically talking about 4 risk factors, I will be coming on. Now the thing is, working on the biological risk factor, there is a traditional approaches of changing human behavior, working on different issues, that how people can change their behavior. Like for a long time, globally, people wanted to change the behavior of hand washing. And the theory was germ theory. If you don't wash your hands after defecation, there is germ and you will be suffering, blah, blah, blah. But it's not working. Whenever you was asking someone, did you wash your hands after defecation? The answer will be yes. But we know the true fact, the reality is a huge number of people don't wash their hands properly after defecation. So the germ theory is not working. Now, being an anthropologist, you have to develop your own strategy if you want to contribute, if you want to reduce the health inequality. And the area of contributing to reducing the non-communicable disease is behavioral risk factor. On that case, so someone from University of California, he was developing an approach. He called it shame approach, disgust and shame. As the germ theory is not working, then if someone come to me and he had a look on me that I was in toilet just after coming from the defecation, I didn't wash my hands, and suddenly I meet with someone, say PC Joshi sir, and sir said, "Oh, you did not wash your hands. I'm not going to shake with you because you had shit in your hands." So that is disgusting feelings, and he was trying to give me a shame. So the germ theory is not working, but new approaches that might be work. So that is what I'm trying to say. The anthropologist, being the social scientist, the social engineer, you can contribute, you can develop new strategies to contribute to manage the risk factor, especially not the biological risk factor, but the social risk factor. Then what are the risk factor? Modifiable risk factor. There are top 4 modifiable risk factor, which is approved by the WHO. There are 4 things. One is you can promote physical activity, you can promote healthy diet, you should control having tobacco, and you should control not having excessive use of alcohol. So these are top 4. These are top 4 modifiable behavioral risk factor. All we know, but we don't change. As all we know that we have to wash our hands after defecation, but we don't change. We don't change our behavior. So how we can change our behavior? That's my point of my today's speech, to develop new strategies, new approaches, and new ideas on contextual base. Maybe you have to address a lot of variation. Say in Bangladesh, when we were introducing the family planning methods, there are a huge barrier because most of the people are in Bangladesh is Muslim. Then there were few social scientists who were trying to promote the reproductive health practices with bringing the religious issue. There are also another successful program of immunization. And it was successful because the immunization program, there are few social scientists who were trying to bring some other social issues which is effective. So finally, the situation of Bangladesh is, it's from communicable to non-communicable disease as all over the world, and they are also facing double burden. But as the disease burden changes, the health system should change and adapt with the changing pattern. But still the LMIC's countries, especially India, Bangladesh, Pakistan, and South Asian countries, the health system is not adapting with the changing pattern. Still in our country like Bangladesh, our health system is mostly focused on mother and child health. But our disease burden completely changes. And the policies taken by the government is not addressing the issue. Like more than 75% of our people are living in the rural area. So if you want to promote if you want to manage, promote, or control the NCD, you have to address the people who are living in the rural area. But still the support and healthcare services are centralized in the capital. So people have to move from rural to urban area, and this is also creating social health inequality. And I would like to share the last statistics from the risk factor survey, which is basically it's in 2010, a little bit later on. So the thing is, almost 99% people are having or suffering or have opportunity of one risk factor for non-communicable disease in Bangladesh. But still now the country is not addressing not taking initiatives for addressing the NCDs. So the thing finally I would like to say that it's time to work on, it's time to contribute, being an anthropologist, to address the severe global health burden that is non-communicable disease. And being an anthropologist, all of we can contribute to doing new research, to developing new strategies, and and to bringing new ideas how we can develop effective interventions so that people can change their behavior, because we can't work on biological factor, but we have the opportunity to work on, to contribute on behavioral risk factor, which is social. And that is all from my side, and thank you so much.
Thank you, Professor Chaudhary. It was small and sweet, and it's true that non-communicable disease is a problem worldwide, particularly with developing nation nowadays. So what he has been stressing is that even points like issues like defecation and then hand washing, that is also a basic thing which is lacking. It's not there. I mean, we have seen even in doctors here, we have organized many seminar workshops to see that they are taught for hand washing, nurses and doctors. How many of them remember the proper hand washing while going for his OT or going for ICU? Does he know exactly what the steps to be taken before he enters or she enters? We found that it was around 70% have forgotten that what is the approach to wash the fingers, wrist and palm properly, stepwise. So if they have forgotten, poor fellows in villages, I really don't blame them. But yes, you have to entice them some way or other. Don't take my word entice as a pejorative. But yes, you have to do something by which that they can really understand that why they should do it. It is basically that if we do not really from our inner core try to understand that why should I do it, I'll not do it. If I'm told it's not right at my back of my brain that I got to do it, it's somehow I must do it. So then only you'll do it. So problem is behavior cannot be thrusted upon. Behavior we try to thrust upon by modules and other things. The point is they have to be brought into that chain where the behavior has to start developing of its own. And it has to be within that context itself. And our problem is we try to thrust behavior of what we know. It's not his or her behavior. It's our behavior we want to thrust on them. That's not the way. If we really know what is their behavior, that means again that old participant observation and whatnot and whatnot. So if we thoroughly know them, then only we can think that, yeah, this is what they need to do and they should do. I mean, what do we do in the PLA, participatory learning appraisal? We give the baton to them and let them work for themselves. We are not to thrust how they should do change their behavior. Thank you. Thank you once again. Yeah, please.
Good afternoon, everyone. So we shall begin with the oral presentations now. Each presenter may take around 10 minutes for their presentation. So the first presentation, oral presentation, is by Dr. N.K. Mungrafi, Assistant Professor, Center for Anthropology. Her title of presentation is The Effect of Obesity on Pulmonary Function. Okay, so we'll have, if the members of the audience have any questions, we'll take them at the end of all the oral presentations.
Please note down whom you want to really ask the question. Because after the whole thing is over, then you please ask it. Otherwise it may protract along.
Respected chair and co-chair and the dignitaries and everyone present here, well, good afternoon to you all. The title of my presentation is Effect of Obesity on Pulmonary Function, a study among Tangkhul Naga males of Manipur. Actually, it's a part of a data, like it's actually my study is both on males and females. females, but the presentation here is just on the male data. So as we all know that obesity is a significant public health concern with a rising prevalence worldwide. Beyond its well-known association with cardiovascular diseases, as we have just heard earlier as well, and metabolic disorder, mounting evidence suggests that obesity is also linked to adverse consequences on the respiratory system and function. I'll just skip all this. Okay. So the effect of obesity on respiratory system have been increasingly studied. The accumulation of fat in the body causes change in respiratory physiology with consequent impairment on various lung functions and function parameters. Different pattern of fat, body fat distribution differentially and negatively affect the function of respiratory system. So the obstructive lung disease such as COPD are one of the leading causes of mortality in the world. The the diagnosis of COPD could be confirmed by the measurement of FEV1, FEC, FER, which is done by spirometry. Maybe in the methodology, I'll explain a little bit more. The objective of this study is to assess the effect of obesity on pulmonary function. So for this study, a cross-sectional research was carried out among 257 Tangkhul Naga males ranging in age from 20 to 70 years. The subjects were divided decadal-wise, 10 years interval each, to study the trend in all the parameters that were taken, height, weight, BMI, and the lung functions. So these are the measurement taken, height, weight, and pulmonary function test was carried out by spirometry, which measured a forced expiratory volume in the first 1 second, forced vital capacity, forced expiratory ratio, which is the ratio between the FEV1 and FEC, and peak expiratory flow rate. So I think I will not explain all those since we do not have much time. Okay, okay, a bit on the subject. Tangkhul Naga is one of the subgroup of the Naga tribe. The Nagas inhabit in the northeastern part of India as well as in the western part of Myanmar. So the Tangkhul belongs to Mongoloid stock and linguistically they belong to Tibeto-Burman language family. Manipur is inhabited by different ethnic groups and Tangkhul Naga is one of the major tribe of Manipur. And traditionally, the Tangkhuls were agriculturists and live a simple lifestyle and follow their traditional religion known as the Hau religion. But the advent of Christianity among the Tangkhuls in the latter part of 19th century, around 1890, 95, around the time, the introduction of Christianity plays an important role in the transformation of their belief system, traditional practices, and also Western education was introduced along with the coming of the missionary in the region, which is the key to development and socioeconomic change in the community. With urbanization and economic advancement, there has been a major shift in their occupation and improvement in their socioeconomic status and lifestyle, and a major nutritional transition has been observed over the years. So these are the basic data of the subjects. We see that the mean height, weight, and BMI here. So the mean height is 162 centimeter, and then we see secular trend. Like we see in any other population, secular trend is clearly visible in the population. We see that the height increases. The mean height is highest among the youngest age group, which is 20 to 29, and the lowest in the oldest age group, 60 to 70, and it gradually increases in the younger age group. And as for body weight and body mass index, we see that it increases till the middle age group and slightly decreases in the older age group. And the prevalence of obesity is 1.6 overall, and obesity is present in the middle age group, and overweight is present in all the age group, and the mean is 16%. Prevalence of overweight is 16%. So these are the mean of the lung function in different age group and in different BMI category. It might not be that visible, but I would just like to share you the trend here. So we see that the lung function, FEV1 or FEC or FER or PEFR, is best in the youngest age group, and the values are all lowest in the oldest age group, which is understandable, which is the effect of age. But we see an interesting finding in the when it is analyzed in different BMI categories as well. We see that both underweight and overweight has an impact on the lung function. It's not just the overweight, but both undernutrition and overnutrition has negative impact on all the parameters, the FEV1, FEC, FER, and PEFR. So we see that the mean value is highest among subjects with normal BMI, and in most cases it's followed by underweight. Comparing to overweight, of course, underweight has better respiratory efficiency, but the maximum impact is on the obese subject. And FER is assessed if it is less than 80 is classified as low, and above 80, equal to or above 80 is normal. So 10% of the entire sample have low FER. So this is just an ode to show how age and BMI is impacting forced expiratory ratio. So higher age group and those in overweight have higher odds of having less respiratory efficiency. Okay, I'll just quickly skip this, coming to the summary here. So BMI showed an association with pulmonary functions, with the lowest respiratory efficiency observed in obese subjects. Subjects with normal BMI demonstrate better respiratory efficiency than underweight or overweight subjects. Pulmonary functions parameters were more efficient in younger age and decline in advancing age. Age had significant positive correlation with BMI, but had significant negative correlation with all the lung functions parameter. And BMI had negative correlation with lung functions, and multinomial logistic regression showed that overweight and obese subjects had higher odds of developing low FER than those with normal BMI. So in conclusion, forced vital capacity and forced expiratory volume in the first 1 second, these are two crucial spirometric indices used to assess lung health, shows reduced value in obese individual compared to non-obese counterpart, indicating an association of impaired lung function and obesity. Both BMI and lung function were associated with age. Respiratory efficiency decline with advancing age. Understanding this relationship is essential for implementing effective prevention and intervention strategies to mitigate the impact of obesity on respiratory health and improve overall well-being. So the transition of Tangku Naga tribe, as I have mentioned a bit in the subject description, the transition of the Tangku Naga tribe in terms of their occupation, socioeconomic status, and overall lifestyle factors contribute to the escalating prevalence of overweight and obesity and also associated health issues. The rising epidemic is not restricted to highly urbanized society, but has now infiltrated even to the traditional tribes owing to their changing lifestyle. A different facet of the complex association between socioeconomic change, obesity, age, and pulmonary functions were observed in the study. Thank you.
Thank you, Dr. Mungrafi, for adhering to the timeline. Our next presenter is Dr. Rupak Mukhopadhyay, Associate Professor, Center for Anthropology, Amity University. His topic for presentation is Social Accountability and its Health Dividend, Experience of a Pilot Study to Scale Up Community Management of Possible Serious Bacterial Infection.
Hello, everyone. Good afternoon. I hope you have a great lunch session. So, I've given exactly 10 minutes, but effectively it would be 7-8 minutes within which I have to finish it. So, to start with, my intention of this presentation would be, reflecting how anthropologists are positioned in cutting edge public health research. And the current trend is in public health research is implementation science, how we improve the healthcare delivery in primary health setting or in specialized care like emergency care in a tertiary hospital. In all these aspects, anthropologist, I felt after working almost 7 years in implementation research, that anthropology, the knowledge of anthropology brings a very powerful tool. So it is not only molecular anthropologists who are, who can be proud of being, I started as molecular anthropologist. So that is a disclaimer. Vineet knows and everybody knows I'm from their lab and I'm very proud of that lab. So if that is one of the cutting edge, and so the implementation science and role of anthropologists in that. With that, I'll start with a very typical topic, what I call social accountability and its health evidence, which I experienced while doing an implementation research on possible severe bacterial infection, or there is a common cause of neonatal death. So neonatal deaths can be due to serious infection, very low birth weight, pneumonia, jaundice, birth asphyxia, and diarrhea. The primary question is how we can prevent them. Identification of danger sign obviously is the primary thing. Prompt care seeking to nearby and appropriate health facilities. In the morning, we have heard about care seeking, and then presence of trained and willing health staff at facilities where medicine and equipments are available. So these are the key points. So to deal with newborn deaths and newborn sickness, Government of India has a guideline which says that, Dr. Rabil was also mentioning that treatments are available in cities, but in rural resource poor setting in villages, we do not have treatments. So how do we deal with severely sick infants, newborns in a village from where maybe the hospitals are 50 kilometers, 100 kilometers away with specialized care? So on the travel, on the way, due to loss of time, critical time, newborn deaths are happening on the transit. So there is a delay of reaching in specialized care. So for recognizing that, Government of India come up with a guideline which says National PHI Management Guideline, that is possible severe bacterial infection, where with simplified identification of danger signs, those infants can be treated simply at primary care. And if they are not, or I mean, sorry, the with the simplified algorithm, the probable cause of sickness can be identified and they can be referred to government hospital. And if they are not ready to go to hospital, tertiary care hospital, they can be treated themselves in PHCs. But that treatment guideline has come in 2014, but for last 6-7 years, it was not being implemented. So how to implement that? How to deliver that guideline effectively in resource poor setting was the intention of that research. It was done in Palwal. It is 80 kilometers from Delhi. It's a resource poor setting. Nowadays, Palwal, New Mewat is very much on news. And then we did a qualitative research. To tell you briefly, we have done. And few key findings we had that says doctors in PHCs and CSCs hesitate to touch and examine and manage sick newborns. Second, A&M, that is auxiliary nurse midwife, they are the nurse in sub-centers who know the public health setting, they know about sub-centers. So they do not consider themselves the treatment provider. So if they do not consider themselves the treatment provider, how they can treat a sick young infant? You know, giving an immunization injection is different, but that is to a healthy baby. But treating with a gentamicin injection to a sick young infant who is 1 week old needs lots of courage. It's more than skill, it is the courage, the comfort and congenial environment in which a health worker is working in a PHC or in a sub-center. Then third, mother has poor skill to identify danger signs in their young infants. You know, in young infants, 1 or more, 2 weeks, 3 weeks old young infants, identifying danger sign is, I would not say difficult, but it is not common that mothers understand. They are the simple signs, but mother do not understand them. Furthermore, the community worker with whom we trust, like Ashas were meant to do the community mobilization. They never gave emphasis to counseling mothers to train them how to identify the danger signs, although they were trained to do so. Then sub-centers and primary health centers, they occasionally have any stock outs. So stock outs, unavailability of medicine is not a problem for PHC, CHC current days. So what needs to be done? After lots of, nexus planning and discussion, we have arrived into 2 components. Number 1, key nudge area of number 1 is knowledge to skill to competency transformation through confidence building amongst the primary healthcare providers. That gives them the sense of accountability. Number 2, empowering mothers to and communities for identifying their sick babies and sick cares and hold health workers accountable. So this is a kind of accountability framework. So if we look at the social accountability, it's very simplistic representation. It says accountability can be broadly defined as obligation of holding power to take responsibility for their behavior and action. It has a long path and it has a short path. The long path goes from voice of client reaches to policymakers, and policymakers prepare some guideline and send it to providers, and then provider provides service to client. It is long path. But the shorter path is that when client has their own voice with their awareness, that shows their power and they can ask for the services. So this is right-based approach. So their health seeking or health services, asking for service as their right. the knowledge where they can get the treatment, the knowledge that my baby is sick. Please look at it. That is your responsibility of the ASHA, is to come thrice to a mother after the delivery to their home and assess their baby's danger sign. And that baby, if that is sick, it is ASHA's responsibility to mobilize that mother to the nearest health facility. Doctor sitting there, it is their right of the mother that the doctor give proper assessment, counsel them, give them treatment, or send them to the tertiary care. So this knowledge is power, and that holds the center to accountable. Now, looking at it looks very simple, but it has several intricacy, resolution if you go deeper into the community. So that is what we have done in this research. First, we tried to look at the yellow box. This is a model we have tried to develop, accountability model for doctors. When doctors will feel accountable, they may deny their responsibility only simply because they are not confident enough. So giving confidence to the doctors is one way that they will be immediately willing to be accountable. So there are paths. For the shortage of time, I'll not describe this. We can discuss this separately. But three main components: integrated management of newborn and child sickness. That skill we tried to enhance. This is a government guideline. It's a very structured module to train the primary health facility providers. So that training we tried to look at the skill gaps and try to enhance their skill. Second, the health system incorporated mentoring visits to PHC and CHC. Now, this is new. PHC, CHC, then generally we see in a very remote location, doctors are not supported. But through the district management, we have created a situation where the pediatrician from district hospital, they visited PHC and CHC for mentoring. That gives enough confidence to the doctors and ASHA and ANMs. So that is the second one. The third component is strengthen enabling environment as PHC, CHC. So the medical officer in charge in PHC, CHC, they have engaged in such a way that they give confidence to the medical officer who is regularly sitting at the OPD. So special OPDs were arranged for them. So there are you can see sub activities that has been devised, and this has been done with an formative research. All those components has been identified through a formative research, and that has been done by a group of anthropologists who worked with me. They are my colleagues. Then at community level, so at community level, we tried to consolidate community voices, and we used already existing platform in the communities. We knew that if we try to establish some platform which is de novo, it will not be sustainable. So consolidating community voice, we use three aspects: awareness on how to identify danger signs, awareness on ASHA HBNC, that is home-based newborn care visits. So there is a scheduled visit, but community did not know when ASHA should come to them and what they should be doing at their home. So we did as community awareness programs through these various channels where this message were typically given to the community so that they understand. If the ASHA doesn't come to their home, they go to their ASHA, respective ASHA, and ask them why you did not visit our house. And then awareness of available treatment on PHC and CHCs. For longer time, when we started the study, not a single newborn were treated in PHC and CHC. So why people will come? But then when there were a training through district health management and through several medical colleges, then doctors were trained and equipped. Now there is a time to tell community that you should visit there, doctor will treat you. If they don't, then you can inform the health system. So this is another approach. So community meetings were done.
Just please conclude.
VHND meeting and everything, all we are not going through that. So ultimately, if you look at the coverage, within 2 months of thing, this has been done during the time of Corona. 70% of the newborn their age were noted, and 70% for the patients ages were noted, and we saw that 64% out of them between 12 months to 6 months. So this age group were never been treated in primary health facilities. If we look at the outcome chart, we see that newborn neonatal mortality was decreased by 10%. So this would be my humble submission that even we take some model of social accountability that could help us also get effective result in terms of health outcome. Thank you very much, everyone, for your patient listening.
If house permits, he provoked me because where I was working for a long time, he also worked in the same place. The thing which he said about that preparing Ashas, Hota, who was the Home Secretary, his brainchild, this Asha accredited social health activist. So there's nothing activism in this now left. They're neither activists nor health worker because they're overburdened. So we know that how we did that, using gentamicin injection by 8-pass lady. Because what we did, that we have seen that how they're taught to prick the needle in a brinjal. So a newborn tender skin is like a brinjal. How nicely and coolly you can pump in the gentamicin, that was taught to them. And that was taught to Ashas also. Actually, we did a precursor, a study in ICMR from Health Ministry, which led to the Asha. We call it a Sishu Rakshak model. We did it with Abhay Bang, who started this in Gadchiroli. He started this actually, that how this just 8-pass women can help. This all, you don't need rocket science for treating these people. And he also did that how cotrimoxazole can help ordinary diarrhea which children suffer from. You need not go in for a heavy dose other anti-protozoals. Cotrimoxazole itself can take care of. And in the same queue, Zafrullah Chaudhary also in Bangladesh did a wonderful job. I've read all his works, what he did for diarrhea and all. He just gave a passing reference. So it is a long story, so I did not go into all that detail. But it was interesting and provocating. Thank you.
Our next presenter is Dr. Tarun Joshi, Assistant Professor, Center for Anthropology. The topic of his presentation is Breaking Barriers and Fostering Inclusivity, Exploring LGBTQIA Identity and Healthcare Disparities.
I take this privilege to acknowledge and venerate all the distinguished invited speakers, chair and co-chair of the event, of the session. So I know there is paucity of time, so I would try to wrap it around in 10 minutes. So my watch is ready. So specifically this LGBTQIA plus community is on a lot of debate these days, specifically when you talk about this judicial hearings, or maybe the new Chief Justice taking much more interest in that. So basically, it is having a very long history that why we need to address this particular kind of issue. So when we say that LGBTQ community or this kind of gender and sexual ideology or identity, it's a new concept of the modern day living but we have anecdotes of such kind of individuals from the historic days. Even in the Vedic tradition, there are people which were giving separate names. For example, gay men were termed as kleba in Sanskrit, and lesbians as savairani, then transgenders as napumsa, and they use a particular term. I will come to all these categories. Like intersex is a very interesting category, in which so many individuals are falling, right? And whenever, according to the Sanskrit tradition, you are referring to the term napunsa, it is not only the one who is transgender, but the person who cannot reproduce. For example, those individuals which are sterile, individuals which are elderly, and children, they are considered as napunsa. So particularly when we talk about gender identity, so we could say that, okay, there is a lot of variety in human species, particularly when you talk about like different kind of skin color, different kind of hair type, different kind of, physiological or cultural characteristics. So the world is divided into binary system, inter alia, on the basis of sex or gender, involving male, female, masculine, feminine, and men, women. So basically, we limit when we talk about this entire diversity. We are talking about as an anthropologist. So I would like to say that whenever we are talking about sex or gender, we are limiting it to the binary setup, whether it can be a man or it can be a woman. But there was an interesting study by Alfred Kinsey, who gave a scale, 7-point scale, starting from 0 to 6, in which 0, he said that this person is exclusively heterosexual, and 7 is 6 is exclusively homosexual. So he said that most of the people lie somewhere in between, right? They could be feminine side of a man, and they could be masculine side of a female or woman, right? For example, you talk about different kind of energies, Ida and Pingala, right? Masculine energy and feminine energy. So now it is very interesting to note that since society is driven by stereotypes, and if anybody is trying to disrupt this stereotype, they are marginalized as misfits, and they are pushed to the margins by society. So when we talk about that, what are different kind of gender or sexual identities are, so on the basis of biological sex, it could be a male, female, or intersex, where sex is not determined at birth. There can be so many biological or congenital condition in which this can happen. For example, it can be male pseudohermaphroditism, sex chromosome mosaicism, or DSDs, like different sex development, Morris syndrome, Klinefelter, Turner, etc., trisomies or monosomies. So now, apart from that, the second is gender identity. A person could be men, woman, or certain communities, not only India, like we talk about the term Hijra, or we talk about the term Kinnar, or Jogapas, or Ravanis, right? So many categorization in different parts of India has been given to the recognition of the third sex, which there are certain other societies which give this recognition to the third sex. Mahu is one such community. There are certain Hawaiian communities which give recognition to the third sex. Then the other thing is sex role. Sex role, basically, whenever you're talking about a particular gender, we tend to associate gender roles associated with that particular thing. That what a man is supposed to do, or there are certain. So basically, from culture to culture, it varies a lot. So when you talk about, for say, there are certain communities in which father is more like a distant person, and in certain others, father is a caring person. So it depends from cultural to culture. So the roles could be masculine, feminine, or androgynous, or gynaendrous, right? Then when we talk about sexual orientation, the person could be heterosexual, then interested sexually in sexually attracted towards the person of the opposite sex, then homosexual, attracted to the person of the same sex, then bisexual, equally attracted to both the sexes, or he or she could be asexual, that is not at all attracted to any of the sexes. These are the biological conditions I have already gone through. Now the term gender, now sex and gender are these two terms which are used anonymously, but they are having a lot of, they are outrightly different terms. So particularly when you talk about gender identity, it's one's internal and psychological sense of oneself as male or female or both or neither regardless of sexual orientation. Now when we talk about that, how this sexual or sexual identity of obviously you can determine at birth, but when you talk about gender identity, so how this gender identity is being formed. So like we can take an example of the social construction of reality given by Peter L. Berger and Thomas Luckman. So we believe that okay, everything what we are, what is reality for us, it is being socially constructed. So it will change in time and space, right? It is temporary construct. The things or certain gender roles which we believe that okay, they are only for men. Now women are also participating in those kind of areas. So gender is a social construct. So there are some people who question their gender identity and may feel unsure of their gender or believe that they are not of the same gender as their biological sex or physical body. So specifically, this is clear when you talk about LGBT. LGBTQIA is L and G are obviously homosexuals. That is lesbian and gay. Then bisexual is there. Then transgender. Transgender is an interesting category in which so many people are falling, like transvestite, who used to like to cross dress. Then androgynous or gynandrous, for example, more dominantly male, but a little bit of femininity is also there, and or more dominantly female, along with masculine characteristics. Then gender queer. Queer is basically those individuals who are not sure about their gender identity, right? They are still confused, right? Then bigender is there. Sometimes they believe like that they are male, or sometimes they believe that they are female. Again, the social construction of reality, I've already told you. So basically, when these gender roles, which are socially constructed, are made available to other members of society to enter into and play out, the reciprocal interactions are said to be institutionalized. In the process, meaning is embedded in society. So whenever basically when we say that okay, we are following gender behavior as per the stereotype which are created by the society, we are said to be doing gender, right? So I was talking about that there are more cultures which identify this more than two genders. North American First Nation culture, two-spirited translation of indigenous term denote one who transformed or one who changes. Then South Asian cultures, Hijras or Kinnars, Yogapa, Aravnis. Hawaiian Polynesian culture, Mahu, biological male who takes or work and dress of a woman. Now talking about the challenges faced by this community, like criminalization of LGBT and especially homosexuality, like Article 377 you already know. So basically it is very interesting to note that there is a colonial baggage of Article 377. All the countries which were once under colonial regime, for example, Brunei, for example, Indonesia, those kind of places, they have the exact number, either Article 377 or Section 377, which criminalize homosexuality. But like it now, it is being decriminalized. Proneness of LGBT to HIV and AIDS and other STDs, parenting and adoption rights. So basically, there are so many psychological theories which are talking about the development of gender, how this gender identity is being developed. So particularly, like there is cognitive development theory. Then by Albert Bandura, then by Jean Piaget, there is social cognitive theory, social learning theory. So basically, they are talking about that children in their childhood, they imitate their parents, right? And through that imitation, they learn their culture and values. So basically, it is believed that when a child is going to have homosexual parents, so he may develop that kind of gender identity just by imitating his parents. That is the main issue that people are talking about, that okay, we can still allow homosexual marriages, but adoption rights should not be given. Then high suicide rates. Obviously, the life of LGBT community is quite stressful because they are trying very hard to be a part of mainstream as a variety and not other deviation. So it culminates to egoism in the community, which is leading to egoistic society because they feel disintegrated from the society. Mental health issues, social marginalization and alienation, poor family ties, lack of support system, violence, physical, mental, and sexual abuse, substance abuse, and overdose. So basically, when we talk about that on an average, this in a particular age group, the percentage of frequency of substance abuse.
10 minutes are over.
Over. So I will try to wrap it around in 3 minutes. So basically talking about healthcare disparities. So I know this is about, this entire seminar is about health. So PrEP, basically, what are these things that, okay, PrEP reduces the risk of getting HIV from sex or, so basically I did a study among 320 individuals in which 200 people were homosexuals, 86 were transgenders and 34 were bisexuals. So it culminates to like most of the people do not have the knowledge of PrEP, right? And obviously it is a costly thing in India, specifically this PrEP prescription for a month. It is costing around 3,000 to 4,000 rupees in India. Okay, so it is difficult for people from all the socio-economic backgrounds to actually have this medications. So some people had some knowledge and most of them were having incomplete knowledge of PrEP. Then depression, most of the LGBT community people were found depressed, and substance abuse. So most of the subjects in the categories were found using alcohol, following by the subject who were smokers. So the subjects tend to mix marijuana and sometimes hashish with their tobacco while smoking. Thus, cannabis-based smoking was present in certain cases. There are dangers of this practice as marijuana can cause schizophrenia and psychosis in already depressed LGBT community. However, as per statistics, in the year 2016-17, the national percentage of smoker was 28.6, and around 17% adults in the country were found consuming alcohol. Thus, both smoking and alcohol were more common among LGBT adults than national adults, where around 30% adults, LGBT adults reported smoking and 64 reported alcohol abuse. Susceptibility of LGBT community to STI, obviously, just because, specifically in the case of transgenders who are sometimes involved in sex work as well, and the homosexual community, just because of unnatural intercourse. So it can lead to mucosal damage and high risk of HIV infection and other STIs, obviously. So society ideation and the type of LGBT identity had a significant relationship. And there's so many effects of like sex reassignment surgeries, right? It is leading to urinary incontinence in F2M female to male transgenders and certain other issues in the male to female transgenders. Then hormone replacement therapy in transsexual. Now what is happening? It may lead to certain kind of cardiovascular diseases in the transgender community, but it is actually like relieving their gender dysphoria, right? And particularly when you talk about that, their psychological well-being or stress levels and anxiety levels were reduced after this hormone replacement therapy. So it was found that considerable considerable number of people were graduate and postgraduate, but their mean income is quite less when compared to other mainstream stereotypical male and female community. So I would like to conclude, or basically I would just give the suggestion that what could be done. The law enforcement agencies like police are to be made more sensitive towards dealing with LGBT people, as police is among one of the agency which is responsible for the abuse of and harassment of LGBT people. The workplace should be made LGBT compliant to make a healthy environment for LGBT youth. This would help in bring them into mainstream and will also educate fellow employees about LGBT community, which will eliminate myths created around the community. There should be nationwide educational programs for safe sexual practices explicitly for LGBT people and also for healthcare practitioners because it is found that they are more susceptible to sexually transmitted diseases, STDs like HIV/AIDS. There should be proper facility and counseling for the LGBT patients suffering from such terminal illness. This will help in limiting the spread of AIDS and STDs. The community is under tremendous stress and they are put to margins by society on the pretext of being misfits. They are trying hard for the recognition and variety and not other deviation. Mental health challenges are immense for LGBTQIA, and there is a special need to address this elephant in the room. I would conclude with that. Thank you.
Thank you. Our next, Tarun will be taking the question and answers at the end. At the end. Our next presenter is Mr. Vineet Chaudhary from Department of Anthropology, University of Delhi. The topic of his presentation is Adverse Childhood Experiences in Depression and Internet Addiction, an exploratory study among young adults of Delhi, India.
Thank you.
Maybe they have certain time to find out from them. I think this is here that will have
Chair, co-chair, erudite speakers, sorry, my esteemed speakers and erudite audience. Along with that, I would also acknowledge my super scared adrenal gland and very high cortisol level. Today I'm going to present a paper from my...
Vineet, I'm so sorry to interrupt you.
Go ahead.
You just have 5 minutes because we also have a valedictory session. So all the presenters henceforth have 5 minutes. Please wrap it up as...
All right, I'll take 4. Fine. I'm going to present a paper from my PhD. This is among the first ACE studies of India. ACE stands for Adverse Childhood Experiences. So I'm going to spend a little more on introduction and a little less on the conclusion because I need to introduce this topic to audience. So the topic is adverse childhood experiences. Now, adverse experiences are something that we can encounter at any point in life. For example, witnessing violence, then fight with a friend, losing a friend, session 3 of a conference, getting a PhD. But why adverse childhood experiences are important? So childhood is the time of increased plasticity. It is the time when we are most receptive, and it is the time when most of our systems, physiological systems, are under the process of maturation. So that's why these experiences are very, very important. These are the experiences that get biologically embedded. That means these experiences leave mark on your DNA in terms of epigenetic imprints. All right. So there are 3 major categories of experiences that we generally study. These are abuse, household dysfunction, and neglect. But apart from that, recently we have also started studying violence. So violence would include peer violence, community violence, etc. Now, as you can see the slide, there are many categories of experiences. At the by looking at this slide itself, many of us can can conclude that this is not the exhaustive list. And in Indian context, we may need more modifications because some of these are totally Western, but we lack Indian validated ACE questionnaire, and that's why I was forced to use this one. Now I'll directly jump to the aim and the conclusion. Before that, one more thing, why ACE is important. So this slide is very important. According to Lancet, ACE or adverse childhood experiences accounted for $748 billion loss to America itself. This is the amount that is around 25% of India's GDP. And this is per year. All right. So in my study, I tried to understand the relationship between ACE, depression, and internet addiction. What did I find? I found a dose-response relationship. So with the increase in number of ACEs, you can see the odds ratio for getting depressed is increasing from twofold. So I would want you to look at the middle column, twofold to sevenfold. So those who suffered from one ACE was at around twofold risk of depression. Those who encountered 4 or more ACEs were at sevenfold risk of depression. Now, if I talk about internet addiction, the same trend was there, 1.6-fold increased risk in category 1, and category 4, it was 4.26-fold increased risk. All right, I'll skip the discussion. I'll straight away go to the conclusion part. So even one single ACE could increase the risk of child depression and internet addiction in adulthood by 2 to 7 folds. Okay. What would be my suggestion? There are many I have enlisted. I'll stick with one. We need to create a trauma-informed society. So, adversities are not something that are restricted to bordering region of Kashmir, or it is not restricted to Naxalite-prone areas of say Chhattisgarh. We all, and as many as around 72%, according to my study, we have encountered one or multiple ACEs in our lifetime. And we need to recognize that, and we need to start working from there. Thank you so much.
Thank you, Vineet. Apurva, our next presenter is Ms. Apurva Sharma, again, Department of Anthropology, University of Delhi. She's presenting on polycystic ovary syndrome, prevalence and associated socio-demographic risk factors, a cross-sectional study among young adult females residing in Delhi NCR.
Good evening, everyone. Respected chair and co-chair, our senior professors, and all the people who are present here. Good evening to all. The topic of my presentation is polycystic ovary syndrome prevalence and associated socio-demographic risk factors, a cross-sectional study among young adult females residing in Delhi NCR. PCOS is a hormonal disorder that affects many young women. Despite being a common condition, it often goes undiagnosed and untreated. In this presentation, we will uncover the mysteries surrounding PCOS and provide a better understanding of its causes, symptoms, and treatments. PCOS is a hormonal disorder causing enlarged ovaries with small cysts on the outer edges. The syndrome affects up to 1 in 10 women of childbearing age. It can cause irregular periods, weight gain, infertility, and other symptoms. Causes of PCOS, the exact cause of PCOS is unknown, but genetics, insulin resistance, and inflammation may play a role. PCOS is often associated with high levels of androgens, that is a male hormone that females also produce, which can cause acne, hair growth, and other symptoms. Symptoms of PCOS can vary, but may include irregular periods, heavy bleeding, acne, hair growth, weight gain, and infertility. Early diagnosis and treatment can prevent long-term complications such as diabetes and heart disease. The present study aims to determine the prevalence and explore socio-demographic risk factors associated with PCOS among young adult females residing in Delhi NCR. There are very few studies which study about the prevalence, especially in the region we have selected. So the methodology we used I used the cross-sectional study design. The sample size was 1,164 females of age 18 to 25 years. We collected socio-demographic data from them from pre-tested interview schedules. PCOS cases were selected on the base of self-report. That is the females who were already diagnosed with PCOS, and the other ones were selected based on the Rotterdam criteria. The results of my study show that there was a 14% prevalence, which was found in the studied population. When we associated the socio-demographic risk factors, we found that females who were in the age group 20 to 23 years and females who were belonging to lower socioeconomic status who were in joint families, who were living in joint family structure, they were found to be associated with PCOS. Those females were found to have they were having significantly increased risk for PCOS. This was logistic regression analysis. It is similar to the earlier results only. So we come to conclusion. The study concluded that PCOS is a common disorder and it is very common in Delhi NCR. Our analysis provides valuable insights into the complex interplay between socio-demographic variables and PCOS status. Healthcare professionals should consider age, religion, family type, and socioeconomic status as potential risk factors when evaluating patients for PCOS. These findings have several implications for clinical practice, public health policies, and future results. Future research. The results also suggest that reproductive health, education, and counseling are needed for young women in India to prevent and manage these problems. Tailored intervention and awareness programs support system could be developed to address the specific needs of individuals based on these socio-demographic factors. Thank you so much.
Thank you, Apurva. Our next presenter is Mr. Suresh Dahal from Department of Anthropology, University of Delhi. The topic of his presentation is prevalence of depression and its biosocial determinants, an important public health concern.
Thank you. Good afternoon to all, chair, co-chair, senior professor, my respected teachers, and my colleagues. I'm Suresh Dal, PhD research scholar in the Department of Anthropology, University of Delhi. Today, I'll be talking about a very common disorder, and yeah, it is common and serious, but often very neglected. So the title of my presentation is Prevalence of Depression and its Biosocial Determinants and Important Public Health Concerns. Because of time constraint, I'll not go with the introduction. Just I'll read about my methodology. It's not moving. Okay. As we all know that depression is an important mental health condition which is characterized by persistent feeling of sadness, loss of interest or pleasure in daily activities, guilt, and even suicidal thoughts. Actually, depression, it's not, it is very different from the regular mood changes and feelings about day-to-day life. If it persists for a longer period of time, it may lead to more sedentary lifestyle, low level of motivation, and decreased energy. In turn, this may substantially impair the individual's ability to perform day-to-day responsibilities, inability to maintain interpersonal relationships, and low productivity. However, despite its growing prevalence, it often remains unidentified as people perceive it as a common problem and are unable to recognize it as a mental illness. However, non-recognition of these symptoms and the various social stigma attached to it are likely to influence health-seeking behavior, and therefore it is a major cause of premature death due to suicides and disease burden all over the world. So if we look into the slides, we can see the global prevalence of depression is around 34%, and if we see the prevalence in South Asian countries, it is almost 26%, and we can see a very high prevalence of depression among Indian population, which is 36%. So this is my methodology, and universe of my studies. Study area is Mansa district, Mansa block of Punjab, and my study population are Jat, Sikh, actually agricultural communities, and the total sample size comprises of 916 participants, out of which 403, that is 41.6%, are males, and 566, that is 58.4%, were females. I've used simple random sampling technique to collect the data, which I followed door-to-door household surveys to capture various socio-demographic and other data. Inclusion criteria is participants who were like 30 to 70 years of age and who do not have any reported mental and other physical illness, such as like cancer, tuberculosis, typhoid. And the exclusion criteria, this is the exclusion criteria, actually those who have already reported mental and other physical illness such as tuberculosis, cancers, and who are not able to give the interview, or who are not willing to to participate in the study were excluded. The objective of my study is to attempt to understand the prevalence of depression and associated socio-demographic and other variables in the present study. So these are the parameters I have captured in my data: anthropometric measurements such as height, weight, and to assess the level of depression, I have used BDI, Beck Depression Inventory, which is a very validated questionnaire used in different population. Even in India, it is already validated. So I have categorized the score. I have categorized the study population in 3 groups based on the BDI scores. 0 to 13 were considered as controls who were not having any depression. They were considered as controls in the present study. Participants who were having the BDI score 14 to 19 as case 1, that is also called a mild depression, and other 0 to 60. Sorry, this is not 0, actually it should be 20. There is some typo mistake. BDI score 0 to 63 were considered as case 2. And also I have done some biochemical, I have taken some biochemical parameters like folate, vitamin B12, triglycerides, TZ, HDL, and all. If I come to the results, this is the prevalence of depression in overall population. As we all can see that the prevalence of depression in this population is 25.3%. Well, the majority of the participants were having mild depression, that is 12.4%, and 9% is moderate depression, and 3.9% that is severe depressions. And as we can see that females were found to be more depressed as compared with their male counterparts. So this is the distribution of socio-demographic variables with different categories of depression. Okay. So this is the, actually I have this is the other anthropometric, hypertension, and biochemical parameters distribution with the different categories of depression. And I have done binary logistic regression to just understand the association of various parameters in depression, in mild, moderate, and severe depression. So in case of moderate and severe depression, after controlling for a large number of variables, the OR analysis shows that age, female sex, hypertension, participants who were having high TC, low HDL, and low folate is showing significantly increased risks for depression, moderate and severe depression. So coming to the discussion part, depression is...
Suresh, I request you to come to the conclusion.
Okay, sure. In conclusion, socio-demographic factors in terms of increasing age, low level of literacy, and female gender are at higher risks for depression in the present population. In addition to these, other biological factors such as high blood pressure, which is hypertension, abnormal lipids, and micronutrient deficiency in terms of folate deficiency caused an increased risk for depression in the studied population. Thus, the early screening of depressive symptoms, maintaining a healthy lifestyle, public awareness to overcome the stigma attached to mental health, and proper knowledge should be imparted for the management of common mental illness in this population. In addition to this, while dealing with depressive disorders, the presence of other physical comorbidities such as hypertension and elevated lipid levels to be considered equally so as to prevent the disease burden in this community. Thank you.
Thank you, Suresh. Our next presenter is Ms. Sapna Kasudhan from Department of Anthropology, Delhi University. Her presentation is on quality of life and its social determinants, a population-based study from rural Punjab, India.
Very good evening, respected chair and co-chair and teachers and who are presented here. Due to the time constraint, I would like to come directly on rationale part. There are various studies that there are numerous studies available which talk about the quality of life, which is in chronic morbid conditions and quality of life among elderly. But very few number of studies have available which talk about general population, how like socio-demographic variables affect quality of life of general population. So, to addressing this gap, the present study was conducted to explore the quality of life and associated socio-demographic risk factor among the Jat Sikh of rural Punjab. The present cross-sectional study was conducted among the Jat Sikh population of rural area of Mansa district of Punjab. Total 931 healthy individuals belonging to 18 to 76 years of age participated in this study. Random house-to-house survey method was used for data collection. Ethical clearance was approved by the Department of Ethics Committee, Department of Anthropology, University of Delhi. There was two tools were used in this study for collecting data. First for collecting socio-demographic variables, pre-tested modified interview schedules were used, and second for assessing quality of life, WHO QL brief tool was used for assessing subjective quality of life. In this present study, overall mean quality of life score was found 67.44, which indicated moderate quality of life. Significant differences in the mean quality of life score observed with respect to age group, sex, marital status, education, and employment status. And lower mean quality of life was scored in those who are elder ages. Like as age are increasing, the quality of life is getting deteriorated among the older age. And females are found to be having poor quality of life as compared to male, and widow is having poor quality of life as compared to the married one. Where in this study indicated that religion and family size is not playing any important role for deteriorating quality of life. And I would like to come directly towards the conclusion point. Like in this study, I found that most affected quality of life was found in the physical domain, followed by the psychological, social relationship, and environmental domains. And in socio-demographic variables, like elderly are reported the most poor quality of life, and illiteracy and unmarried are also reported poor quality of life. So through this study, we cannot modify the age and sex and widow status, but through the education we can improve the quality of life of this population. Thank you, all of you.
Thank you, Sapna. Our next presenter is Shruti Hiremat from Anthropological Survey of India, CRC Nagpur. Shruti?
Yes, I'm here. Good evening, one and all. Sorry if I'm not able to present my PowerPoint presentation, but I'll just read out the paper. I'm Shruti Hiremat, first of all, research scholar from Department of Anthropology, IGNOU, and also a junior fellow from Anthropological Survey of India. My topic is unplanned conception, prelude from Maharashtra. So as we know,
Sorry, I just request you to keep the presentation to 5 minutes, 3 to 5 minutes. I'm so sorry.
Yes, ma'am. I'll cover. So as we know, almost 70% of Indian population stays in rural India. So due to lack of knowledge and lack of facilities, results into unplanned conception. That results into population growth, poor family management, unsafe abortion, which is severely affects to the mental physical health of women and her family. So objective of my study is to evaluate the reason behind unplanned conception, to evaluate the awareness of contraception among women in rural Maharashtra, and to evaluate the knowledge of reproductive health and process. Also to understand women's place in families of rural Maharashtra in decision making. So I have studied in the junior district of Maharashtra with 150 couples. So basically, in my study, I found out that even after there are so many birth control programs from government, uh, all are not been able to reach to the each and every families, and also uh, families ignore it. So this is the one reason behind it. Apart from this, there are some serious issues like poor knowledge of reproduction process. As women just follow what husband says, they don't know how to control it. Then, apart from that, the fear of having side effects of the contraceptive methods, like the tablets, like the internal uterine devices or the injections, whatever are the medical facilities, they have fear of getting them. They might affect their health. Apart from that, poor facilities of local healthcare centers or primary healthcare centers or untrained workers who cannot provide these facilities in qualitative way, which affects on the women's health. And by saying that, other women doesn't follow it. Apart from it, the major problem is domestic violence or dominance, which leads to the unplanned conception. Now, effects of the unplanned conceptions are one, unsafe abortion. Those the ladies who doesn't want to conceive the child, they go for the abortion. In local areas, healthcare providers just give the pills and they follow the process. This is very unsafe and very life threatening. Apart from that, it gives the economic stress and population growth and etc. So conclusion of my study is uh, the private healthcare centers in the rural regions and the PSC centers should be trained with the reproductive health, its knowledge, its process, and how to give contraceptive methods, how to provide them in rural areas. If they get trained, they can uh, counsel the other couples, newly married couples for this, and we can avoid the unwanted pregnancies or conception in rural India. So, thank you.
Thank you so much.
Thank you for patient hearing, and then it is already pretty late. So there is no question answer. Sorry, we said that there will be question answer at the end. So because I think the valedictory has to start any time now. Thank you once again.
Sorry to interrupt, sir. Before we start with the validatory session, I would like to invite chair and co-chair to felicitate with our speakers. First, we have volunteers. Are you ready? First, we have Professor Shalina Mehta, Dr. N.M. Rabul, Dr. N.K. Mongrafi, Dr. Rupak Mukhopadhyay, Okay, now I'll request Dr. Rupak sir to felicitate our chair and co-chair. Thank you, sir. Thank you. Now we'll start with the valedictory session.
So once again, a very warm evening to all of you. So as our founder president, sir, Dr. Ashok Chauhan has already joined. So I take this privilege to thank sir for providing us this wonderful opportunity of organizing this Pre-World Anthropology Congress International Seminar in Amity University, Uttar Pradesh. His guidance, support, and motivation is the main reason why this international seminar has been a resounding success. So I would like our founder president, sir, to share his blessings and some words of wisdom.
I want to make an institution, research center for anthropology. I immediately said yes. Because India is the country in the whole world where have the highest number of diversity in the area of plant, animal, human being. And but not very many institutions are taking care of that. And I think we should work in this area, and the whole world will cooperate with us, collaborate with us. This is a wonderful area in every respect. So I congratulate and bless all those who are associated with, who have come for lectures today. You people have assembled the great worthy brains from all over the world, from NCR and from India, from IITs, Delhi universities. And I was very proud. Partly I was listening to your lectures, partly because anthropology is very close to my heart. Because this is the area, because you must have known, you must have seen, not very universities are following it. But I feel that it's a futuristic area, and Ruby Dev is working very hard. I don't know how many of you know, once she got a government job and resigned. And I gave her a farewell party and told Ruby Dev, you will come back soon. And I think 2-3 months back, she came back, and she's a good leader. And you all are working, I think, under her umbrella. So we should have a mission to work more research oriented. In the Northeast, there is a lot of diversity of plants. So I think this is an area which is no end for research. So now it is our brain, it is our ambition, it is our effort that we go deep in these anthropological areas, and the whole world would need you. We should see which are the big universities in USA, Great Britain, France, South Korea, and other renowned countries where anthropology is taking prominent place, so that we should have a collaboration with them and invite them here, and we go there because I have no knowledge at the moment where anthropology is in which universities are running well. Delhi University, we invited your former very senior professor or director in the beginning, and he gave a lot of advice to us. So I wish you further good process of the seminar, and I wish you that this benefits to everybody for their professional career, for professional progress, and for their intellectual capital. So I'm with you, so that whenever you want, I'll come to your institution, talk to you, but make a networking. I don't know in IITs how prominent is anthropology. There are 26 IITs, and I have told to Basant Sikarwar from my engineering college to make MIT IIT Synergy Network and take 10 scientist faculty members from each. So we have now a network of 260 brilliant scientists from IIT. My aim is synergy of brains. If one is working himself alone or herself alone, and if you do networking with other brains or connect, and then what important is outcome. If you work very hard, but if there is not the right outcome, then the whole exercise, whole efforts are futile. So I think with these all missions, we will really show our efforts in anthropology to all over the world, but a lot of still further efforts are required. And I think we should all try to make further efforts to achieve the goal in the area of anthropology. Thank you very much.
Thank you so much, sir, for your words of wisdom. We have grown, and I hope we will continue to grow under the umbrella of your care. Over to Rumi ma'am. She's going to speak now.
Good evening, sir. Thank you so much, sir, for joining us, and your blessings were very much required here. This would have been incomplete without your blessings. And we are here today, whatever we are here, whatever we are doing under the umbrella of anthropology, it's all because of you. I remember, sir, I won't forget that when I said, how do I start anthropology, sir? It's very challenging. It's not a very selling subject. It's very conventional. You said, like, you will teach me, I will be your student, and you have to start it. And sir, it's all your blessings, motivation, vision, and encouragement. We are here today. We are ever grateful to you. And sir, I would invite Professor P.C. Joshi, who was the former head of Department of Anthropology, Delhi University, and he was the former Vice Chancellor of Delhi University. He's with us. I would like to request him for a few words so you can have an idea how we can move forward with anthropology. Thank you so much, sir. So grateful to you because you're here. Sir.
Respected Ashok Chauhan ji, I hope you will remember you visited my department when Professor A.K. Kalla was the head.
Right. And his wife was working with me for quite some time.
Yes. So that was a time when we saw you were, of course, quite young at that time. I was also quite young. But what I saw in you was that full of enthusiasm, and you were really somebody who created this great institution. And right from the day Dr. K.N. Saraswati joined you and later on Rumi Dev, I think I have been also closely watching the progress of anthropology in MIT University, and I have been quite fortunate to have also interacted with this institute from time to time. And today, in fact, I would say that is a very historical moment for MIT University Anthropology Department, that they are now participating in the pre-World Congress. The World Congress is going to be held from 9 to 14 in Bhubaneswar, but they have so nicely organized this program, and I'm here since morning, and I'm attending all the sessions, and most of the presentations that have been made here, they are of very high quality, and I think state-of-the-art presentations have been made. And for that, I think I would like to congratulate MIT University Anthropology Department
And of course, I know how you have been the inspiring force behind them in the very beginning. And that, I think, that is now reflected in today's program, that is reflected in the kind of deliberations and discussions we have heard, not only the faculty members, but also students of MIT University Anthropology, and they are also involved in, I think, very meaningful research, very meaningful topics they have taken. And with these words, I think I'm not part of the valedictory session, but I have been given this privilege, so I would like to thank all of them, and also to you that you spared your time and blessed us. Thank you so much.
Yoshiji, when was you Vice Chancellor of DU? Which year?
I was there, I was for 1920-21. I was officiating Vice Chancellor and Pro Vice Chancellor, both. That is 2021.
No. It can't be 1920-21, no.
Yes. 2021.
Wow, वही मैंने कहा ना 2021. Now one day I will invite you to learn leadership of you. To be heading of Delhi University is like to be the President of America. Very complicated, very difficult, but any Vice Chancellor who asks for that big tenure there is something miraculous. I will learn from your leadership.
All right. Namaskar.
Namaskar.
Thank you so much, our dear Joshi sir. And sir, it's true, he's no less than the President of America because he supports us without saying no anytime we ask him for any help, any support. So, and because this United India Anthropology Forum, under the United India Anthropology Forum, today we are organizing this international seminar. It's because of sir and sir only. He called me up and he said, you have to be a part of UIAF. And I said, okay, sir, I'll do it. And then the next was the proposal, why don't you organize something in Amity University? And I said, okay, sir, I'll do it. And you were kind enough, VC ma'am was kind enough to permit us, and we are here today. Sir, I would just like Professor Saraswati, she's here and she wants to say something.
Great. I'm very happy to see her because she was very close to my heart when she was with us.
Namaskar, sir.
Yes, please.
You're not still angry with me. I left MIT because my professor, he wanted me to be there in anthropology department.
Right.
After my PDF in USA, I came to India. After 7 days or so, I went to IP University to meet Dr. Kannan.
Right.
That time I met Chauhan sir. Same time, at the same moment, he put me in his car. He brought to his office and he offered me a job. And I still remember that, and I joined him. And the MIT Institute of Biotechnology, it was biotechnology, and we were in 44 sector, I think. And he specially called me for the foundation stone of this campus. These are all fields. When I was there, these are all fields, and there was a big havan. And then I sat with sir and I performed havan also. That was a great opportunity, sir. And one more important thing I wanted to tell, sir, Chauhan sir works on instincts. He does work on, data. He works on instinct. He feels start work on it. And one evening, he arranged some senior faculties, not senior, faculties of certain departments, and he booked a resort somewhere near Noida, somewhere, and I don't remember the place. And the day was called as Day of Belongingness.
Correct.
Remember, sir?
Correct.
All were given 5-star hotel rooms, and we stayed there. We had DJ. Whole night we were there. At that time, Rumi did not join this department. Wonderful time. So these were the ways he used to keep his faculty members very happy. And I feel so nice to see this campus flourishing so well. And sir, the infrastructure you created, I tell you, from our department, if I come here, I'm feeling I'm in USA. It's so beautiful. Thank you so much, sir. It is a pleasure to be interacting with you here in this stage. Thank you so much, sir.
Your contribution was very valuable. I remember every moment spent with you, but you are looking as you were looking that time. Great, great.
Thank you, ma'am. Thank you, Founder President, sir. Now, I would like to invite for valedictory talk Professor Shalina Mehta, former Professor, Department of Anthropology, Punjab University, Chandigarh. Professor Shalina Mehta did her master's and PhD from University of Delhi and taught sociology at the Institute of Home Economics, Delhi University, before joining Punjab University, Chandigarh in 1977. She taught there for 39 years and served as professor for nearly 20 years. She has been recipient of several national and international honors and awards. Some of her achievements include Senior Fellow SSRC, Social Science Research Council, New York, under its South Asia Regional Fellowship Program, funded by Ford Foundation USA, and expert guest professor in gender studies at the University of KwaZulu-Natal, South Africa. She has more than 80 research papers published in national and international journals. She is author of 5 books and 4 edited volumes. Her publications are on ethnicity, gender, tribal studies, and medical anthropology. I would once again invite you, ma'am, please come to the dais.
Great.
Thank you so much, sir. I must, at the outset, convey my gratitude to you for bringing me to this beautiful campus that I had always seen on television. So this is my first visit to Amity, and it's just amazing. My congratulations to you for having built this wonderful institute and for establishing anthropology here as a very, very important discipline. You were curious to know, and I'm not really going to talk about what I had come to, but you were curious to know where and how anthropology is being taught. Let me share with you that there are more than 50 departments of anthropology in India today. Anthropology, in fact, we are now saying this is the century of anthropology. The challenge of climate change, the epidemics, pandemics that we are confronting, I think it is our expertise that is helping, facilitating in resolving these issues. Take any premium organization of the world, starting with WHO, starting with IMF or World Bank. Every organization is today looking for anthropologists. I've stayed and lived in Chandigarh now for about 40 odd years. There's an institution, medical college, and you were asking about IITs and IIMs and AIMS. Every institution has a place for anthropology. They've included them, I think it was almost 25 years ago that I happened to be on a selection committee at JNU for Center for Public Health and Community Medicine. And we had more than 30 applicants from LSE and others. And the chairperson of the department and the economist vice chancellor sitting over there at that time said, out of all of them, it is that anthropologist who stands out. And I'm very proud of the fact that this young woman over there is doing exceedingly well, as I see Romy doing here. I've come here for the first time. I met many of them for the first time. But let me assure you, sir, to the extent that the Postgraduate Institute of in Chandigarh today says that whenever we want to have research associates or research assistants for any project in public health, we want to hire anthropologists and only anthropologists. It's their field training. It's their ability to make things work that stands out. And in that sense of the term, I think it's a golden opportunity for you to expand this institution. You were talking about international universities. Go to Harvard, go to MIT. They're all flushed with anthropologists. I've spent years teaching at Clear Lake University in the United States, which is an environmental institute. So almost all environmental institutes need anthropologists. So you need to specialize, you need to develop this area because all the positions that would be coming and all the networking there that's going to happen is actually now, we say it is the era of Anthropocene. So anthropological knowledge and understanding is going to be the premise on which the world is actually going to sustain itself. Because the knowledge that we get, you see the focus on the indigenous knowledge systems. Who's going to bring it to the table? It is the anthropologists who are going to do it. They're the ones who've been working in these Adivasi communities. They're the ones who have that traditional knowledge with them that can be brought to the fore. So please include these areas of research. Help, Romy has done an amazing job. She's managed to get so much funding for this conference. And United Indian Anthropology Forum is a platform that wants to encourage young researchers, young scholars to come forward and share their knowledge with the world concerned. I see so much potential. The institute where we're going to organize the World Congress, I'm sure you've heard about it. He's another person who dreams like you. The Kalinga Institute of Social Sciences, Technology, they are the partners for us for organizing this conference. And they've dreamt like that. When I look at people like you, I look at him, I always think of a couplet which says, अकेले चले थे जानिबे मंजिल, रास्ते में लोग मिल गए और कारवां बनता गया. तो आपने कारवां बनाया है. Seeing your campus today, I can say with some kind of a certainty and assurance that you not only exist on television screens, but in reality, you dreamt and you built it up. And in that dream, I think anthropology must hold a very, very special place. It is science, it is social science, it is humanity, it is psychology. Put everything together. I'm just going to read that out for you for a moment. I looked at your institution and I read your motto, and I'm just reading that out. Right. Build the nation and the society through providing total, integrated, and transcultural quality education. The words itself are so powerful, so profound. The global front runner and nurturing talent with modernity and tradition, sir. And that modernity and tradition, is the essence for any kind of future. So what I tried doing was, sir, that I looked for some definitions of anthropology. And I found this on the website of University of Florida, which sort of converges with what you've been wanting to do. It says, anthropology is the study of humankind, of accomplishments. That's what, when I see these people who are here, Ritwik, Romy, all those who made the presentations today, I think it is all accomplishments that they have achieved. And they examine aspects of human existence, and only anthropology explores the entire panorama of the human experience. You are a citadel of human experience yourself. Your journey from where you started and where you've come today in itself is exemplary. And I'm sure all of them who are sitting here are learning from it. It's from, we as a discipline, we talk about human origins, we talk about contemporary societies and all the issues and problems that occur here. So, sir, standing here with you there, I seek your blessings for the institution, for the fraternity of anthropologists who are going to come and work with you and to build a great institution where you are not only known for management studies, but you're also known for exceptional skill building in anthropology. Thank you so much, and thank you, Romy, for inviting me.
Professor Shalina ji, are you living in Chandigarh or, are you living in Chandigarh or somewhere else?
I am, as Salman Rushdie said, midnight child of Delhi. I was born in Delhi, brought up, educated, and I do live in Delhi most of the time now.
Because, my university in Mohali, which is developing very well under the guidance of Mr. Atul Chauhan, who is the president of the whole foundation, is personally interested to develop. And Punjab is very clear to me because I born in Jalandhar. तुझे पंजाबी बोल दो?
हाँ जी, बिल्कुल बोलनी है सर.
Rumi Dev se कहूँगा she should make a consultative committee in the anthropology and invite you as a worthy member of that committee. And I am very eager and very inspired to develop it further. But people do not have that knowledge of its importance, which you rightly depicted. So I think we all together tell to the whole country, and not only all other Asian countries, other countries, that anthropology, come and study with us. So I will take your advice, and Rumi Dev will follow with you. And next time, when I'm the campus at one more time, I'll call you, and you tell us the ways and means how we develop faster. Thank you.
Anytime.
Great.
Thank you so much. Thank you.
So kind of you.
So thank you so much, ma'am, for your talk. So now I would like to welcome for his concluding remarks, Professor S. Gregory, former Dean, Faculty of Social Sciences, former Chairperson, Department of Anthropology, Kannur University, India. Professor S. Gregory did his MA and MPhil from Pune and Madras universities respectively, and PhD at ISEC, Bengaluru, under IDS, Mysore University. He retired as Director, School of Distance Education, with additional charge as Director, HRDC, Kannur University. He has visited several US universities, including George Washington University, California State University, Los Angeles, Boston University, Rutgers University, and University of South Florida, and delivered lectures. Professor Gregory had organized a panel discussion at the 17th World Congress of IUAES at University of Manchester in 2013. He had organized several seminars, conferences, workshops, and panel discussions, including the 10th INCAA Anthropology Congress 2013. He has more than 60 publications, including 5 books. His main areas of interest include sustainable development, participatory research, and decentralized planning. I invite Professor S. Gregory on the dais to address.
Very good evening to one and all. I'm extremely happy to see this wonderful pre-Congress international conference at Amity University. As Dr. Ashok Chauhan is here, the founder, I think he's so curious to know about the potentiality of anthropology. And I think he is already familiar with that. My only grief is that anthropology is so rich with knowledge, but we are making use of it very minimally. We need to explore a lot. In fact, I heard, discussed in some of my papers that, say, anthropology has been included in different universities under different faculties. If you see in Delhi University, it is under the Faculty of Science. In Pune University, it is under the Faculty of Humanities. In Kannur University, it is under the Faculty of Social Sciences. And I had put forth that anthropology should be having its own faculty of anthropological sciences, which would include a large number of branches as specializations. So it has to develop, and we are just confining at the PG level. I have taken a lot of efforts to bring anthropology at the school level, and we are teaching in Kerala anthropology at the school level, at the higher secondary level as a subject. And if we move into that direction, I think anthropology's potentiality has to be largely realized, and we are yet to realize it. As Shalina madam was telling, that we are teaching anthropology only in 50 universities, but it should not be there. And there are many people who are still asking, what is anthropology? It's very sad to say that. I mean, I have been talking about anthropology as a people science. We know that. I think there is no other subject which can be, labeled as people science, because we are so proximal to the people. And still, people are asking, what is anthropology? And that is the gap we have between anthropology and people. So I think this is just to say a few words about anthropology. But if you look at the history of anthropology, at many points of time, people have been talking about the crisis in anthropology. At some point of time, people have been talking about the death of anthropology. But at every time when they talked about this, it had risen above and had become with very strong existence. And we have also been facing, even in India, at many times, this crisis. But every crisis always comes out with a stronger identity. And that is where we are moving towards. And I should say that Professor Raumi has touched upon United Indian Anthropology Forum, which came into existence just 2 years back. If you look at the website of the United Indian Anthropology Forum, it has now, within 2 years, it has more than 75,000 viewers. Thanks to Shalina madam and others who have contributed to the very lively website we have. And this United Indian Anthropology Forum was started virtually, and we call it as a virtual discourse forum, where we give importance to all the people. We have young anthropologist forum, budding anthropologist forum, senior anthropologist forum, veteran anthropologist forum. I don't think at any point of time in Indian anthropology, all these anthropologists have been brought together, and we are familiar with now one another, though virtually. I think this is the first time we are just coming together in the offline mode. And the coming World Anthropology Congress is going to make us the greatest gathering in India. I mean, after 1978, 45 years before, where we had this World Anthropology Congress. And after that, this is the Congress which we are going to have. And I should give some idea about the World Anthropology Congress. As you know, we had the pre-Congress at Delhi in the month of January, right? And after that, we had pre-Congress at Harisinggaon University, and last week we had one at Pune University, and this is the fourth pre-Congress we have, and we are going to have another in Punjab University. And all these pre-Congresses are just preparations for the World Anthropology Congress that we are going to have at Bhubaneswar in Kalinga Institute of Social Sciences, deemed to be university. And if you look at the topics that had been the theme of these pre-congresses, that would talk about what anthropology really stands for, the variety of topics. And even if you take the World Anthropology Congress and the entries, it's not just confined to the anthropologists. Practically every discipline is going to be represented in that Congress. And that speaks how anthropology is a coordinating science. Anthropology, in fact, we say that is anthropology a science? Is anthropology a humanities? I mean, it has all identities, and that is where we should say that it is having its own identity. And that's why I am putting this idea of faculty of social sciences, where it can have its own identity. And we are going to have post-congresses in many places. In Calcutta University and Vidyasagar University, we are going to have a post-congress. In Lucknow University, we are going to have a post-congress. And we are going to have a post-congress in Cotton University, Northeast. And we are going to have, most likely, because we are supposed to have a pre-congress at Manipur. We know the situation there. That's why it's probably we'll have a post-congress in Manipur and also in Mysore University. So this World Anthropology Congress really talks about its identity and credibility, how it represents all walks of life and across country, across states. And that is where we come together. And I would say that this United Indian Anthropology Forum, the last 2 years, we had conducted more than 100 online webinars, young anthropology webinar series, gender dialogue series, and addressing about the vision of anthropology and new researchers. And we have also this forum, if you take the constitution of the governing council, you would see that we have 5 zones, divided into 5 zones, and each zone has got its own president and secretary, and we have different standing committees. But these are our visions. I can say now that we have not moved, I mean, even an inch what we have targeted at. And I invite all the anthropologists. See, it is not always when we have an association and it's an organization. We expect that the organization will take care of itself. It cannot take care of itself unless the members become active and proactive. So that's what the expectation of the United Indian Anthropology Forum is. Every anthropologist should contribute so that we will achieve something different. I am sure that there needs to be a paradigm shift. We are moving towards that, and everyone should contribute their might. For example, we have 16 core research domains in United Indian Anthropology Forum. Each domain focuses on different areas of research interest. And the idea of these forums is to bring together all those people who work in a particular area in one single forum, so that they will interact with each other. And they hail from different parts of India, and they have conducted researches in different parts of India. But what is the commonalities? What are the similarities? How we have to go beyond our research? How we can translate these researches into action in policy implications? I think if each core research domain takes it seriously and addresses this problem and bring out all the publications that are related to these each research domains, I think we will do wonders for this anthropology in India. We are being in a crucial time, this 2023, if you take, we have just completed our 75 years of independence. We are moving towards 75 years of our republic. We have just completed 150 years of Gandhi's birth anniversary. We have just completed 100 years of PG teaching in anthropology. So all these bring together the importance of 2023, and we are going to be going to make history in Indian anthropology. I'm sure you are all part of this history, and we are going to make the Indian anthropology and give a new direction to Indian anthropology. And that is what the message I want to give at this juncture. And I should appreciate Professor Dev for taking this initiative to organize this wonderful pre-congress in Noida, in Amity University. I am sure our founder, he has a lot of vision, and I am sure that under his foundership and direction, this department will become a premier institute in India for anthropology. And we are also targeting at the Department of Anthropology at Kalinga Institute of Social Sciences to make it a premier institute, to model it to an institute where it can be emulated by other people. We should work towards this, and I am sure that, I should also say that I think Salina Madam was pointing out, see, in other universities in other countries, when you go, like US, you will see anthropologists in every department. It's not confined to anthropology departments alone. Anthropologists are there in music department, in international relations, in gender studies, practically in management studies, everywhere, because anthropological expert is required in every field. And that shows the comprehensive understanding of anthropology. I don't want to take more time. I can go on talking about anthropology, but then the time is very short. Thank you very much for giving me this opportunity to come over here. And this institute is very beautiful. I can say I have visited several universities in US, and I don't see any difference between those universities and this Amity University. I am sure that these are the universities that are going to give a lead for anthropological knowledge and anthropological applications in India. Thank you very much once again. And I welcome you all to the World Anthropology Congress that is going to be held in Kalinga Institute of Social Sciences, Bhubaneswar. Thank you very much.
Professor Gregory, every word, Professor Gregory, Professor Gregory, every word was going deep in the bones and mind, body, and soul. And after hearing you and Shalina Madam, if everybody will not make a promise that we will do our best in the area of anthropology, and I have just called from a meeting our worthy Vice Chancellor, who is 23 years with me, one of the best Vice Chancellors in the country, that she should see that at this late hour, so many people are sitting with interest because she's holding hundreds of conferences, seminars here, but the time she has given to Rumi Dev to plan it from the very 0 hour. So I thought she should see her. I compliment your wisdom, and because the time you have given to Rumi Dev, I read everything. 5 government organizations have funded her, even a small amount, to promote this. Even somebody give 50,000 1 lakh, I don't mind, but they recognize the value of the Congress or this pre-Congress seminar here. That is very much because of the contribution of Dr. Shukla. Dr. Shukla, I must compliment you. I did not think that it will take so much importance. Shailna Madam from the Punjab University is here. We will take him in consultative committee. Gregory Saab ko we will take him in the consultative committee because, we will boost further. As he rightly told, people do not know the real value of anthropology. And I will also make a network of these 50 institutions in the country. Rumi, they will give me, and immediately will start because I work with networking, with synergy of brains, with connect. So, Dr. Shukla, 2 words from you, my compliment and my appreciation.
Thank you very much. I'm sure that we are going to have a very great change in Indian anthropology with these words. Thank you.
Thank you.
Yeah, thank you very much, Honorable Founder President. It's really a great moment that Amity University is hosting the pre-conference international seminar of the anthropology, and the Congress, the Anthropology Congress is going to be hosted by the Kalinga Institute of Social Sciences, and I'm extremely thankful to all the distinguished speakers, the president, everybody who have come to the Amity campus. And this morning I've been hearing that wonderful deliberations are going on. And Honorable Founder President, as you have given the mandate, every conference event happening, there must be outcome. And in the morning when I was addressing, I said, I'm sure that there will be outcome which will not only be the learning, but will be the networking, collaborations, and the future. So that's what the vision is, Honorable Founder President, of yours. And I'm sure that all the researchers, scientists, academicians who are sitting in this hall and who will be again gathering at the Congress, I think that there will be a lot of outcomes will be coming, or the joint research collaborations, and really contributing. Because anthropology is one field, it spreads across all the domain and disciplines. And because social sciences is the area which contributes immensely in all the disciplines, even if it's engineering or the health sciences. And I'm sure this conference is going to set a new milestones to achieve for everybody. Thank you very much, Honorable Founder President, sir.
Dr. Shukla, please invite Dr. Gregory and also Shalina, who are in the Punjab University. Really very motivating words. And I think Rumidev, let's give a big clap for supporting and giving all wisdom for this conference to my Vice Chancellor. Let's clap for welcome Dr. Shukla. I think we should support. I have known better now, hearing these lectures, how important it is. But I think we should take a big initiative. People do not know the importance. That I think we should take initiative with all the speakers. Professor Halina, we will take in the advisory board, and also for Gregory, so that there is a dynamism there, and because they are all obsessed from anthropology like me, and I think we together can move the mountains in this area. Thank you, Dr. Shukla, for running here again after the lecture in the morning. Good. Dr. Rumidev, now you go ahead. I appreciate all sitting and patiently hearing it. I appreciate everybody.
Thank you so much, Honorable Founder President, sir, Honorable Vice Chancellor, ma'am, for predicting the bright future of anthropology in Amity University, and also to Gregory, sir, for pushing the envelope for anthropology. Now, I would like to welcome a guest from ICSR, who is one of our sponsors. So I would like to welcome Dr. G.S. Son, who is presently working with Indian Council of Social Sciences Research, ICSR NRC, as senior research consultant, and is also holding the charge of honorary director of ICSR NRC, JNU New Delhi. He did his PhD in psychology from Kumaon University, Nainital. Dr. Son started his career as a lecturer in a degree college in Uttarakhand. Later, he worked with NCERT and Education Consultation India Limited, New Delhi, in various capacities before joining ICSSR, New Delhi. He holds more than 30 years experience in the field of training and research in social sciences and educational administration. He has held the post of member secretary ICSSR from 2015 to 16. Sir has published a large number of research papers, articles, and research journals and books. He has been the managing editor of Vichar Vaibhav and CSIR International Journal. Dr. Son has also worked as member of ICSR review committees on various research institutes and also represented India in the UNESCO General Assembly for Social Science Research in 2015. Please, sir, come to the dais and address the gathering.
Good evening, everybody. First of all, I apologize for my late arrival here, owing to some traffic problem. But I'm glad that I could finally make it, and I'm among you. Well, first of all, I should pay my honor, my respect to founder president of MIT, Dr. Ashok Chauhan, Vice Chancellor, who are online, Professor B.C. Joshi, Shalina Mehtaji, and other senior academicians. Of course, the organizer, Dr. Romi Dev, for making it possible for me to be among you this evening. And of course, I am equally glad that some of the students are also here. Well, friends, I think during the whole day's deliberation, you would have been enriched by a lot of experience of the senior faculties, various speakers, and the papers presented during the conference and seminar sessions. I'm not a student of anthropology. My core discipline has been psychology. But being in ICSSR, you know, ICSSR deals with all social sciences. So little bit exposure to the discipline like anthropology also I have. Initially, if I look at this title of the seminar, you know, Anthropology, Health and Disease, Eliminating Disparities. I saw this topic at least 3 months before it is here, because Dr. Romi Dev had moved a proposal to ICSSR, Northern Regional Center, for some financial assistance. And I had opportunity to look at it. Well, I really found that by going the topic, though we don't deal much in anthropology, I must admit Professor Joshi is here, but social anthropology more we are dealing in ICSSR, not with the physical part. But by looking at the topic, I found, yes, this is worth, and this is where I think, if possible, we should support it. And it was processed, and finally, yeah, we were able to give some assistance for this proposal. I am very happy for that. And second issue was coming, whether I will be able to make it or not. It is the persuasion of Dr. Dev that I was keen, but in the morning I had some engagement. That's why I could not make it. But it's my pleasure to be among with you. Well, that I have said, I am not a student of anthropology, but when I looked at the topic of health, I just want to attract your attention to the Sustainable Development Goals, which were set by UNESCO in 2015. 17 goals were set. And one of the important goals at number 3 is the health and well-being. So I take you from that goal, which has been set as the Sustainable Development Goal by the UNESCO, the international body. And it has been put at serial number 3 by going the importance of the issue like health. Health is such an issue before us, which is to be looked and taken care by different people, sort of disciplines, people coming from different disciplines, people coming from different expertise and all that. But yes, anthropology also has its share on it. How a discipline like anthropology could help to the, normally people know health means all PhD, MBBS and all these people, medical field and all these are there. But when you look at the, as a student of anthropology, little bit whatever exposure I could get, is that the study of health, which anthropologists do, is equally important in understanding the disease pattern, in understanding these problems in different societies, different communities of the world. I think the anthropological view of health is very important. And if these views are taken together, coordinated together with the medical approach and with the other social science approaches, I think that we can make a holistic approach towards the burning issue like health. Even today, if we look at the country like India, even if we have a good, I should not say very robust public sector health infrastructure, but despite that, I find everybody spends a lot in health, even poor or rich. Why? We have, of course, government system, but why more and more people are going to the private sectors? Why it is like that? What are the reasons behind this? Is it the attitude of the people? Or it is the real problem of availability of facilities in the public sector? Or it is something else that we have to see? At the very beginning, I just wanted to give you a very small example. We have our Aya at home who comes for our cleaning utensils and other things. Of course, you can imagine the monthly income she may have. So day before she was telling that her son fell ill. She complained to told my wife, she was telling. Then she says, no, I had to take him to the hospital. And I told she would have taken to government hospital, which is nearby, I know. No, she took it to the nursing home, where she had to pay a heavy amount for admitting him there. Then I was thinking the issue, why it is so? Even if you don't have resources, you are financially tight on that. You cannot afford the treatment in the private hospitals. You know how much we have to pay in the private medical system. Even the minimum nowadays, a doctor's fee is ranging from 700, 1,000 to 2,000 consultation fee. Even if a person like that is tending towards going to the private nursing home, then what is the reason behind it? Whether it is the mental set or whether the fault lies in our public health system or what else is there. I think these are the issues which need to be paid attention, which need to be researched over there. How we can help the people to educate, how we can make the people know that, no, this is where the problem lies. This is not that people have mental set, oh, government hospital means there is no facility, nothing will happen over there, though no care is over there. And it so happens, even if you find that there are some good hospitals, it is not the case that every government hospital or the public sector hospital is not good. But the perception is like that. In order to change this perception, then who has to play the role? It is we, social scientists, the researchers, people working at the grassroots level, public health workers. I think that sort of movement is required wherein we could contribute something to the health system and to change I think, our attitude towards the health facilities, at least whatever are available with us right now. Coming to the second part, I should say, again, if we go by the Sustainable Development Goals, if we see globally, what is the scenario? There are so contradictory, data which speak about the health prevailing in various countries in the world or prevailing in the various part of the world. Simple example, I am telling you about the availability of doctor per 1,000 population. If you go to the African countries, Saharan African countries, this data shows, I am quoting the data from Global Development, Sustainable Development Report, which came in 2019. Because as you know, for Sustainable Development Goals, the provision has been made that after every 4 years, there will be a midterm report, assessment report, which will speak about the progress in achieving the Sustainable Development Goals. So next report is due, I think, in September next month, 2023. But this is the report which speak 2019 report, which says in Saharan African countries, the availability of doctor per 1,000 of population is 2.9. And if you look at the data for European countries, it is 39.3 or 6, something like that. So now you can imagine the people who are getting this much of facility because they have resources. But the people in those countries which are supposed to be backward still, who don't have much resources over there, rather they need more attention from the doctors by growing the social and financial structure over there. So these sort of disparities are still over there. And how this gap could be, filled, in what way we could do, this is what I think we have to work on. This is where we have to proceed further. Similar is the case of maternal mortality. Similar is the case of, vaccination of children, which is taking place in the countries where you need more vaccination. The children don't get even the basic, which are the essential vaccinations. They are deprived of that. So these are the disparities and the contradictions we see worldwide. So I think those things need to have more attention from the social scientists, from the researchers like us, and you people have the challenge. Of course, I found from my previous speaker that he was bringing attention about the, less presence of anthropology in the universities and departments. Yes, that is what, if I look at overview of the country as a whole, being in ICSSR, yes, sir, this is fact, because for the disciplines to grow, there are many factors which are working in the universities. If you look at the management science, which have taken birth much, much later than what you say, anthropology and other disciplines, how it has spread so quickly everywhere. Any part of the country or any part of the world, you say. But the core disciplines like anthropology, and even I must say about my own discipline, psychology, has not got that much of attention and that much of spread and that much of place in many universities or the good colleges there. Well, those are the factors. Some might we find the salability, and some might we find all these factors are there, sustainability, and all these are the issues. But if we see that at the level of policymakers, I think some which can be only in the, I think, public sectors. In the private, of course, I must thank Dr. Ashok Chauhan that in the private sector, in the MET University, the anthropology department has been started, and it is doing all these such good academic, work activities. But in the private sector, I must say, that is what you also accept, that more salability is the factor wherein such disciplines grow and such disciplines sustain over there. Well, there are centers like where Professor Joshi is from Delhi University or some other university, you say, wherein subjects have been there, their growth have been there, but where the question of spread and is there, it is the question, it is the challenge. I think the UGC, the body like UGC and the policymakers have to pay attention towards that if we really want to have some balance. And then the question comes, nowadays you find that I have seen in many universities, why you are not opting for this particular subject, whether anthropology, whether psychology and others. The curt answer from the student is that, sir, after that there is no scope. Only if you want to go in teaching, and even if you want to go for teaching, very limited places, you will find the vacancies are there. And in the lower classes, I told why you are not opting for, in the graduation, you are not opting for psychology and others. There also, this is, if we go for B.Ed, the combination is not like that. If we take the combination, then psychology is not there. Anthropology is not there. So that's why these subjects are deprived over there. But that deprivation needs to be addressed too by the academicians, policymakers, and others. Well, third thing, I don't want to take much time from you. Already we are very late. Coming from ICSSR, I just wanted to bring to your knowledge that we have been trying to promote. Yes, we have been trying to promote social science. And there are so many opportunities and programs that we have been giving. I think you all senior academicians as well as budding academicians and students can log in. We have various programs, and among those recent program we have advertised, the short-term empirical studies are there. But in this context, I must say ICSR have been a special concern, particularly for the tribal studies, which is core to the anthropology. And only a week back, we have announced the result of some projects, wherein 162 projects we have approved for the tribal studies. So that itself is the indicator of our concern for the studies of such people of our society who are deprived, wherein we need to do something, and if we get something out of those studies, we could perhaps contribute towards the policy making. And even prior to that, in earlier also, you would have seen for tribal studies, we have studied on the phases. B.K. Roy Burman conducted a series of studies earlier, which was again sponsored by ICSSR. And those studies also, if you look at it, is I think early 2000, those volumes have been there, which again ICSR published. So those are very important volumes for the people who are interested in anthropological studies and the tribal studies. So that is what from ICSSR we have been contributing towards the cause, and also we look forward to contribute more to the disciplines wherein they need more assistance, they need more training. Why don't you hold more and more training programs, research methodology programs? I have seen very less proposal coming from the anthropology department for research methodology programs. Most of the programs I have seen coming from either economics, either political science, or sociology, so and so forth. But anthropology, very, very few proposal I have seen, whether it is research methodology, whether it is capacity building programs, which are open for the scholars from ICSSR. So I think you as a anthropologist and working in the field can make use of all these things to fill the gap, what you find in the subject, and those steps I see will definitely contribute to the overall growth of the subject. And then, of course, the contribution that you will be making to the overall growth of the social science in this country. With this, I stop. Thank you very much.
I think your keys are have fallen. So, as we drew curtains on this international seminar, I would like to call upon Professor Rumi Deb to honor and felicitate Professor Shalina Mehta. And now I call upon Professor S. Gregory to be felicitated by Professor Rumi Deb. In this series, now I call upon Professor G.S. Son from ICSR to be felicitated by Professor Rumi Deb. Now I call upon co-equal and dear friend of Professor Rumi Deb, Professor K.N. Saraswati. Now, to honor and acknowledge invited speakers who have traveled from abroad, I would like to welcome Dr. Kaustav Dalal to be felicitated by Professor Rumi ma'am. Now I call Dr. Rabiul Awal Chaudhry, who has traveled from Bangladesh, to be felicitated by Professor Rumi Deb. And last but not the least, I would like to call Dr. Anup Adhikari to be felicitated by Professor Rumi Deb. Thank you, everybody, for making this event exhilarating success. Now, I would call upon Professor Rumi Dev for a vote of thanks.
Good evening, everyone. So, I don't want to stand here for a formal vote of thanks because it's a formality. But today I'll speak from my heart. I would really like to tell you that how grateful and thankful I am to each one here who had come here and made our day. We are extremely grateful to our Honorable Founder President, Sir, Honorable Chancellor, Sir, and Honorable Vice Chancellor, Madam, and entire fraternity of Amity University for actually providing us with a platform to organize this wonderful event. I'm actually getting a little feeling bad that such a preparation it was going on. We were actually like it's as if it's a wedding, you know. We were preparing and we were organizing things. We were talking to each other. We stayed late in the evening and we were interacting. And my colleagues, all my colleagues in my department, my support staff, my students, were simply amazing and they were contributing without any saying a single word. At times, I was also like, because of the pressure, you can understand, like, I was going a little rough with them, but then they were very cordial, very nice, and they contributed without talking a single word. I'm thankful to all my dear faculty members, my colleagues, my students who have contributed. Now I would like to say we are here because of UIAF and United India Anthropology Forum. Joshi sir, I remember when the proposal for UIAF comes from Dr. Saraswati that Rumi join the UIAF. I said I had to think because there was something else which was happening and I was getting into that and I got into that and then I had to think okay because I want after all, like I want to be in amongst the anthropologists of India. I wanted anthropology to shine, and I want anthropology to be so bright that one day we should be on top of others. Because often, even I got to hear when we started anthropology department in Amity University, what is anthropology? Is the study of anther a part of the plant? Is it insect? Something like that. But then justifying from that point, and today we are here when many of our students are studying anthropology with their own choice. They are coming to us, they want to learn anthropology, and many are going beyond that when they want to understand much beyond the subject. And we are getting students from all fields, not only anthropology, we get from biotechnology, psychology, sociology, forensic science, who after doing their graduation in anthropology are joining this particular doing in various fields. They're coming to anthropology. So I am very grateful to our management, our founder sir, for giving me this platform to start this university's program in anthropology. So I want to express my deepest appreciation for all the distinguished scientists, members of UIAF, invited speakers, esteemed presenters. Your profound insights and groundbreaking research have been truly inspiring. I could not hear all the talks because I was doing a little bit of running around, but undoubtedly, I think this was a very enriched discussion. There was a lot of enriched discussion. Whenever I sat and I listened, I found it very informative, and I'm sure we will move forward and we will do something, some collaboration in some aspects. So we are honored to have and had the privilege to learn from the expertise and passions from all of you and those who have traveled all the way from all other countries. I'm thankful to Dr. Kostub Dalal who has come from Sweden, and he said I will come and attend because he was in Kolkata. Dr. Raibul, thank you so much for coming from Bangladesh, and Professor Joshi, Professor Gregory, Professor all the other Sanjay Juvekar and everybody who came here and who participated and who made this event successful. Our Nita Mawar ma'am, Shalina Mehta ma'am. Ma'am, so thankful to you. I followed up with Shalina Mehta ma'am a lot. I said, ma'am, you must come, you must come. So this is how we did. And Nita Mawar ma'am, thank you for accepting our invitation. I'm so thankful to all the chairs and co-chairs, and I invited all my faculty, one of my faculty member, Dr. Kalindi Sharma, who is placed in a very prestigious position in IBHAS and who was with us, and she at once agreed to be the chair of one of the session, co-chair one of the sessions. Thank you, Kalindi, for always, whenever I tell her, whenever I speak to her, I get such a positive response. So I feel like talking to her, and thank you so much for coming. Dr. Anup Adhikari, sir, I'm so thankful to you for you being here. I extend my sincere gratitude to Professor G.S. Son, sir. Sir, I'm so thankful to you for supporting us in all ways and coming here and making our day. So I'm very, very grateful to you. I extend my greatest and deepest gratitude to our event sponsors. We got the sponsorship from DST Serb, ICSSR, NRC, and sir is here. So grateful to have you, sir. Then CSIR, DRDO, and Anthropological Survey of India, whose funding came just day before yesterday, but we are so privileged. So I consider that we all are very privileged at Amity University to get so much support from various funding agencies. I should not forget the private funders. We have 4 private fundings from different private partners, and this is, I should name them. It's Bell Cooling Towers, it is Aran Industries, it is Strip and Metal, and I think it is Posh Dynotech, right? So all these 4 partners we had for the private funding. So we had a lot, like they believed in us, they believed in our ethics, they believed in us. So that is which gives us a lot of pleasure. And I promise that we all together, we will do much more to bring anthropology in the forefront from Amity University on behalf of UIAF. I'm saying that we all will support you also, and we will contribute to the field of anthropology. I would like to extend my sincere thanks to the advisor ASCO for the photography and video coverage for the seminar, DG Hostel Administration for the arrangements, for the VP Media for the photo and media coverage to the event, Senior Director Administration for all necessary arrangements and hospitality, to Senior VP IT for fully functional audio and video projection system, cordless mics, and availability of duty persons at the venues, to the Director Security for the smooth entry exit of the guests, and every person who have directly or indirectly supported us in the success of the event. Behind the scene, once again, I should not forget my own team of the dedicated individuals who worked tirelessly to ensure the seamless execution of this seminar, to organize the committee, to organizing committee, volunteering staff and students. Thank you for your commitment, but I should name each one of you here. I thank Professor Dr. Rupak Mukhopadhyay, Dr. N.K. Mungarafi, who looked after arranging the, you can say, the abstract book, which went for printing only yesterday evening. Thank you so much, Dr. Mungarafi. Thank you so much, Dr. Rupak, for right from the beginning, he has been arranging the thing, the speakers list, and she budgeting and everything he contributed. And Dr. Tarun, who is my own dear student, God bless you. I don't have words to say how he contributed, and the amount of contribution, ma'am, I could not everyone, I should say that Tarun is an asset to us. And my dear students, I should call each one of you. And Naveen, khade ho jao. Naveen ke liye ek jordar taaliya. The support system of our Center for Anthropology, Naveen. Without you, this would not have happened. My dear students, Alok, who is running around for the bringing and pick up and drop and anything, anytime. Today morning, I called him and I said, pick up the abstract books. And without saying no, he turned his car and he went and got the abstract book. Thank you, Alok. Nikhil, poster making, whatever we said, like he came and he did everything. So your contribution is immense. My dear PhD scholars, the beautiful ladies of Amity Center for Anthropology can come forward, Ms. Akanksha Dubey, Ms. Prabhu Ms. Pratima, and all the undergraduate students and the post-graduation students. You have made this event successful. It is not my event or anybody's event. It is your event, and you have made it successful. Thank you, each one of you, for your contribution for this success. I owe everything to my students and to my colleagues of this institute, my management, my founder president, sir, Vice Chancellor, Madam, Chancellor, sir, who were supporting tirelessly without saying anything. Thank you, everyone. Thank you, United India Anthropology Forum, for supporting us, for giving us this opportunity, for giving us this platform to excel in anthropology. Thank you so